నందకిషోర్ వచ్చుంటారు, అది కూడా అలో చేయండి. రాహుల్, ఏమి వెళ్ళిపోయావు మళ్ళా? సిఆర్ సార్కి చెప్పాలా శ్యామ్, అన్మ్యూట్ చేసుకోమని? ఇంకా స్ట్రీమ్ చేయలేదు కదా మీరు?
స్ట్రీమ్ చేశాను సార్, ఇప్పుడే స్టార్ట్ అవుతుంది సార్, 30 సెకండ్స్లో. సార్ ఉన్నారు సార్ ఆల్రెడీ, శ్రీహరి సార్. సార్ స్క్రీన్ షేర్ నడుస్తుంది, అన్మ్యూట్ చేయమని చెప్పాలి సార్.
దాన్ని మొత్తం ఉండరా?
ఆఫ్ చేసి చాలా. హలో,
ఉండండి సార్, ఏం కాదు. రావు సార్ ఉండొచ్చు.
మనం
లైవ్ ఉన్నాం సార్, లైవ్ సార్.
ఓకే, కొట్టగొట్టుకుంటా. ఓకే కొట్టగొట్టు. అది వస్తే దీన్ని ఆఫ్ చేసి అలా రీస్టార్ట్ చేస్తాం సార్.
శ్రీహరి సార్, వీఆర్ లైవ్ సార్.
నాకు రాహుల్ బాబు కనపడటం లేదు, ఎందువల్ల?
సార్ది కెమెరా ఆఫ్ ఉంది సార్.
రాహుల్ బాబు ఆపరేషన్. రాహుల్ రాహుల్ అమర్, డిడ్ యు జాయిన్?
హలో,
జాయిన్ అయ్యి ఉన్నావు కదా? ఎందువల్ల మీరు కనబడుతుంది?
Sir, very good morning, sir. We are all live, sir. We can start the proceedings, sir. Introduction.
నాకు శ్యామ్ గారు లైవ్ స్క్రీన్ కనబడటం లేదు నాకు.
సార్, ఇప్పుడు సార్ది స్క్రీన్ షేర్ మీకు కనిపిస్తుంది కదా సార్? సార్ చేశారు. శ్రీహరి సార్ది స్క్రీన్ కనిపిస్తుంది కదా సార్ మీకు?
కనపడటం లేదు, అందువల్ల.
మా అందరికి కనిపిస్తుంది.
ఇంకో ల్యాప్టాప్ ఓపెన్ చేయమన్నాను, ఇది ఏందో తెచ్చు. ఇప్పుడు కనపడుతున్నారు శ్రీహరి సార్.
శ్రీహరి సార్ వచ్చారు.
సార్ నేను ముందర మాట్లాడతాను. Good morning to all the, good morning to sir, the chairman of the AP Medical Council. We welcome all the delegates. Now the president and secretary are also available here. Basically, sir, we have registered 418 already. Before 9 o'clock, 270 have already come on the line. Now I request the president to give his remarks and secretary also. Next, after which Dr. Srihari Rao Garu, the chairman of the AP Medical Council, who is a dynamic personality and known for his honesty, integrity, and a dedicated person of IMA. Not only for IMA, he is dedicated to APMC. He has shifted his residence to Vijayawada also. There is nothing words to say about him. He's a dynamic personality and a national leader in IMA, and we wish him future as the national president from Andhra Pradesh also. Next chance of Andhra Pradesh should go to him. That is the wish of the IMA Nellore branch, sir. And now I request Dr. Amarendra Reddy, President IMA Nellore, to give his opening remarks and Secretary's report. Thank you.
Good morning, everybody. I welcome you all to this CME program, which is being conducted by IMA Nellore. Firstly, I would like to congratulate Dr. Srihari Garu for taking over charge as AP Medical Council Chairman.
సార్ సార్ మీరు మీ ఫోన్ టిల్ట్ అయిపోయింది సార్, మళ్ళీ ఇలా చేసి చేయండి సార్ ప్లీజ్. ఫోన్
Am I audible, sir?
సార్ మీరు ఆడిబుల్ ఉన్నారు సార్, ఫోన్ ఇట్లా టిల్ట్ చేయండి.
Amarendra Reddy, 1 minute. Our Nanda Kishore, President, AP State, has come on the line. Before Dr. C.R. Rao inauguration, Dr. Nanda Kishore will give his message, sir.
Good morning,
Right,
sir.
okay. Carry on. Sir,
Amar
after
only-
Amarendra Reddy, please give your message, sir. After
Yeah.
Amarendra Reddy.
Yeah,
good
good morning. Once again, good morning to everybody. I would like to congratulate the AP Medical Council Chairman, Dr. Srihari Garu, for taking over charge as Chairman recently. And I also thank him on behalf of all the members of IMA Nellore and also IMA members of the state for arranging all the registrations in the district level only through slots. I am very grateful to him. This was not even done in the past. He has taken a good initiative and is coming over to the district level and doing the re-registrations for all of us. I once again thank him on behalf of IMA Nellore, and I thank all the delegates who have registered for this program. Almost 418 have been registered to this today's CME, almost equal to the January count. In January, almost 440 have been registered. Now also around 440 out of 418, 40 have been registered from other districts also by seeing from the this APMC website. So this shows the importance of the credit hours for the APMC registrations and all these. Also thank the APMC for giving us the opportunity to conduct this CME and giving us the credit hours. Thank you. I hope all of you have a feast of knowledge through this CME. Thank you. Now I request Dr. Nandakishore Garu, IMA State President, to give his remarks on this CME. Thank you.
Yeah. Good morning. Am I audible, Amar?
Yes,
Sir,
sir. You are audible,
Yeah,
sir.
yeah. Thank you. Thank you. So, good morning, all of you, respected President Dr. Amar and Dr. Rahul, and the pillar of Nellore IMA branch, our beloved state past president, Dr. Ashok Garu, and today's chief guest, our past president, national past vice president, Dr. Srihari Rao Garu, and all other office bearers of IMA Nellore and dear delegates. So first of all, I would like to congratulate the IMA Nellore branch under the leadership of Dr. Amar and guided by our senior leader, Dr. Ashok Garu. They are regularly conducting CME hours, CME with credit hours. Every year, almost 2 to 3 CME is being conducted by Nellore branch. So they are doing great service to the not only to the Nellore IMA members, as well as it is online CME. So almost more than 400 are attending. So they are giving credit hours regularly. So coming to our chief guest today, Dr. Srihar Rao Garu, very dynamic personality, and he is chairman on wheels. Somebody is calling nowadays because he is not staying in Tirupati. వాళ్ళ ఇంట్లో వాళ్ళు మరి ఏమి గొడవ చేస్తున్నారు నాకైతే తెలియదు, కానీ సార్ ఈజ్ రెగ్యులర్లీ రోమింగ్. ఇక్కడ ఒక వారం వైజాగ్, ఒక వారం విజయనగరం, సో తిరుపతికి వారంలో 1-2 రోజులు వెళ్తున్నారు. సో ఈ ఆయన వచ్చినాక చాలా చేంజెస్ were visible, because since 8-9 months we struggled a lot at medical council. Now he is ఒక ప్రాబ్లమ్ ఐడెంటిఫై చేసి సార్ ఈజ్ గివింగ్ సొల్యూషన్స్. Especially is giving importance to the more than 60 years senior citizens. So we hope we will see more and more positive things from APMC. Once again, I would like to congratulate Nellore branch for inviting me for this inauguration and conducting CMEs regularly. Thank you, one and all.
Thank you, sir. Thank you very much for your kind-hearted remarks. May I now request Dr. D. Srihar Rao Garu, Chairman AP Medical Council, to give his inaugural remarks and deliver Dr. Rotarian E.S. Reddy Memorial Oration for the year 2025.
Hello. Hello.
Sir, go ahead, sir.
Yes, sir. You are audible, sir.
Okay.
Yes, sir. Yes, sir.
Presentation visible, sir?
Yes, sir. Yes, sir. Sir, slideshow
Yes,
mode.
sir. Yes, sir.
Slides mode.
కింద రైట్ సైడ్ లో ఉంటుంది.
So, okay, sir.
Yes, sir. Okay, sir. You can go ahead, sir.
Good morning, all. The President of IMA Nellore branch, Dr. C. Amarendra Reddy Garu, our dynamic State President, Dr. Nandakishore, Senior Leader of IMA, and other past President of AP State, Dr. G. Ashok Garu, other leaders of the and members of IMA Nellore branch, Secretary Dr. Rahul Babu, and Treasurer Dr. M.V. Rammohan Garu, and today's eminent speakers and Registrar NTR University of Health Sciences, Dr. Vemireddy Radhika Reddy Garu, and myriad delegates. I declared the CME program as inaugurated. At the outset, I appreciate and congratulate the team IMA Nellore for their constant efforts and organizing the CMEs, orations, and National Health Days, IMA headquarters schedule programs. I believe knowledge is power. To empower doctors with knowledge, they can do wonders. And finally, it is beneficial to the patient and the society. The 10th Parliamentary Committee, in its 13th report, they have decided to renewal the registrations of the registered medical practitioners every 5 years. For that, they have to submit 6 credit hours per year, totally 30 credit hours per 5 years. This is the parliamentary decision. For that, APMC giving the accreditation and allocating the credit points. APMC recently taking the decision in the general body to reduce the credit hours according to the age. But we want to monitor the CME programs with latest technologies like artificial intelligence, and through artificial intelligence, we are taking the photographs that will match the delegates' photos with the photos we have in our AP Medical Council, and allocating the credit points according to your participation in the CME program. Sometimes you may get 0.5 credit points also out of the 2 credit points. we have generally we are allocating 2 credit points per day. 8 hours we are allocating 2 credit points. So out of 2, we'll get the 0.5 also according to your participation. We are going to strengthen the observed system and issue the new guidelines for them. Today, I am giving the delivery Dr. Rotarian E.S. Reddy Memorial Oration for the year 2025 on medical ethics. As all of you know, APMC is a medical registration and the regulator authority. We will register the undergraduates and postgraduates and super specialty courses, which are the MCI recognized degrees. We will require medical ethics case. We were receiving so many medical ethics cases from the government of Andhra Pradesh and central government, National Medical Commission, Human Rights Commission, Women's Rights Commission, Lokayukta and other courts also. High Court also sending the cases to AP Medical Council. We are only monitoring force in the healthcare. Nowadays, we are getting so many unethical and misconduct cases rather than the patient and doctor related cases. So we have to rectify our refresh our medical ethics awareness program during our PG and internship courses. So then we will start the medical ethics awareness program. Next. Is it okay, sir?
Yes, sir. Yes, sir.
Medical ethics and the duties and responsibilities of our character of the physician, good medical practice, and the maintenance of the medical records, display of registration numbers, and display of degree and professional fee, and legal responsibilities. Character of the physician rendering service is the humanity. Doctors, they believe that they are human, and we have to render service with the humanity and uphold the dignity and honor of the profession. Generally, all are respecting our profession. Quality and register under Medical Council of India or state medical councils. Earlier, it is only MCI and nowadays NMC recognize our degrees. Now, all the state medical council are registering our degrees. Maintain good medical practice. Practice methods of healing founded on scientific basis. So all our allopathy is based on the scientific basis. Take membership in medical society. Because you have to, any association, you have to be a member of the any association. But ours is the IMA is the mother organization for all the medical fraternity. You know, all of them, IMA is having 4.5 lakhs members at more than 800 branches in all over India. So they are fighting with our problems, our doctors' problems. Sometimes they are trade union, like fighting for the trade union like activities. So we have to join in IMA and strengthen our medical fraternity, and they will all the problems of our community will solve by through an association, that is the IMA. So any member to join before registering the AP Medical Council, they have to register or take this IMA membership of life membership of IMA. Participate professional meetings as a part of continuous medical education program at least 30 hours every 5 years. As I told you earlier, that is, you require the 6 credit points per year, and 5 years 30 credit points. Now we have reduced the 15 credit points 65 to 70 years, and 70 to 80 years 10 credit points, and after 8 years we reduce the no credit points for registration. So like that, you have to attend the regularly CME programs. You have to enhance our technology and the latest knowledge about our medical and our concerned degrees or our concerned specialty, and maintain medical records. Generally, I have doubt about how many days you have to maintain the records. That is, as for the Medical Council and AP Medical Council Act, you have to maintain the records for 3 years. In 3 years, if within 3 years, anybody asked for the records, you can issue within 7 to 2 hours. Any authority, court, or any police, or any, if you received any letter or any demand from that concerned authorities, you can issue within 7 to 2 hours, and maintain register with the, as you're issuing the certificates and all, but not maintain the records. You have to maintain the issued certificates, identification marks, and signature and thumb marks, and computerize medical records. You have to computerize every record of the concerned patient and the issued certificates. And display registration number in our clinic, in front of your clinic boards, and I have to mention your registration number. That is, these are the mandatory. In prescription pad also, you have to mention your registration number of AP Medical Council, and issuing certificates, you have to mention your AP Medical Council registration number, and money receipts also. Whatever you are giving them during registration or inpatient or outpatient, any receipt you have to mention your AP Medical Council registration number. Display only recognized registered degrees. Only you have to mention and display your MCI recognized degrees only, not your memberships or fellowships or foreign degrees, not recognized. The MCI should not be displayed. Generally, MD, MD, AM, and like that, we are mentioning the degrees, and fellowship memberships also you are mentioning. So that is not good for our community. So you have to mention your recognized degrees only. And payment of professional services. Announce fees before service. Somebody doing before surgery, but it may not be possible because any emergency or doing cases, then something happened to that patient. So you have to mention OP fees and what are the admission day per bed charges, room charges, and all. You have to inform the patient. Generally, you can give what are the total cost or the approximate cost of the patient. But somebody is doing in between the operations, come out and tell leftover the cystic is there, another problem is there. Like that, you have to not mention that. So, it is unethical to enter into contact of no cure, no payment. Generally, they will tell no cure, no payment. Name కాకపోతే మీరు డబ్బులు కావాల్సిన అవసరమే లేదు అని చెప్పని కొందరు ఏదంటే ప్రాక్టీస్ దానికోసం లేదా పేషెంట్ సాటిస్ఫాక్షన్ కోసంగా ప్రామిస్ చేస్తూ ఉంటారు. బట్ ఇట్ ఈస్ నాట్ కరెక్ట్. దేర్ ఇస్ నో సచ్ నో క్యూర్, నో పేమెంట్ ఇష్యూ. Under legal responsibilities, abide by law relating the protection and promotion of public health. You have to responsible about the public health. You have to anything you have to in front of press, telling the press or giving the notice or any press note. You have to responsible because the public health is the major role for our medical fraternity. Duties of the physician to their patients and in consultation with the obligation to the sick patient delicacy and secrecy. నువ్వు మనకి పేషెన్సీ ఉండాలి ముందుగా. ఇప్పుడు డాక్టర్ సగం ప్రాబ్లం ఎక్కడ వస్తుందంటే కమ్యూనికేషన్ ప్రాబ్లం ఉంది. యాక్చువల్ కమ్యూనికేషన్స్ వల్ల ప్రీవియస్ మన సీనియర్స్ అయితేనేమి ప్రీవియస్ జనరేషన్స్ లో దర్ ఇస్ నో కేసెస్ అగనెస్ట్ ది మన డాక్టర్స్ కి అగనెస్ట్ లేదు, ప్లస్ ఫైటింగ్ లేదు, ఎక్కడ ర్యాన్సమ్ గా జరిగినటువంటి ఇన్సిడెంట్స్ లేవు. సో మనం పేషెన్సీ మన మాట ద్వారానే వాళ్ళు కమ్యూనికేట్ చేస్తే డెఫినెట్ గా మనం మంచి డాక్టర్ గా పేరు వస్తుంది. బట్ ఇది టు మెయింటైన్ ద సీక్రెట్స్ ఆఫ్ ది పేషెంట్. ప్రోగ్నోసిస్ లేదా ఎగ్జాగరేట్ ఆర్ డౌన్ ప్లే. మనం ఎగ్జాగరేట్ చేయాలని, డోంట్ ఎగ్జాగరేట్ ఆర్ డౌన్ ప్లే. సంబడి తెలుగు అమ్మ అదే నన్ను ఆ ఎక్స్ప్రెషన్ ఆల్సో దట్ విల్ క్రియేట్ ఎ లాట్ ఆఫ్ ప్రాబ్లమ్స్ టు అవర్ డాక్టర్స్. పేషెంట్ నాట్ బి నెగ్లెక్టెడ్. Engage for an after cases. Engaged physician is absent. Another physician is entitled to professional fee, but handover or arrival of the physician engaged. This is the problem. Once you have referred the patient to the other doctor, they will give their visiting cards and their addresses and all. The patient, they want to come again to the patient, not the prior whose physician is examined or treated the patient. They are not in this one. So you have to, but after arrival of that physician, you have to send that patient to the previous physician. To the physician to the patient and in consultation. Avoid unnecessary consultations. Generally, we are referring the patients to one doctor to another. Simple causes also, you can referring the patient to the another doctor. And punctuality in consultation. You have to maintain the time. Time is the most important nowadays. It is everybody is depending on function time. So you have to punctual on time. Explain patient after consultation, frank and impartially. You have to tell the facts about the treatment, diagnosis and treatment. And treatment after consultation, after consulting treatment, before the going to treatment, the can get the proper diagnosis to treat that patient, refer with details. Generally, we are referring patients with institutes, higher institutes or tertiary care institutes. You are not mentioning about the disease or what are the investigations has done. Like that, you have to mention what are your provisional diagnosis and final diagnosis, what are the treatment you have given. Like that, you have to mention in the referral slip. Fee charges should be clearly displayed. As I told you, that is one of the this actual 11 of 2008 Act, before Registration Act, where our association promised to we will display the charges about regarding the patient and responsible physician to each other, dependence of physicians on each other. Don't criticize the referring physician. Generally, we don't criticize the physicians and conducting consultation. No rivalry or no envy. There is no rivalry between us. Both are the studied in MBBS and they do our specialty. So there is no rivalry or no envy between us. And appointment and priority and visiting another physician's case. They have to give the priority to the another referral cases and utmost consideration to the interests and reputation of the other physician. And duties of the physician to the public and paramedical professions. Disseminate advice on public health. You have to publicize on public health issues. Note every case of communicable disease. Notable diseases, you have to inform the concerned department and concerned heads of the department. Like TB, tuberculosis recently added this is notable disease. Recognize and promote practice of paramedical services. So you have to recognize without paramedical services and paramedical staff, it is difficult to run our hospital or any healthcare system. So you have to respect and recognize their duties and promote their medical practices. And unethical acts. Ethics deals with wrong conduct with what we ought to do, what we should avoid. So first we have to learn about what to do, what should be avoided. To say simply, treat the patient as you would to be treated yourself. And printing self-photographs on head and consultation rooms in unethical. Letterhead and consultation rooms is unethical. We are seeing so many, but I am actually in favor because our medical profession is now taking as healthcare is a industry. So all industries are publishing and doing the thing, but this has to discuss in NMC because a course of rupees are we are investing. So and permitted to make formal announcements in press on starting practice. When you are starting the practice or in change of practice or address, whenever you're changing the, once you are coming the dermatologist or sometimes they go to surgery or other department, are changing the address on temporary absence from duty. If you are not in India going to abroad, then you can publish on resumption of another practice, changing of the duties and public declaration of charges. And patent and copyrights. The benefits of such patents or copyrights are made available to public. Otherwise, it is unethical. And open shop dispense drugs and appliances. You can give drugs to emergency patients only, not to run a open shop or give solid or receive or offer to give any gift, gratuity, commission or bonus in consideration or return for the referring. That is the referral fees and all. That is also unethical. Doctor prescribed to the physician should always carry a property formula and clear name. You can write a drug in a capital letters also. And the physician shall not avoid or abet, touch or concealment of touch by some of the other persons or agency in clear violation of human rights. Can't arrange a in-between person and practicing euthanasia shall constitute unethical conduct. However, on specific occasion, trying supporting devices after brain death shall be decided only by team of doctors. It is decided, this euthanasia is decided by the team of doctors, then you can follow. Otherwise, it is unethical. And misconduct, violation of regulations, adultery or improper conduct, sex determination tests, signing professional certificate reports and other documents which are untrue, misleading or improper. Generally, we are giving the professional certificates. So they are become the RMPs now. The experience certificates we are giving. And also sometimes we are, as a radiologist, we are giving somebody coming and taking the letters. We are trained under radiologist. You are doing ultrasound. This is a misconduct. Prescribing drugs are procedures without indication. Without indication, you don't prescribe any drug or do any procedure. Issuing certificates of efficiency to unqualified person. As I said, tell you know that RMPs and all. Advertisement only, name, institution, facilities offered, and fees. Only the name of institution and facilities offered and fees. No, there is no name of the doctor. There is no photography in the advertisements. Consent before surgery. You have to take consent. Any procedure you can going before the procedure. You can take the consent from husband and wife both in sterile during the tubectomy and sterility operation. You can take both husband and wife consent. Public photographs or case reports without patient permission. You can get the permission from the patient. Otherwise, you can't display the or publish the photographs or case details about the particular person. Use of thoughts for procuring patients. Research without patient consent. You have to take permission before going to research. And physicians will be if you were option 2 to 3 times, they will take the necessary actions. Other in duty, somebody is coming out and being practice and going to the hospital, government services. That is a misconduct. They can take action any time. And misconduct and punishment. Complaint, inquiry, peer review. We have the ethics committee. We have the 5 members are there in ethics committee. We will, whenever necessary, we will take the expert opinion also. We will inquire after receiving the cases. Chairman will take the decision to which is complainable or not. And then we will refer to our ethics committee. They will call the both patient and the complainant doctor, and they will decide and discuss with both the if they want to, they can produce their advocate also. Then we will give the punishment, suspension or removal of name. And any complaint regarding the professional misconduct can be brought before the appropriate medical council and disciplinary action. The medical council would have an inquiry and give opportunity to the parent to be, as I told you, pleader can appoint. Punishment can be removed from the register for limited period. Sometime you will leave limited period or deletion from the register also. We can do if it is a grass problem or grass negligence, grass mistake done by our doctors, they can be deleted from the register. This will be published in press and in publications of medical associations. So after decision taken, we will publish in the press and also issue these to inform our medical association like IMA, GMA and all. Like that, we will publish in that. Professional incompetence shall be judged by the peer group of as per the guidelines of the MCA. So any incompetence of the doctors, they can be decided by the group of doctors. And PCP Act, as I know, is a separate act. It can prohibit the sex selection both before and after conception. General, as a radiologist, I have elaborately described that it regulates the use of prenatal diagnostic techniques like ultrasound, amniocentesis. No laboratory or center or clinic will be conducting any test, including ultrasonography, for the purpose of determination of the sex of the fetus. No person, including the one conducting prenatal diagnostic procedure, as per the law, will communicate the sex of the fetus to the pregnant woman, consent to her relatives by words or signs or any other method. You can't declare the sex of the fetus. So, if anybody doing and they made a means of hoardings, wall paintings, signal, lights, sounds, that will be punishable. There will be 3 years punishment is there and 10,000 fine is there. Any medical genetics or gynecology registered medical practice, any person who owns genetic counsel, done any mistake, they will imprisonment up to 3 years and 10,000 fine. It is again subsequently they will get the 50,000 fine and imprisonment for 5 years. And the person seek the aid of genetic ultrasound clinic and medical genetic sex can be face imprisonment for 50,000 pay or 3 years imprisonment, and repeated it will be 1 lakh. And the appropriate authority will have a women's organization. That is the PCP India Act. We can appropriate authority. Any complaint, they will refer to the appropriate authority. They will take the necessary actions against the doctors. And but there is a problem with that. There is no grading of the punishment. They will take the clerical mistakes and the sex determination as the same. they will punish the doctor, radiologist, and any doctor, they will take the action, same as the clerical mistake. These are the, cannot allow the show baby to the patient from a machine during scan. Self-referral not allowed. Referral should be in consultation, own letter pad. And you cannot distribute the referral forms to your center, clinic, or hospital. Note down the time when you obtain consent before scan. You can't talk to patient nor report to be disclosed. And no picture of God to be in the scanner, no picture of God or any. Our photos also are not, it is unethical in keeping in our scan rooms. And no reflection mirror, and straight the mission to be kept. Opposite mission, you can reflect the mission, and showing the picture is also unethical. And we have the maintain the forms, Form F, consent form, a nominal register, case number, and reports. These are the PCPND Act registers. They have to keep all the registers in the inside. And declaration, when you are coming to that time of registration, each applicant shall be given a copy of the following declaration by the register concerned, and the applicant shall read and agree to abide by the same. When you are coming to the registration to the AP Medical Council, they will give the form. You have to read and accept that the declaration. And these are the 11 points are there. So at that time, you have to sign and name, place, and address you have to mention. And form of certificate, leave or extension or communication of leave. Whenever you are giving the certificate for the leave or any this one, you have to take the identification marks and take the signature of that patient and our thumb impression. And this is also same. And you have to mention everything, and your APM's registration number has to mention in that certificate. And you have to take this for the patient details, name of the patient, age, sex, address, occupation, date of visit, clinical note, provisional diagnosis, investigations advised with reports, diagnosis after investigation, advised, and follow-up date. And you have to mention that. So you have to mention all these details with them before taking that. Nowadays, the provisional diagnoses are missing. So you have to mention your provisional diagnosis in that form. And the certificates we are using so many there, like mental deficiencies and driving license and other health acts and orders made and Workers' Compensation Act, Persons Disability Act, so many letters is there. And under Employee State in CSI, in connection with the Sick Benefit Insurance and Friendly Society, under Merchant Shipping Act, in connection with the quarantine rules for procuring driving license, like that you have to issue the so many licenses. You can take care about the details about that person or patient before issuing the certificate. You can mention their everything. As I told you, identification marks and signature you will get. That everything will be clear and transparent. And the International Code of Medical Ethics, these are the generally our national and international medical ethics. A doctor must always maintain the highest standards of the professional conduct. A doctor must not allow himself to be influenced merely by the motives of profit. The following procedure and aimed unethical any self-advertisements except such as expressed authorities by the National Code of Medical Ethics. Taking part of any plan of medical care in which the doctor does not have professional independence to receive any money in connection with the service rendered to the patient other than the acceptance of a proper professional fee, or to pay any money in the same circumstances without the knowledge of the patient. And the duties of doctors in general, under no circumstances is a doctor permitted to do anything that would weaken the physical or mental resistance of a human being, except strictly therapeutic or prophylactic indications imposed on the patient. A doctor advised to use great caution in publishing discoveries. The same applies to the methods of treatment, which value is not recognized by the profession. When a doctor is called upon to give evidence or certificate, he should only state the which he can verify. We have to verify everything. And a doctor must always bear in mind importance of the preserving human life from the time of conception to death. A doctor owes his patient complete loyalty and all resources of his science. A doctor owes his patient absolutely secrecy on all which has been confident and to him in which he knows because of the confidence entrusted to him. A doctor must give the necessary treatment in emergency unless he is assured that it can and will be given by others. So you have to, in CPA Consumer Protection Act and all, you have to take the care about the patient. Before when a patient is come to emergency, you can hand over the patient next to hospital. If the responsibility of the doctor, you have to be responsible for that up to the reaching the next session. And a doctor ought to behave his colleagues as he would have them behave to him. A doctor must not entice patient from his colleagues. A doctor must observe the principles of the Declaration of Geneva approved by World Medical Association. These are the Geneva Declaration. And finally, a qualified allopathic doctor should register with the state councils and also register additional qualification to practice in AP. It is also mandatory as for the Medical Establishment Regulatory Act. Except recognition, no other subjects should be added to the name. One should display registration number on letter pad. Also, the name boards should not be unusual, large, and not be displayed place other than where practicing. A physician should maintain inpatient records for 3 years, and they have to use 2 years, and maintain PCP net act. Consistency should be only for the benefit of the patient and should not maintain punctuality. Is unethical. When case is referred to consultant, the case should be referred back to the treating doctor. As I told you, if the treating doctor is not available, arrangements should be made, especially in obstetrics cases. A doctor is allowed to announce in lay press of media when he is starting practice, changing type of practice, change of address and temporary absence, and when succeeding to another practice. And physician is citizen as is responsible towards the public and community health. You have to remember this one. So what should not be done? Should not solicit patient directly or indirectly, should not entertain middlemen, should not display any degree not recognized by the MSA, should not be speak about the patient to other than close relatives, should maintain secrecy, delicacy, and secrecy while treating. One should not run a open medical shop, claim secret remedies or violation of human rights or help in euthanasia, should not contribute to lay press which have effect of advertising or soliciting patient, or one can speak on public health issues, deliver lecture, and giving talk, should not print photographs and letterheads. And unusual large signboard should not be used. It should contain only name, qualification, and specialty and registration number. Should not issue certificates of efficiency in motor medicine to unqualified and non-medical persons. Not allow unqualified person to perform procedures or assist in operations or allowed to work in our hospitals. Should not issue false certificate. Should not indulge in adultery, improper conduct or conduct sexual should not violate drugs. And the Hippocratic Oath, all are knows, and for our starting our course, you are taking Hippocratic Oath. And I thank our CM and Deputy CM and our health minister, Yadav garu, and CM Chandrababu Naidu garu, and Pawan for giving the opportunity to work as a chairman for AP Middle Council. Earlier also 2014 and 19, I worked as a member and vice chairman for this guest body of on the AP Middle Council. And AP Middle Council taking the district level programs, doing our renewals and other renewals and re-registration, NOC, and good standing certificate, and online also we are taking the sign-up forms. So you can utilize our service in your district. Next 3rd week we are coming to Nellore, July, and you can take this opportunity and enroll as many as possible, because I have, as a leader of IMA and Apna and worked as a AP Medical Vice Chairman, I have noticed this problem. That's why I taken the immediate, within 1 month, I have taken so many reforms in our AP Medical Council. Definitely, well, our friendly, doctor friendly, our members are giving so much cooperation. Our sister and staff are doing during the district level renewals. Our staff is working.
సార్ మీరు అన్మ్యూట్ చేయండి సార్ ఒకసారి శ్రీహరి సార్.
Thank you. Thank you very much. thank Amarendra and Ashok sir for giving this opportunity. I always be friendly and close to our Nellore branch. They are very much cooperative for our. There is actually our original Ashok sir is a senior leader and will take always the help, and our Nandakishore is doing a lot, and this team also doing for medical association. Thank you, one.
థ్యాంక్ యూ శ్రీహరిరావు గారు.
Sir.
ఒక్కటి ఇక్కడ ఉన్న డెలిగేట్స్ కూడా అందరూ సార్ ఇన్ఫార్మింగ్ యూ 100% attendance is now as of now. And what I would like to tell to all the delegates is medical council before lifelong ఒక ఒక హిస్టరీ క్రియేట్ చేశారు సిఆర్ రావు గారు. బిఫోర్ ఏపీ మెడికల్ కౌన్సిల్, బిఫోర్ సిఆర్ రావు అండ్ ఆఫ్టర్ సిఆర్ రావు అనేది ఎప్పటికీ లైఫ్ లాంగ్ నిలబడిపోతుంది. బికాస్ హీ హాస్ టేకెన్ such a steps that he has taken the AP Medical Council to the doorsteps of the doctors in each district. Thank you, Srihara garu.
One time you can get the e-signature. You need not come to the AP Medical Council. You can go lifelong online. Any renewal, anything, you can go. Thank you, sir. Thank you. Namaskar.
Sir, next speaker is Dr. N. Gopalakrishnan. He is the ex-professor of Madras Medical College, a luminary in the department. He is a member secretary as of now, the Transplant Authority of Tamil Nadu. He is the author of around 18 books.
Thank you, sir.
Yes,
thank you very much for inaugurating our Nellore IMA CME and for giving elaborate details on medical ethics like conduct, misconduct, legal procedures, punishment, PCB and DT Act, AP Medical Council registration, and the reforms taken by you, and also for bringing the medical council to the doorstep of the doctors at the district level. And I once again thank on behalf of IMA Nellore. Thank you very much, sir. Now I request Dr. K. Rahul Babu, Secretary IMA Nellore, to give his remarks. And after that, I request Dr. Ashok Garu to give introduction about the first speaker, Dr. N. Gopalakrishnan Garu. Thank you.
We welcome Rehan Garu. He has just joined. Sir, Rahul Babu, please.
Thank you, sir.
Good morning, all of Good morning, all of you. Good morning, Dr. Rehan sir. Dr. Rehan sir will deliver oration on Dr. Karmula Garu, and he is giving topic on keyhole heart surgery, myth or reality. He is a consultant cardiothoracic surgeon in Apollo Hospitals, Chennai.
Sorry, Rahul Babu. Sorry. Next speaker is N. Gopalakrishnan Garu. He is member secretary, Transplant Authority of Tamil Nadu, and a very luminary in the profession in his department. And he was the director of nephrology department, Madras Medical College, and he had the prestigious J.M. Patel Oration Award, and he had the Tamil Nadu Medical Council Good Governance and Administration Award, examiner for the Royal College, and he has edited around 185 journals, and he is advisor, and he has authorized books for 18 books. Sir, and he is delivering Dr. P.L. Rao oration for the information of Dr. N. Gopalakrishna Garu. Dr. P.L. Rao oration is installed in the name of Dr. P.L. Rao, who has been a leading ophthalmologist not only in Nellore but the entire Andhra Pradesh. He has number of branches, and he is the Babai of Surendra sir for your information, sir. Please carry on your oration, sir. Thank you, sir.
Hello? Sir.
Very good morning. Can somebody help me in sharing my presentation?
Yes, sir.
I'm not able to share it.
So there's a button on the screen, sir, share ani.
Yes,
Click on that.
yeah, now I am able to, I think.
Yeah. No, sir. Yeah. No, it's okay.
Yes, Andy.
1 second. ఇప్పుడు ఓపెన్ చేయండి సార్, ప్రెజెంటేషన్ ఓపెన్ చేయండి. క్లిక్ ఆన్ దట్, డబుల్ క్లిక్ సార్.
ఇప్పుడు కనిపిస్తుందా?
ఒకసారి లోడ్ అవుతుంది సార్.
ఓకే.
సార్ ఒకసారి ఓపెన్ చేయండి సార్. అది ఐ థింక్ ఇట్స్ టేకింగ్ లాట్ ఆఫ్ టైమ్. కెన్ యూ ఒకసారి స్క్రీన్ షాట్ ఆఫ్ చేసి మళ్ళీ చేయండి సార్, స్క్రీన్ షేర్.
స్టాప్ చేసేసి మళ్ళీ చేయను.
మళ్ళీ చేయండి సార్. ఆ ప్రజెంటేషన్ ఓపెన్ చేసుకోండి సార్ ఒకసారి. ఫస్ట్ ప్రజెంటేషన్ ఓపెన్ చేసుకోండి సార్. టేక్ యూ టైమ్ సార్. యా.
ఓపెన్ చేసుకున్నాను.
ఇప్పుడు స్క్రీన్ షేర్ చేయండి. గ్రీన్ కలర్ బటన్ క్లిక్ చేసినాక షేర్ అని మళ్ళీ కొట్టండి సార్.
ఓకే.
ఎస్ సార్. ఇప్పుడు స్లైడ్ షో కింద రైట్ ఉన్నాడు సార్, బాటమ్ రైట్ సైడ్లో స్లైడ్ షో బటన్ ఉంటుంది.
అవునండి.
ఎస్, క్లిక్ ఆన్ దట్ సార్.
ఎస్.
ఎస్, యూ కెన్ గో హెడ్ సార్. థ్యాంక్ యూ.
ఓకేనండి.
గో హెడ్ సార్.
బట్ నా ప్రెసెంటేషన్ కనిపించలేదే.
మీరు నెక్స్ట్ కొట్టండి సార్ ఒకసారి. ఆరో మార్క్, నెక్స్ట్ ఆరో మార్క్ చేయండి.
లేదు, ఐ థింక్ ఇట్స్ షేరింగ్ అగైన్.
ట్రై డూయింగ్ దట్ వన్స్ అగైన్ సార్. We're able to see chronic diseases. ప్రెజెంటేషన్ ఆల్రెడీ ఓపెన్ ఉంది కదా సార్, అది ఓపెన్ చేయండి సార్.
ఓకే
సార్, మీరు స్క్రీన్ షేర్ చేసేటప్పుడు ఎంటైర్ స్క్రీన్ అని కొట్టాలి సార్. వెన్ యూ క్లిక్ ఆన్ స్క్రీన్ షేర్, ఒకసారి స్క్రీన్ షేర్ ఆఫ్ చేయండి సార్ మీరు. యా, వెన్ యూ క్లిక్ ఆన్ స్క్రీన్ షేర్ కదా సార్, ఇప్పుడు ఎంటైర్ స్క్రీన్ అని ఒకటి పైన ఆప్షన్ వస్తుంది, అది క్లిక్ చేసి మళ్ళీ షేర్ అనే బటన్ మళ్ళీ క్లిక్ చేయండి సార్. ప్రజెంటేషన్ ఓపెన్ చేసుకోండి సార్. ఎస్, ఇప్పుడు నెక్స్ట్ చేయండి సార్ ఒకసారి. నెక్స్ట్ గో ఆన్ టు నెక్స్ట్ బటన్. ఒకసారి మౌస్ బటన్ ఒకసారి క్లిక్ చేయండి సార్. మౌస్ బటన్ ఒకసారి క్లిక్ చేయండి బయట. ఇప్పుడు నెక్స్ట్ కొట్టండి సార్. పర్ఫెక్ట్.
ఫైన్.
స్లైడ్ షోలో పెట్టండి సార్.
స్లైడ్ షో చేస్తాం సార్.
ఓకే,
సూపర్. సో ట్రై చేయండి సార్ మళ్ళీ సార్. నెక్స్ట్ బటన్.
ఒక నిమిషం. ఓ,
స్క్రీన్ మీద ఒకసారి క్లిక్ చేయండి సార్, ఏం ప్రాబ్లం లేదు. స్క్రీన్ మీద ఒకసారి క్లిక్ చేయండి. ఇప్పుడు ఒకసారి ట్రై చేయండి. ఓకే, ఎస్కేప్ బటన్ కొట్టండి సార్. ఎస్కేప్ బటన్ కొట్టండి సార్. ల్యాప్టాప్ మీద ఎస్కేప్ అనే బటన్ ఉంటుంది సార్.
అవును
సో క్లిక్ చేయండి సార్. చేస్తున్నారా? ఒకసారి మళ్ళీ ట్రై చేయండి సార్. ఇప్పుడు నెక్స్ట్ బటన్.
కింద యారోస్ ఉన్నాయి సార్, నెక్స్ట్ యారో నొక్కండి సార్.
అవును, లేదు, నో ఇట్స్ నాట్ మూవింగ్.
ఓకే, ప్రాబ్లం లేదు సార్. ఇప్పుడు మీరు ఒకసారి స్క్రీన్ షేర్ ఆఫ్ చేసి మళ్ళీ స్క్రీన్ షేర్ చేసి యూ కెన్ గో ఆన్ విత్ ద ప్రెజెంటేషన్ సార్. ఒకసారి మళ్ళీ చేయండి సార్ స్క్రీన్ షేర్. ఎంటైర్ స్క్రీన్ అని చేయండి సార్. ఎంటైర్ స్క్రీన్ క్లిక్ చేసి మళ్ళీ షేర్ బటన్ క్లిక్ చేయండి సార్.
ఓకేనా?
ఒక్కసారి వన్స్ ఇప్పుడు చేయండి సార్ ఒకసారి నెక్స్ట్.
ఇంకా డౌన్లోడ్ అవుతుంది అనుకుంటా, షేరింగ్ అవుతుంది.
షేర్ అవుతుంది సార్. ఫస్ట్ స్క్రీన్ వస్తుంది. సెకండ్ స్క్రీన్ మీకు వెళ్ళండి సార్.
లేదే, ఇట్స్ నాట్ మూవింగ్.
అప్ యారో డౌన్ యారో కానీ సైడ్ యారో నొక్కండి సార్.
లేదండి, మూవ్ అవ్వడం లేదు.
ఏం ప్రాబ్లం లేదు సార్. ఒకసారి మళ్ళీ స్క్రీన్ షేర్ ఆఫ్ చేసి మీరు స్లైడ్ మోడ్కి వెళ్ళకుండా ప్రజెంటేషన్ ఎలా అయితే ఇంతకుముందు చూపించారు కదా అలా చేద్దాం సార్. ఒకసారి గుట్టి స్క్రీన్ షేర్ చేయండి సార్. గుట్టి ప్రెజెంటేషన్ షేర్ చేయండి సార్. స్క్రీన్ షేర్ స్లైడ్ షో చేయకండి సార్.
ఓకే.
ఓపెన్ చేయండి సార్, అంతే. డౌట్ లేదు.
ఇప్పుడు కనిపిస్తుందా?
లేదు సార్, ఇంకా మీ హోమ్ స్క్రీనే కనిపిస్తుంది. ప్రజెంటేషన్ ఓపెన్ కాలేదు సార్.
ఓపెన్ అయిపోయింది నాకు. మీరు ఒక పని చేయండి, నేను ప్రెజెంటేషన్ మీకు పంపించున్నాను. కెన్ యూ షేర్ ఫ్రమ్ యువర్ ఎండ్?
యా ఐ కెన్ డూ దట్ సార్.
ప్లీజ్ డూ దట్ బికాజ్ అన్నెసరీ టైమ్ ఇస్ గోయింగ్ ఆన్.
గ్రూప్లో పోస్ట్ చేయండి సార్.
చేస్తున్నానండి ఆల్రెడీ.
ఒక్క నిమిషం సార్, మీరు స్క్రీన్ షేర్ ఆఫ్ చేయండి సార్.
చూడండి.
సార్ అశోక్ సార్కి పంపిస్తారా సార్ ప్రజెంటేషన్ ఒకసారి?
ఎవరికో పంపించున్నాను ఆల్రెడీ.
అశోక్ సార్కి పంపించండి సార్ ఒకసారి.
నాకు ఒక నంబరే ఉందండి, ఆ నంబర్కి పంపించానండి.
పంపించండి సార్ ఒకసారి, పంపించండి.
నో, ఐ ఆల్రెడీ సెంట్.
ఓకే.
ఉందా?
ఒకసారి డబుల్ క్లిక్ చేయండి సార్ మళ్ళీ.
నాకు యువర్ స్క్రీన్ షేరింగ్ అని వస్తుంది. ఇట్ ఈస్ స్టార్టెడ్ షేరింగ్ ది స్క్రీన్. ఐ డోంట్ నో హౌ లాంగ్ ఇట్ విల్ టేక్.
ఒక్క నిమిషం సార్. మీరు స్క్రీన్ షేర్ ఆఫ్ చేయండి సార్. నాకు ప్రజెంటేషన్ వచ్చింది, నేను ఓపెన్ చేస్తాను. సార్ వచ్చింది సార్, ఒక్క నిమిషం. సార్ మీకు స్క్రీన్ షేర్ కనిపిస్తుందా సార్?
కనిపిస్తుందండి.
యూ కెన్ గో ఆన్ సార్. మీరు
Okay.
నెక్స్ట్ చెప్పండి, నేను చేంజ్ చేస్తాను.
ఓకే, థ్యాంక్ యూ సో మచ్. సారీ ఫర్ ది టెక్నికల్ గ్లిచ్. అండ్ ఎందరో మహానుభావులు, అందరికీ నా వందనములు. ఫస్ట్ ఆఫ్ ఆల్, ఐ ప్రొఫ్యూస్లీ థ్యాంక్ the team IMA Nellore for conferring this prestigious oration award upon me, and my pranams to PL Rao Garu. Today topic for my discussion is the chronic kidney disease, the global crisis. Why this topic is important? Because the chronic kidney disease is considered as a kind of a pandemic. Normally, the expressions as epidemic and pandemic are reserved for communicable diseases. But now, given the enormity of the problem, there are certain non-communicable diseases which are also described as epidemic and pandemic, like hypertension, diabetes, obesity, cardiovascular disease, malignancies, as well as chronic kidney disease. So look at this. This is a very important paper published in Lancet in 2020. I was also one of the multiple co-authors of this paper. This analyzes the global, regional, and national burden of chronic kidney disease and the trend changes that have taken place over 2.5 decades. Next slide, please. Yeah. So these are the alarming numbers. The current projected number of the people across the globe afflicted with chronic kidney disease is about 850 million. Now, this is an approximate number only. And look at that. There is about 30% increase in the CKD prevalence. Something very serious is happening during the past 2.5 decades. There has been a 30% increase in the CKD prevalence. And more worrisome fact is that 1/3 of the global CKD patients are living in only 2 countries, that is China and India. Okay. And why are we bothered about it? And CKD is the 12th leading cause of death, and CKD causes direct mortality. Also, it causes cardiovascular mortality. You all might have come across that many patients with chronic disease, even before they reach a stage of dialysis, that is end-stage kidney failure, they die of cardiovascular disease. So CKD is a great and very significant cardiovascular disease risk factor. So the mortality is directly to the CKD per se, as well as due to cardiovascular disease. Next slide, please. Yeah. So these are the important, so look at these figures. This is a global description of the prevalence of the CKD burden across the entire world. And why this problem? Can you please unmute yourself, please? Please, all the attendees, please remain muted. Yeah. See, why this is CKD is increasing so much? Why so much of CKD during the last 2.5 decades? There are so many etiological factors, but you can divide the etiological factors into 2 broad classes. Number 1, the diabetes, hypertension, metabolic syndrome complex, particularly the obesity. All these things contribute. Across the globe, the numero uno cause for CKD, the most important cause for CKD is diabetes, and diabetes. Across all the countries and all communities and so on. But this is one half of it. The other half of it is the CKDU, chronic kidney disease of unknown etiology. Meaning those who don't have diabetes or hypertension and no known family history, no inherited problem, and they are diagnosed with CKD. This is called chronic kidney disease of unknown etiology or unknown cause. About that we'll discuss. So these are the 2 broad menaces, 2 broad problems of great dimension facing us. Next slide, please. Yeah. So let me talk about diabetes to start with. Again, I had the fortune of being one of the authors of this important Lancet paper, the increasing burden of diabetes and variations among the states of India, the global burden of disease, a study on diabetes alone. This again compares the data between 1990 to 2016. Next slide. Fine. So look at this. Tamil Nadu and Kerala, the prevalence of diabetes is very high according to this paper. Overall, there has been a significant increase in the prevalence of diabetes as compared from 1990 to 2016. The prevalence in India in 2016 was 7.7%, whereas in Tamil Nadu and Kerala, the increase in diabetes prevalence is much more than other states. Why this increase in the diabetes? We all know it is the price we pay for the so-called the progress of the society, the economic affluence and sedentary lifestyle, per capita consumption of calories getting more and more. All this is, but this is the old data. What are the latest data? Next slide, please. So this is the current data. The recent publication in Lancet 2024. This is an assessment, rough assessment of the global prevalence of diabetes by the year 2022. According to this figure, across the globe, there are 828 million of adults across the globe have diabetes, such a number, okay? And please concentrate here in India. So the South Asian countries, in India alone, 220 millions, the brown color. Look at the concentrate there. So India, there are 26% of the global diabetics are residing in India. This is the problem. So India is going to become the diabetes capital of the universe. This is not a big kind of credit, but it is an alarm bell. You all had to get alerted. Diabetes has openly announced, it has waged a war against humanity, particularly in India. But are we ready to fight it across? Next slide. Fine. So let me talk about the the half of the problem, that is CKDU, chronic kidney disease of undetermined etiology. What is this actually? Next slide. What do you mean with this CKDU? So this is a definition given from Sri Lanka. Initially, they only identified such a phenomenon. To put it across, as I've already said, an adult getting diagnosis of CKD, but who's not a diabetic, not a diabetes, not a hypertensive, no family history, no glomerulonephritis, no obstructive nephropathy, and so on. Who are they primarily afflicted with this? The agricultural workers and other construction laborers and so on. They don't know what exactly is the cause for it. They thought it can be some water contamination or chemicals and so on, but now we know more about it. Next slide. Yeah. So how about in Andhra Pradesh? The first kind of announcement of CKDU from India came from Udhanam region of Srikakulam district. You all might have known. A lot of work was done by a great Professor Raviraj Garu on this. The coastal Andhra Pradesh, Srikakulam district, and there was a clustering of CKD. 18.7% of the population had CKD, and this is called Udhanam nephropathy. Next slide. Next slide, please. Yeah, in Tamil Nadu also, there is a lot of clustering of CKDU. In fact, one of our colleagues has termed it as kind of Tondai Mandalam nephropathy because, there is a clustering of CKD in Ariyalur, Viluppuram, Tiruvannamala districts and so on. What is common for all this? The climate is hot and humid during most part of the time. Next slide. Fine. So, who is afflicted with CKDU? Those who are working in the unorganized sector. Those who work outdoors for long hours of the day and for most months of the year and for many years, particularly two classes of workers. One is agricultural laborers and the construction workers. And of course, those who are working in lathes and brick kilns and furnaces and foundries and goldsmiths and truck drivers. And also there is increased incidence of CKD in Gulf country returnees. Those who have been working in Kuwait and Saudi and so on for 10 years plus when they come with chronic kidney disease. So what is in common for all these things? What is in common? We surmise there are three factors. One, the heat stress, the climate change. It is an offshoot of climate change. So the long summers and increasing peak temperature during every year. And these unfortunate, our brothers, they work in the hot sun without adequate consumption of water, chronic dehydration, the kidney suffers. We call it as heat stress nephropathy. It's not just that. The environmental pollution. There's so much of pollution in the ambient air. Most of the Indian cities, the level of pollution in the ambient air has crossed the unsafe limits. There is particularly, of all the pollutants, there is something called PM2.5, the particulate matter of 2.5 micron dimension, that we inhale a lot of them, and that causes a perennial and persistent activation of the stress axis, and that is supposed to contribute for heart disease, lung disease, kidney disease, and even cancers and neurodegenerative disease and so on. And the third factor is the chemicals, the fertilizers and pesticides and the silica dust in the cement for construction workers. So these are three important factors. One is the heat stress, then the environmental pollution, and the chemicals. Probably these are the important factors for causing CKDU. Why I'm talking elaborately on this is that on the one hand, we have to concentrate more on diabetes and hypertension and obesity. On the other hand, there is not much sensitization on this. Next slide, please. Next slide. Yeah. How about the data in Tamil Nadu? Tamil Nadu, when I recently retired from Madras Medical College, we completed a statewide randomized cluster sampling survey done by nephrology and community medicine, and with the great help of Directorate of Public Health of Tamil Nadu. First of its kind in the entire country. Next slide, please. Next slide. Yeah, there are about 6.5 crores of Tamil Nadu adults. But we divided Tamil Nadu into 177 clusters from Kanyakumari to Chennai. And in a randomized technique, cluster sampling technique, we selected 4,800 subjects across the state of Tamil Nadu. We did all these things, About 600 people were involved. It was a mega exercise, and successfully we completed first of its kind in the entire country. All the demographic and personal family history data and BMI calculation, blood pressure, urine protein using dipstick there itself at the spot, and drawing blood for hemoglobin, sugar, and creatinine, and all the blood samples were transported to a single central public health laboratory in Chennai. And we applied CKD epi formula, and we estimated the GFR. What are the results? Next slide. The results were very alarming. The prevalence of hypertension among Tamil Nadu adults is 32.8%. I don't think Andhra will have a different data. Andhra also should be in the same line. So this is the prevalence of hypertension, and diabetes is 18%. And 60% of Tamil Nadu adults are either overweight or pre-obese and obese. Look at this. Where are we? Are we really sensitized? We are really facing a real threat and looming danger, right? And the most important thing is that about 30% of the diabetics and 60% of the hypertensives were not aware that they have been having diabetes and hypertension. At this point of, at this juncture, my humble request and sincere appeal to the IMAs, all IMAs are doing great work across the country, and every IMA branch should get sensitized on this, and wherever there is an opportunity for IMA, you please spread the message across to our own fraternity first and then to the public at large. Next slide, please. What are the prevalence of the chronic kidney disease? The chronic kidney disease stage 3, 4, and 5 itself, 8.4% of our Tamil Nadu adults are in CKD stage 3, 4, and 5. Very big number. So am I right? Am I justified to call CKD as a kind of a global crisis? Yes, of course. Next slide, please. Yeah. So as I've already pointed out, 53.4% of the CKD patients of Tamil Nadu, they are neither diabetics nor hypertensives. So most of them are likely to have CKDU. So almost 50% of the problem is due to hypertension, diabetes. The remaining 50% is the so-called CKDU. So equal importance has to be given for both. Next slide, please. Right. So what is CKD? CKD is a big continuum, a chronic kidney disease, which is defined as a decline in the GFR and or even with the normal GFR, if somebody has got persistent proteinuria for more than 3 months or persistent hematuria, microscopic hematuria for more than 3 months, you can call it a CKD. This is what is the definition. We have staging of CKD from 1, 2, 3, 4, 5. And then stage 5 is GFR less than 15 ml per minute. And then with further decline in the GFR, you reach a stage called end-stage kidney disease. What do you mean by that? At this particular point of time, an afflicted person cannot lead a qualitatively normal life without either dialysis or transplant. So this is a kind of a chronic continuum. So for CKD care has to be a kind of a protracted care. There should be multiple personnel involved in this and navigating through the stages until starting from CKD1 up to transplantation. The patient and the patient's family has to be supported with a lot of empathy and diligence. Next slide. Right. So how to stage? So look at the small box which I've put on the right top corner, estimation of GFR. How to do that? It's very simple. I request all the attendees of this lecture, please download in your smartphone the CKD epi formula, the chronic kidney disease epidemiological collaborative study formula. It's very, very simple. It will just ask for the gender of the patient, male or female, and then weight in kilograms and serum creatinine in milligram per deciliter. If you feed that, that will give a number. That is your GFR. Okay. Based on this, you classify. Means you stratify the GFR. G1, as I've already said, the GFR is well preserved, but still you call it as stage 1 CKD because there is proteinuria. Okay. Then G2, 60 to 89. G3A, 45 to 59. G3B, 30 to 44. And G4, 15 to 29. And G5 is less than 15 ml per minute. So what is this actually? If you club the data of the estimated GFR with the proteinuria of the patient, that is albuminuria of the patient. If you get these different colors, if somebody is in the red color, is at a very high risk for progression to ESRD. Next slide. Yeah. So how to prevent? I've already said millions of Indians, millions of adults across the globe are afflicted with CKD. It is not possible for any healthcare delivery system, however sophisticated, whatever be the budget, to offer care for all these millions of patients. It's not possible. You open a dialysis unit, immediately it gets filled up. That is not the solution. The solution is prevention. Prevention is the key. And India is not a country. India is a subcontinent by itself. 1.45 billion population. Every sixth human being on the planet Earth is Indian. So your strategy has to be more on prevention rather than establishing dialysis units. Fine, that's right. So what is prevention? People normally talk about primary prevention, secondary prevention, tertiary prevention. But I always say there is something called primordial prevention also for CKD. What is that primordial? Even before primary, what is that? Next slide. Next slide is that. The primordial prevention. If you want to handle hypertension and CKD, you have to strengthen your maternity services. Why do I say so? In a society where the fetal birth weight of the fetus, baby, is higher, that society is healthy. It's one of the important health indexes. So now the research is that if a child is born with a very low birth weight, there is a chance that the kidney weight of the baby is less, and a kidney with less weight is supposed to have less number of nephrons. Okay? A person who is born with less number of nephrons is inherently at risk and vulnerable to develop hypertension and chronic kidney disease in later life. So this is called Brenner's hypothesis. According to Barium Brenner, he calls CKD is a fetal flaw. Even though we are taught that each kidney has got 1 million nephrons, it's not so for every person. Some people can have just 0.3 million, the other one can have 1.3 million. So we have to focus more on the maternal nutrition and ensuring adequate birth weight. This I always call it as a primordial prevention of CKD. Next slide. Next slide. Primary prevention, a healthy lifestyle. The previous generation elders, what kind of life they all lived? Early to bed and early to rise. Be satisfied with what you have. Discipline in food, a balanced diet, walking, physical exertion, and having a control on your weight, having a check on what you eat, and a stress-free life. All this is very important. No smoking, no drugs, adequate water consumption. At least 45 minutes per day you have to walk, at least on 5 days in a week. The salt restriction, less than 5 grams. And reduction in the consumption of highly unsaturated fat, junk food, and ready-made food, all that. These are all recipes, nice recipes for inviting diseases. So that is number one. Number two, early diagnosis and treatment of hypertension and diabetes is very important. Obesity prevention. Almost every adult in the middle class, the so-called upper middle class of India, is obese or overweight. Very unfortunate. And then avoidance of unnecessary drug consumption over the counter, without any prescription, without any proper advice. Okay, just listening to some advertisements and attractive advertisements, taking some healthy, so-called health drinks and so on. All these things have to be avoided. Next slide. Yeah. So when I talk about the hypertension control and diabetes control, so there are many people who just remain unaware that they have these. Number one, those who are diagnosed with hypertension, diabetes, also majority of them, they don't follow treatment regularly. And even those who are taking treatment regularly also, their BP and sugar are not appropriately controlled. So where do we stand? In Tamil Nadu, recently, the government of Tamil Nadu has initiated a very important program, Makkalai Thedi Maruthuvam in Tamil. What does it mean? Like, to enhance the adherence to antihypertensives and antidiabetics, there is a mechanism of delivery of these drugs at the doorsteps of these patients itself. Okay, that is the initiative of the government. So they target glycemic control. HbA1c should be less than 7. In young people without comorbidities, even you can attempt 6.5 if they tolerate without hypoglycemia. Number one. Number two, hypertension control. Even though the international standards, they say it's less than 120/80. That target you can achieve in young people who tolerate it, but ideally it is less than 130/80. So for hypertension, for diabetes control, you prefer a new class, relatively new class of drugs, which is there for about a decade, SGLT2 inhibitor, sodium glucose cotransporter inhibitor, SGLT2 inhibitors is drug of choice. It is included as, along with metformin, it is included as a first line therapy. Why is it so? Next slide, I'll show it to you. Similarly, previous slide. Yeah, previous slide. Still not complete. Yeah. You prefer the ACE inhibitor or ARB for hypertension control. And again, I'll tell about that later as to why. Then the dyslipidemia correction. The LDL cholesterol has to be less than 100 milligram per deciliter. The protein restriction in the later stages of CKD, not in the earlier stages of CKD. Alkali supplementation, you might have seen the sodium bicarbonate. The sodium bicarbonate prescription in all the patients with CKD. So to correct acidosis, that will prevent the retardation of progression and avoidance of nephrotoxins. These are all the secondary prevention measures. Next slide, please. Next slide. Yeah. Let me elaborate on this. I've already mentioned as hypertension, hyperglycemia, and proteinuria. Proteinuria per se can promote progression of CKD. So a drug which you select should have anti-proteinuric effect as well. Okay, that's the idea. On the previous slide. Previous slide, please. Yeah. As I've already said, obesity, how does it contribute for all these problems? Obesity, sometimes that is the starting point for all these problems. When there is excess fat, particularly in the abdominal adiposity, central adiposity, that causes insulin resistance, which results in hyperinsulinemia. Hyperinsulinemia affects the endothelial function. That initiates the disease, vascular disease, and then that releases a lot of cytokines as well. Increased aldosterone production that contributes for chronic kidney disease. And that leads on to hypertension. So diabetes, hypertension, cardiovascular disease, chronic kidney disease, the starting point is obesity. Not just that. Most of the, and another important disease that remains underdiagnosed is obstructive sleep apnea. My humble kind of request to all the attendees of this lecture, please have an index of suspicion on OSA, obstructive sleep apnea. Any patient coming to you with a protuberant belly, he says extreme fatigue, uncontrolled hypertension, feeling fatigue, always tired. Please ask one history. Is there history of snoring? Gurakalunaya. And then daytime somnolence. If it is so, please ask for sleep study. If it is a severe obstructive sleep apnea, they have to undergo the CPAP therapy. With CPAP only, they will be able to go for walk and all that. A person with severe OSA with sleepiness, somnolence, there will be a tendency for fall. You can't advise immediately to go for walking and all that. So please identify this. It remains an underdiagnosed entity. Please have a low threshold for asking for sleep study. And this obstructive sleep apnea per se can contribute for resistant hypertension, pulmonary hypertension, ventricular arrhythmia, sudden death, and progression of CKD and CVD. Then smoking. Smoking and the addiction drugs, all those have an impact on the CKD progression. And infections, particularly the uncontrolled diabetes, you might have come across acute pyelonephritis, even emphysematous pyelonephritis, and they can worsen the kidney failure. And then periodontitis. This is again underdiagnosed. The reason knowledge is that a dental checkup has to be done. Even asymptomatic periodontitis has to be treated. It has got a link with that accelerated atherosclerosis and progression of CKD. And always encourage people to check BP. With a BP apparatus at home, with a modern automatic machines and so on, oscillometric machines, home BP monitor. Why? Because a single reading in your office and clinic is very difficult to kind of devise a good prescription. And where there is a wide swinging of blood pressure, go for ambulatory BP monitoring as well. Similarly, you encourage home CBG monitoring for blood glucose, better blood glucose control. Next slide. Next slide, please. Yeah. So this is a newer terminology, CKM syndrome. C stands for cardiovascular disease, K stands for chronic kidney disease, and M stands for metabolic syndrome. All these are linked together. So any therapy which you initiate should be able to address the metabolic factors of obesity and hyperglycemia, the cardiovascular risk factors for hypertension and dyslipidemia, and then the chronic kidney disease. So what are these drugs? These are the drugs, the 4 classes of drugs are very important, particularly for person with diabetes and so on. The RAS inhibitors, SGLT2 inhibitors, aldosterone antagonists. Actually, spironolactone is very inexpensive. I'm a great promoter of spironolactone. And the reason one is a non-steroidal aldosterone receptor antagonist, that is a finerenone, that is supposed to be a wonderful drug in mitigating the mortality and morbidity. And the latest to the addition is the GLP-1 receptor agonist. And now there are more and more of experience coming up with this drug that is supposed to causes a weight reduction, better glucose control, and also it brings down the cardiovascular morbidity and mortality and progression of CKD as well. Next slide. Yeah. So let me talk about XGLUT inhibitors. You all know, so that empagliflozin, empagliflozin, and so on. Why we have to prefer? Why is it brought along with metformin as a first-line antidiabetic drug? This is supposed to be kind of renoprotective. You all know the first stage of diabetic nephropathy, there is intraglomerular pressure and hyperfiltration. So this intraglomerular hyperpressure, increased pressure, that itself is induce the glomerulus later on. So it brings down the intraglomerular pressure. How does it act? Next slide. Next slide. Yeah. So it causes SGLT2 inhibition. Next slide. You keep on clicking. Yeah. So it blocks the reabsorption of sodium and glucose. So there is more sodium at the early distal tubule. That stimulates that stimulates the macular densa, and that liberates adenosine. So that brings down the intraglomerular pressure, reduces the GFR to start with. So the early stages, this is the mechanism of action of SGLT inhibitors. But SGLT inhibitors are effective up to the GFR of 25 mils per minute. So how does it act? Next slide. Yeah. The multiple mechanisms by which the SGLT inhibitor is not only renoprotective, also cardioprotective. How? It brings down the blood glucose level. It is anti-inflammatory, anti-fibrotic. So when so much of glucose is excreted in the urine, the body relies on the fat for energy. So there is lipolysis, increased free fatty acid, and that produces mild amount of ketone bodies, and mild ketonemia is supposed to be organ protective. And reduction in the weight, and reduction in the lipid composition of the kidney, reduction in the epicardial fat composition, and also brings down the uric acid level. And it does not increase the sympathetic activity. So by all these mechanisms, it has been proved beyond doubt by multiple studies, SGLT2 inhibitors are not only anti-diabetic, but they are renoprotective and cardioprotective. But at the same time, a word of caution, you should not prescribe SGLT inhibitors in persons who have suffered an acute pyelonephritis. Number one, you should be monitoring for urogenital infections. Number two. Number three, if there is a dehydration, the patient should consume adequate water and stop temporarily both RAS inhibitors, AC inhibitors, ARBs, as well as SGLT inhibitors during acute stress and perioperative period and acute infections. And those who have severe peripheral vascular disease, please don't prescribe SGLT inhibitors. Next slide, please. Yeah. So how to prescribe? You all know, but it's a very important slide again. How to prescribe AC inhibitor ARB? AC inhibitor ARB also they are antiproteinuric, anti-inflammatory, anti-fibrotic. But how to prescribe? There are two absolute contraindications. One is pregnancy, because it can cause filtral amylase, and then bilateral renal artery stenosis. Whenever you start ACE inhibitor or ARB, just have a baseline serum creatinine and serum potassium. If the serum potassium is more than 5.5, please don't prescribe. Wait for some time, redo potassium, and only if it is less than 5, you have to start. Otherwise, don't start. Then you start ACE inhibitor or ARB, and then recheck the potassium and serum creatinine after 7 to 10 days. What will happen to serum creatinine? It will increase. That is how this drug acts. But the increase should not be more than 30% from the baseline. If the increase in serum creatinine is more than 30% from the baseline, withdraw or reduce the dose. Probably you may be dealing with a person with renal artery stenosis. Okay. Next slide, please. So this is what we have published from Madras Medical College. Actually, this news has to spread very, very widely, the guidelines on management of early stages of CKD. Because not early stages of CKD, the general physicians can jolly well manage. So we have just devised a very simple protocol and the do's and don'ts for management of CKD, particularly with retardation of progression measures. Next slide. Next slide, please. Yeah. As I've already said, early detection of diabetes and hypertension is very important. Near Chennai, we detected a CKD hotspot, a Sengadu village near Kanchipuram. Under the leadership of our dean, the entire team of nephrology and community medicine went to the village, and we screened the entire village for CKD, and we picked up early CKD. This is what my request to IMA, all my brothers of IMA across the country. Please indulge yourself in, focus your activities on CKD. Already you are doing, but please enhance that. Next slide. Right. So this is, and as the disease progresses to stage 3 to 4, there will be volume overload, there will be exacerbation of hypertension, and you have to be carefully watching potassium because hyperkalemia will happen. acidosis will worsen. There will be hypocalcemia and there will be hyperphosphatemia. So volume overload, hyperkalemia, acidosis, hypocalcemia, hyperphosphatemia, anemia. All these things have to be managed accordingly. Next slide. Next slide. Yeah. At the tertiary level, the promote kidney transplant, where the patient reaches end-stage kidney disease. Either the patient has to go for dialysis or transplant. So dialysis, there are two types of dialysis. One is hemodialysis, the other one is peritoneal dialysis. Encourage CAPD because hemodialysis is not environmental friendly. There is huge amount of water is consumed. A lot of biomedical waste is added. There is power consumption, and the man hours and man days of the patient is lost. Okay, so encourage CAPD. And no need to, based on just serum creatinine, you need not initiate dialysis very urgently. You create a fistula and make all the preparations, and as far as possible, delay initiation of dialysis. So that's very important. That's how I practice. And there's something called incremental dialysis. To start with, patients may not require 12 hours per week, may not be required. They may just require a dialysis session once in 4 days or 5 days and so on. So these are all the measures by which you are kind of making a dialysis therapy eco-friendly. Next slide. Next slide, please. Yeah. So again, transplant. There are two types of transplant. One is the living donor transplant and the disease donor transplant. I'm the member secretary for the disease donor transplant program. Please promote disease donor transplant in Andhra Pradesh. Also is doing well now. Actually, nobody should die on the road or prematurely in any family, but as long as such deaths do happen, the organs should not go wasted, and from each donor there can be 7 or 8 fellow countrymen afflicted with organ failure. They can get a second lease of life. So promote disease donor. Next slide. Next slide, please. Yeah. So as a primary care physicians, when you are supposed to refer a patient with CKD to a specialist. So this is the guide for that. As you can see here, even in stage 1 itself with a normal serum creat also, if the severity of proteinuria is A3, a severe proteinuria, more than 2+ dipstick proteinuria, please refer to a nephrologist. And as you can see here, this guide gives us to up to how long you can retain and treat with all the measures I've described in your own setup, and when to refer. Any significant proteinuria, any rapid progression of kidney failure, any kidney failure, any CKD for more than stage 4 and 5, don't retain with you because there are so many other things that have to be done. In the initial stages, you can just adopt the guidelines and you can jolly well manage. Next slide. Right. So this is the final slide and some important messages, and I would like to reiterate the screen for diabetes and hypertension CKD. Screening for CKD is very simple. Just check blood pressure, do a urine dipstick, and look for presence of RBCs and protein. And then do a simple serum creat. Apply CKD-AP formula, you get eGFR. That's all. Very simple, very inexpensive. And again, those who have suffered an episode of acute kidney injury, even if they are discharged with a normal serum creatinine, periodically they have to be monitored because they are at a high risk for going in for CKD later on. And achieve BP and sugar control. Please focus the target. It's not just enough if you treat. And then prefer ACE inhibitor ARB and prefer SGLT inhibitors. And a healthy lifestyle. And my young people, please sensitize them. There is mushrooming of the gym centers where they consume a lot of creatine powder and very high protein. And this combination of high creatine powder plus high protein, many of them going for kidney disease. And non-steroidal anti-inflammatory drugs, proton pump inhibitors, they are supposed to be in a vulnerable person. Long-term proton pump inhibitor per se causes CKD. So your prescription of omeprazole, pantoprazole, there should be a justification. Without justification, don't ever prescribe PPI. And aminoglycosides, again, judiciously you have to use. And avoid drugs of unproven benefit, because the patients with CKD, they have to be, the entire family suffers because of economic constraints. And whatever prescription you give, that should have a very strong scientific basis. Nowadays, it's very common practice to prescribe N-acetylcysteine, keto analogs of amino acids and probiotics and so on. I don't have anything against these drugs, but these drugs have got very, very little evidence for benefit. So avoid such drugs, okay? Then what will happen? the focus on the more important drugs gets diluted. And a very strict advice about smoking. Many times we don't ask the history of smoking. Please ask for this thing, and then some unhealthy drugs and unproven drugs, traditional drugs, which may be nephrotoxic, that has to be avoided. And last but not the least, obesity. That is a major pandemic now. And beware of obstructive sleep apnea. And if you don't correct obstructive sleep apnea, you can't prevent rapid progression of CKD and cardiovascular disease risk. So thank you so much. Once again, I profusely thank the team, IMA of Nellore, and all the dignitaries of Andhra Pradesh Medical Council and so on for this opportunity. Thank you so much.
Thank you, Gopal Krishnan sir, for wonderful presentation. Now I would like to introduce about the next speaker. He is Dr. Rehan. I am very much pleased to give introduction about Dr. Muhammad Rehan Saeed. He is graduated from prestigious Madras Medical College in 1994, and he got his general surgery DNB degree in 1998 from Madras Medical College, and he completed FRCS from Royal College of Surgeons from Edinburgh University, and he completed DNB in cardiothoracic surgery from Apollo Hospitals, Chennai, and accomplished fellowship in adult cardiac surgery from Boston University in 2004. And in 2005, he got fellowship in pediatric cardiac surgery from Boston Children's Harvard University. And in 2006, he got fellowship in heart transplantation and artificial hearts from the Cleveland Clinic Foundation, Ohio. He worked from 2006 to till today in various corporate hospitals in Bangalore and Chennai. And he is the founder of Motherhood Group of Hospitals and Vellotree Nutrition Project. And he is main host for talk show, and he is the creator. He is a well-known in minimal access cardiac surgeon in India. Thank you, sir. Dr. Rehan, sir.
Thank you, sir.
Yeah, you can proceed with your topic, sir.
Yeah, I'll just share it.
Sir, 1 minute.
Dr. Rehan, sir is going to give oration on behalf of Dr. Karimulla Garu.
Sir, go to the first slide, sir.
Yeah. Right. Good morning, everybody. At the very outset, I'd like to thank the IMA for giving me this opportunity, Dr. Ashok for looking at and giving me the privilege of delivering this oration. It's truly an honor to be here. I'm here to talk about minimally invasive cardiac surgery, a game changer. It's not a myth, a reality in today's world. For all of us, we would have had many family members who have undergone bypass surgery, and CABG with the traditional surgery is a long surgery with an incision of around 18 to 25 centimeters, a full sternotomy. Initially, it was done on pump, then we started doing off pump or beating heart surgery. And this surgery has a 2 to 4% incidence of wound infection, a lot of pain. Most patients struggle for at least 2-3 weeks or even sometimes more than that after the operation. Average hospital stay is in the range of 7 to 9 days. The blood transfusion rate is very high and there's very poor patient compliance. These are the incisions that we deal with, standard median sternotomy. That's what it looks like. We have then moved on in 2006 to a mini sternotomy, and that's the mini sternotomy incision. So it's only a lower partial sternotomy. I'll show you a video as we go along. Now we don't do sternotomy at all. We just do thoracotomies, and that's the incision for a thoracotomy. So this is sternal sparing operations. In some cases, if required, we even do a subxiphoid approach.
So the new choices for patients to have are number one, mini bypass surgery, small 5-6 centimeter incision, lower partial sternotomy, less than 1% risk of infection, low pain scores because the manubrial sternal angle is spared, average length of stay of only 4 to 5 days, and in some cases even 2 days, much lower transfusion rates and faster recovery, overall a better compliance. If you compare the incisions, you can see clearly that that's a pretty long incision and this is a much smaller one over here. And that's the operation, a short video of it. We give a paravertebral block for pain relief, and this also reduces the requirement of the anesthetic agents. That's the length of the incision. We make a sternotomy, lower partial sternotomy to the left side first. And then we will harvest the lima or the left internal mammary artery as usual in skeletonized fashion. You can see the heart beating over there. Then if you want to do a bilateral mammary, you can tee the incision to the opposite side and then harvest the right internal mammary artery also the same way in skeletonized fashion. By doing this, you're providing this patient a total arterial revascularization, which has much more longevity than doing a vein lima with veins or just a vein bypass. As you can see in the video, the visibility is outstanding. You can access all the vessels. That's a lima to LAD reconstruction. Here I'm using a vein graft to the ramus intermedius to show that even a vein can be used and this operation can be done safely even with a vein bypass in place. That's the right internal mammary artery, and that's going to the distal RC or the proximal PD. So we can go as far as the inferior surface of the heart quite comfortably. Even the aorta is quite visible to us. As you can see here, I'm doing a vein top end to the aorta, and with the help of certain maneuvers, you can access the aorta quite well. Through this approach, we are able to do just independent CABG, or you can even do a CABG plus mitral valve. You can do double valves. You can do a mitral plus tricuspid. So multiple operations can be done through this approach. Our experience on bypass surgery for these patients is quite large. We've been doing it since 2007. It's almost 2,000 plus cases. We average around 4 grafts per case. Our incision is around 6 centimeters. 98% of our work is done on beating heart. Most of our work is slowly moving towards total arterial revascularization. Our average length of stay has been 4 to 5 days, and we use just Dolo 650 3 times a day or maximum Proximon if the patient is very fussy. And this paper was awarded a Young Innovator Award at the SPICS at 2012. Today, we have stopped doing sternotomies completely. We've gone to doing sternotomy approaches, thoracotomy approach. We do a left thoracotomy, and through that, we do all the bypasses. And I'll show you some videos on the same. So this is a multi-vessel bypass. So through this small incision of 2 centimeters with much shorter hospitalization stay, very little blood loss, thereby hardly any transfusion given, much faster recovery. The patient can return to work in 10 to 15 days. No wound infection, no lung infection. That's your incision in compared to a sternotomy incision. So that's a small incision through which we do this. You can reconstruct the same thing like I mentioned, a proximal anastomosis. So you can do every operation the normal way. If you want to, if you're comfortable using vein grafts, you have to, you can. But that's the size of the incision. And that's what it looks like after 2 weeks. So, should display. This is us reconstructing the Lima radial Y. And that's the flow on the radial after the anastomosis. And suppose you are short of conduit, you don't need to go and take or do something different. You can take a small bit of vein and extend the lima and the radial anastomosis, and you can get again a long length of conduit. The advantage of this approach is that you don't touch the aorta, and because you don't touch the aorta, you will not have a risk of stroke from the procedure. So you're thereby eliminating 2 to 3% risk of stroke from not handling the aorta. And this approach is called an aortic approach. Our experience in this has been over 1,500 cases, and now it's continuing to increase. It's 95% of our work is total arterial revascularization. We've been lucky to have a very low mortality of 6 patients. We've had some graft failure in the early period, but nothing of late. We believe in doing check angiograms for most patients because we're running a study group also. We do one at 1 year, one at 3 years, and our first 500 have all got check angios. We have averaged 3.6 grafts, and our A loss is in the range of 4 days. Sometimes when they're very fragile patients and we know that they can't tolerate full surgery and they need a very small approach, then we do a TCAP using a robot where we do a Lima to LAD. And sometimes we may take a RIMA and do a Y graft only to the diagonal and leave the right coronary artery to be stented by the cardiologist. This hybrid approach is very good for them because you don't put them through a prolonged anesthesia time, and we finish the left grafts with arterial grafts, and then we take them to the cath lab the next day. We can check our grafts, and then we can also do the stent. So it serves both purposes. You validate what you have done, and also you are able to get them stented. So we did a QOL, a quality of life comparison in patients with post MICS surgery, conventional bypass surgery, and post PCI. And mixed approach is equal to and superior to is equal to PCI and superior to conventional CABG in the quality of life scores. And this is clear that this is the way forward. It is the average length of stay is only 2 days more than a patient for PCI, but the long-term durability of these operations are far ahead than the stenting, especially because we're doing a lot of total arterial revascularization. But CABG is not the only thing that we do with minimally invasive approach. We also do minimally invasive valves. Almost 100% of our valve work is done through minimal access work. We have stopped doing the sternotomy approach at all for valves. So today we do valves through either a upper partial sternotomy or a lower partial sternotomy like the video I showed you. But majority of our valves, almost 90% plus, are done without a sternotomy with just a thoracotomy approach. So if you take an aortic valve, you can go through upper partial sternotomy. That's the vision that you will get on an aortic valve. The tissue valves, we prefer tissue valves in those above 50 years of age because there's no need for anticoagulation and thereby preventing any anticoagulation-induced complications. And if you look at the patient, that will be the size of the incision for a aortic valve. So this is how it can be done. We do a femoral cannulation. Under TE guidance, we are able to place the cannulas perfectly. And you make a small incision, which is around a 5 centimeter incision. And through that incision, you can identify, we're just opening the pericardium. You can see the aorta. Now we've opened the aorta and you're decalcifying the entire aortic valve. In this case, I think I used a mechanical valve because it was a young patient. And that's a mechanical valve in place, tilting this mechanical valve. And then you close. So this is a right thoracotomy, right anterior thoracotomy approach. And you don't need to cut the bone at all. That's the length of the incision. We do mitral valves exclusively robotically and endoscopically. We do not do sternotomies for mitral valves at all. And we are a center of excellence for valve repair surgeries. We repair a lot of valves. So this is one video of valve repair surgery. And that's the kind of exposure that you will get. That's the size of our incision. That's the aorta getting clamped. And now I've opened the left atrium. And you'll see the mitral valve. That is the mitral valve. I'm now closing the left atrial appendage to avoid any embolization from a clot formation in the left atrial appendage. You can see the mitral valve clearly. Sometimes, as we know in rheumatic heart diseases, the left atrium is very grossly enlarged. So if it is like very large, like a giant LA, then you can also reduce the size of the posterior wall of the LA by doing that suture that I just did. Now we go on to examine, this is a rheumatic valve. As you can see, it's quite thickened, it's rolled up, and then we inspect the valve to see if there's any prolapse or there is anything else. Once you finish the inspection of the valve, that's the inspection of the posterior leaflet. That's the posterior leaflet of the valve. And then you can take the ring sutures. This is to place the ring in position. And I have basically thinned out the valve completely. I'm checking to see if I've got enough coaptation on the valve. As you can see, this valve now looks quite thin over here, like glistening appearance. And I've got a reasonable thing. I'm further debriding the posterior leaflet and making it thinner. So because in rheumatic heart disease, this fibrous tissue sits on it. So if you remove the fibrous tissue, the whole leaflet becomes quite pliable. And once it's pliable, you measure what ring you need, and then you can put the ring down through that small incision. Today, we do a lot of these repairs through a robotic approach. I'll show you some pictures on the visibility. You've seen the visibility in an endoscope, but you really have to see to believe the visibility through a robotic approach. The magnification is outstanding and the clarity is also amazing. So once you tie the ring down, and that we use a knot pusher to tie it down, and then that's the ring that you have in place. We also do double and triple valves through the same incision. And that's this is a triple valve procedure for a patient who required redo kidney transplant, and he had multiple valve lesions. So I did him through a right anterior thoracotomy. You can see that visibility is quite good. What you're seeing inside over there is the right atrium. And once you go on femoral bypass, the aorta gets pretty well seen. Yeah, so the aorta and the RA both are in the field. You can see the aorta, the right atrium. You can see the aorta quite considerably. So doing a cardioplegia purse over there. Visibility is not an issue. Actually, I like what people think. It is just that one has to be used to doing this procedure this way. In fact, I'm in putting an SVC cannula through that small incision itself because I would like the SVC to be drained well, keep the heart empty, giving me even more space to work within inside. So you can snare it down, and so you can do multiple procedures through this approach. We get a chitwood clamp from the side. I think it's gone to the next slide. 1 minute, I'll go back over here. So this is a core knot. I just wanted to show you. This is a device where you don't need to tie your knots down. You just take the suture down. You park it there. As you can see, that's a mitral valve that is sitting inside. And then you just fire it. It has a little silicone tip and leaves. It's like a knot being tied down. This is the aortic valve that you're seeing. And we are replacing this aortic valve with a tissue valve. So today we can do multi-valve operations through these small 6-7 centimeter incisions, which are non-sternotomy approaches to be done. Talking to you about mitral valve surgery through a robot, I just showed you the endoscopic approach 2 slides before, but you can now compare that to the robotic approach. That's the robot. That's my hand using the robot. And the beauty of this is the visibility. We use Gore-Tex sutures. And the advantage of Gore-Tex sutures is that they are easy to pull through and slide. And they're also a little bit easier to handle. You can use Prolene if you would like to, but it's much easier. This video is on a little, I think, 2x thing. I don't move that fast in reality, but it's not very slow either. So that's the left atrial appendage being stitched, and that's the mitral valve in the visibility also. Now I'm putting a ring to the mitral valve, and so you can see that quite well. This is the advantage of the robot because you can take a bite in any which angle you want. There is no problem. It's 360-degree dexterity. And it's so much easier to work in the depth because you have the freedom of movement. So that's the analysis, and that's how I'm putting the ring back together. So we do 100% of our isolated aortic and mitral valves through a minimal access and robotic approach. We also do double valves or valve cabbage through these approaches. We have pushed the limit so far that we even doing aortic root replacement like Bentall procedures and aortic arch replacements also through this upper hemi sternotomy approaches. So where are we today? Endoscopic heart surgery is a reality. Robotic heart surgery is a reality. We even do this for ASDs and I think this is an ASD which we have done, a sinus venosus ASD. Through this approach, through an endoscopic approach. This is the SVC end. You can see the CVP line come in. And then that's the big defect that is present over there. You can take the stitch accurately so that you don't avoid the any narrowing to the SVC. This is not possible when you do it with a sternotomy approach because you have to look over the sternal edge and try and see it. But here the visibility is outstanding, and I'm putting a pericardial patch to close the ASD in place. You can see the patch once it's sutured. We check for leaks. There is no problem with it. And then we close the right atrium and come off bypass. So we also do, like I said, aortic surgery through this. We do single stage hybrid frozen elephant trunks, minimal access hemi arches, and aortic valve sparing procedures. We have started doing VADs. We normally do VADs through a full sternotomy, but we have now initiated the VADs also through an MICS program through a thoracotomy approach. So why MICS? Because we at Polo Chennai, we have very large experience of this. We have less than a 0.5% rate of transfusion and infection. We have had only a single case of sternal dehiscence because it's only a partial sternotomy. Our oldest is an 88-year-old and our youngest is an 8-year-old. An average length of stay is 4 to 5 days. Average pain score is much less than 5. Return to work in 2 weeks. No sternal precautions needed. So why do we even think of looking at sternotomy as an option today? I think it is unfair to tell our patients that sternotomy is the treatment of choice. I think we should seriously look at avoiding sternal incisions and go to non-sternotomy approaches because they have stood the test of time. There's long-term data now on this, and everyone is slowly in the Western world moving towards that. Thank you. Hello?
Yes, sir. Just a moment, sir.
Madam వచ్చారా? Good evening, madam.
Yes.
Good evening,
Good
madam.
afternoon,
Sorry, good morning, madam. Thank you very much for accepting our invitation and participating in this today's webinar, madam. Even with your busy schedule, Dr. Radhika Reddy, she was associate professor at Siddhartha Medical College and also at Guntur Medical College and also professor of and HOD at Siddhartha Government Medical College. Now, presently, she is the registrar of AP Medical Council. Presently, she is registrar of Dr. NTR University of Health Sciences. May I request, Madam is today delivering Dr. O.M. Baer IME Efficient Oration. This oration has been installed in the name of Dr. O.M. Baer, who was the founder of the BC Hospital at Nellore, and she was alive till last year, and she died in America only last year. She was doing a lot of service to the community. Thank you, madam. May I request you to kindly deliver your oration, madam.
Thank you. Thank you,
Thank
sir.
you.
Thank you for a nice introduction of me. Let me share the first. So, I'm Dr. Radhika Reddy. I'm professor of psychiatry.
Ma'am, can you go to the slide mode, ma'am? Yeah, slideshow.
Yeah, 1 minute. Yeah, 1 second.
Yes, ma'am.
Yes.
Yeah.
So I'm Dr. Radhika Reddy. I am from Vijayawada. So I worked as professor of psychiatry, and then at present I am working as registrar for Dr. NTR University of Health Sciences. Today we have selected a topic which is appears very simple for a general practitioners, and it's a very common problem. And every day to day in your practice, everybody will be seeing some mood disorder patients for sure. So these are very, very common diseases. If you see 3 people are there, one among 3 will have a depression. So that is how it is, the depression. So the lifeline prevalence is more than 20%. And you know, the morbidity and mortality of this problem is very high. So the first change in these disorders, as the name suggests, it is the mood of the person. Usually there will be a lot of changes, that is either depression or elation. So we have a range of mood, like sometimes you feel little low, sometimes you feel little high or so elated, or you appear very happy. So when it is for a period of time, then only we call it as a disorder. So these disorders are all lifetime disorders most often. So they are recurrent also. And there are many types in this. So either unipolar, you can say, or bipolar. Most of the time, the depression is very common in these disorders. And there is another term called mania. So in olden days, we used to call it as MDP, manic depressive psychosis. But the names are changed, and now we call it as bipolar mood disorder. So if you see the classification, you have a number of the international classification. You have single episodes or bipolar disorders, only depressive episode or recurrent depression, persistent mood disorders, and unspecified disorders. So there are several test methods to see, to diagnose otherwise. So these are all simple scales. Just the physician can also interview through these scales, and there are some self-reporting scales also. To diagnose mania, there is YMRS, and for depression, Beck's scale and Young scale. And with Hamilton's scale, most of these scales are very simple scales, and a few questionnaire will be there, and it is easy to assess also. Why? Because in our OPDs, you see many patients who come with vague symptoms, and most often you try to diagnose them as with somatic complaints. You diagnose them as some anxiety disorders also. But it is better to have sometimes these scales also. And I will just go through all the just to enlighten you about the common and the criteria of diagnosing depressive episode. Though you can, when a patient comes to you, they may not tell you that they are having a sad mood. So they may give you vague complaint like I am having pain here and there, or I am not sleeping, or they may relate it to some other life event also, like they are having some problem at home, or there is some financial issue, something like that. But you can just ask these kind of questions so that it is easy to diagnose depression. First one is the depressed mood, and whether there is lack of interest in day-to-day activities. Just asking them whether they are able to do all their routine work. For a housewife, the routine work. For an employee, whether they are really interested in their job, whether they are completing their day-to-day tasks or not. and they become more fatigued with normal work also. So the activity comes down. So there is reduced energy. So that is the reason there is increased fatigability. And there is lot of tiredness with simple things also, they become more tired, and the concentration is low and attention is low, and the self-esteem, self-confidence comes down. And sometimes there may be ideas of guilt. So they feel bad that they have done something wrong, and they may feel that I am not really worthy, I am worthless, I am helpless, I am hopeless, and they think that people are not really um, caring for them. So this kind of negative connotations will be there, and there is a pessimistic view about all the future and other things. And there are ideas of self-harm. So when the depression is increasing, in severity of depression, you see ideas of self-harm, or sometimes suicidal thoughts or attempts will be there. And the biological activities also come down. So the clinical presentation, there may be marked individual variation. This we have to mind. So in some cases, anxiety, distress, and agitation may be prominent. And in some cases, you may not see all those things. There will be a masked type of depression where you don't find the classical features, and irritability may be there, especially in adolescent college going kids. You can see, or in a teenager, irritability will be there. The sad mood may not be there. You see more of irritability. And there may be the substance abuse may increase in some people. And there may be histrionic behaviors like dissociative behaviors will be there. And the anxiety and phobias, obsessional things may increase. Or sometimes the hypochondrial preoccupation. So that illness, anxiety may increase sometimes. So the depressive episode minimum should be there for 2 weeks. Then only we call it as a clinical depression. If there is, like for example, if there is a death in the family, so that grief, it may last for initially. In that grief, there may be some depressive symptoms. But if it is there for 1 day or 2 or 1 week, we may not call it as clinical depression, and we need not give medication for that. So the lifetime prevalence of any depressive episode is 17%. See, nobody is immune to this, like fever. Depression is a very, very common, and it can recur also. So I always tell my patients, like they will ask whether if you are treating for depression, it will not recur again. No. So I just tell it is like fever. So you can get fever anytime. Once if you get fever, you are not immune to fever again. So something like that for depression also. So that mood variation is also diurnal, like immediately after getting out of the bed. So some people are very depressed and very tired, and fatigue will be there. So that can be a genetic depression. And sometimes towards evening they become better, this kind of people. And some cases towards evening they get all these depressive symptoms, and in the daytime when they are active in their work, they may not have that much of mood symptoms. So somatic symptoms again are very common, and you call them as somatic symptoms. So there is another, like these are the symptoms like loss of interest or pleasure in activities that are normally enjoyable. Lack of emotional reactivity. When there is a pleasurable situation, somebody cracks a joke, this guy will not have that thing, emotional reactivity, and he may not react at all. So waking early in the morning, 2 hours before their usual bedtime, that is one. In the symptom, we can ask the person about when they are telling you about their sleep disturbance, we can just ask them whether they are waking up early in the morning than their usual time. So worse in the morning, and there is objective evidence of definite psychomotor retardation. They become very slow. So that psychomotor activity coming down, you can watch, and loss of appetite is there, and weight loss and lack of libido. So these are all the 4 symptoms and a typical depression, you can see all these things. But you can calculate at least few symptoms should be there. You need not have all the range of symptoms in any case. So you can have, see, for a few symptoms at least to diagnose it as depression. And there are many other types of depression depending on the severity, like mild depression, moderate depression, and then some severe depressive episode with psychosis and without psychosis. And why I am telling you this is, so diagnosing depression, and when you are treating that depression, if it is a mild, that is okay. When if we are missing a severe depression, then that will be a problem, because in severe depression, that person may end his life. There may be serious consequences of the severe depression. So this mild, why I'm this mild is all the same, all the symptoms. So when at least 2 to 3 symptoms should be there to say it as mild depression. So the treatment part varies with mild, moderate, and severe. The treatment, the drugs which we have to give, or the counseling or therapies we have to give will change accordingly. So, but if it is a mild thing, there should be at least 2 to 3 symptoms, but the sad mood should be there. So in moderate, if you see, they will have 4 or more symptoms. And there is a difficulty, considerable difficulty in continuing their social work and their domestic activities. And in severe, they cannot do their routine activities. So in severe, again, some are will have the agitated depression, where they become more something like restlessness. There is a lot of self-esteem problems, and the guilt will be more. So this is severe depression. Here you will not have this guilt, like I am very bad, and I am not doing my, I am responsible for the past or something like that. They have those guilt feelings, so they have done something wrong and everything. So then we'll go for symptoms with psychosis. So when there are symptoms of psychosis, you may find delusions. You may find some hallucinatory behavior in them. And sometimes even when it is severe, you can see depressive stupor. In the stupor, it appears like a something like a semi-conscious or unconscious patient, something like that. But all parameters may be normal. They are conscious, but they may not respond to our regular stimuli. So the social activities are impossible, and the psychosis part in delusions. So this depressive psychosis, the delusions are related to most of the negative mind, like they may think that they have done something, some sin, or they think that they don't have any money, or they may hear voices saying or accusing them, and all towards a negative activity. So recurrent depression, this is again very, very common problem, and most often in women we see more frequently. So these suicide rates are very high in this depression. So where you see there are repeated episodes of depression. So why this recurrent depression we have to keep in mind is, so there is difference from my bipolar disorder. So why, when you give antidepressant in a bipolar disorder patient, they may switch into mania. So while treating bipolar or recurrent depression, so that variation should be there, and we have to be keen on diagnosing. Otherwise, if you are giving antidepressants, the patient may land up in mania. And there is one condition called seasonal affective disorder also. So the patient themselves will tell you, like, so in every winter, they become more depressed, and they'll have more symptoms in the mood symptoms in winter months. And once the summer or spring starts, they become normal. There will be some kind of spontaneous recovery also. So this slide, a very important slide and most commonly used by us. So just to understand the severity of depression. So the first part is there is no depression, and as the disease progresses, so within 4 weeks to 6 weeks, so there is a downfall. That means it is entering into a syndrome. So when we start treatment, so there is a response. So like 6 to 12 weeks, there is a response. And sometimes in between also we can have relapses. And they come to a stable stage where we call it as remission. So relapse can occur any point of time, whether they take medication, sometimes without medication, they may go into relapse. Stopping medication before the course also can give rise to relapse. So remission and being stable for 6 months or so, then only we call it as recovery. And again, once again, that patient may have the symptoms after 1 year or so. That is called as recurrence. So this again, recurrent depressive disorder, there are again, we subclassify into mild, moderate and all. Now we'll just I'll brief you about the manic episodes also. So these mania, so there are hypomania, mania with psychosis, and mania with without psychosis, and there are other and unspecified manias. So here in this, hypomania is very common. Again, there is a mild elevation of mood. So mild elevation, you have to recognize this. Why? Because when you are giving antidepressants, sometimes there will be a mild elevation of mood, and they are going into hypomania, and they will not stop the antidepressants because they like it, because being in hypomania is more productive for the patient. So they may resist you or they may not consult you, and they may continue the medication. So knowing about hypomania is also very important. There is increased energy, increased activity, and there are that feeling of well-being will be there, and they are more sociable, they are more talkative, and they visit you more, and over familiarity express all these things. So we have to be little more judgmental while dealing this case. And the severe type is mania, where you don't have psychosis. So at least 1 week should be there to call it as mania, that the elevated mood and increased energy, increased activity, overactivity, there is pressure of speech, there is no need for sleep, and normal social inhibitions are not there. So they are lost. So the attention cannot be sustained, and they pick up cues. They are more distractible. The self-esteem is inflated, and they become grandiose, and over-optimism can be seen sometimes. And these extravagant and impractical schemes will be there. They spend money a lot, and reckless behaviors, aggression, all those things will be there. So when there is psychosis, again, you will find those delusions and hallucinations. Most of them, they are mood congruent, until they go along with the mood, because this fellow his mood is high, so he will have delusions that of grandeur. He thinks that he is a millionaire, or he got a lottery, or something like that. So this is bipolar disorder. So when there is a manic episode, we call it as a bipolar disorder. When there is only depression, there is no manic episode, there is no to understand it simply. So there is no manic episode, more hypomanic episode, only depressive episodes are there. That is recurrent depressive disorder. So when there are at least one manic episode, or a brief period of hypomania also, we call it as bipolar affective disorder. And there are conditions like rapid cyclers, where they get number of episodes in 1 year. So usually mania episodes, bipolar, there may be the gap of episodes can be 1 year to 10 years. Sometimes they get an episode in adolescence, and they come to us after 50, 60 years of age also. So the frequency of episodes, you call it as rapid cycler. So differentiation, why this kind of so much of classification and differentiation is important is the treatment part differs with each type of the current episode. So one more thing is persistent mood, most often seen in women. And this persistence is the day-to-day activity is not disturbed, but continuously there will be some fluctuation of mood. Either they are not significantly severe to warrant being described as hypomania or depression, but at the same time there will be suffering. When it is more than 2 years, then only we call it a persistent mood disorder. And these, when both moods are there, depression and hypomania, you call it cyclothymia. And when there is this cyclothymia is the mood, you have depression and elevation both together. And these are, you call them as mood swings. This word is commonly used, like there are mood swings. And in dysthymia, you see only mild type of depression. They do their all day-to-day activities. They feel more tired. And this is quite common. The people, they come to us and they say, they don't really, they do all the things, regular activities, and they go out, everything they do, but they feel more tired and they really don't enjoy their life. So now we'll come to the depression treatment. So the most common treatment is, and everybody, all the general practitioners or everyone, they are well aware of all the antidepressants. So the only point is, so treating depression should be adequate, and there are number of drugs available. The selection of the drug is important, and adequate dose is important, and the duration is important. So we are giving antidepressant. So within 1 week, there will be some elation of mood, and the person will come and tell you that I'm okay, I'm better. And we can, and stopping will again give rise to relapse. So the duration part, we have to take care, and we have to give adequate strength of drug depending on their weight and their symptoms. So the overall effectiveness of antidepressants is around 70%. And you know, there are the most commonly used ones are serotonin specific reuptake inhibitors. Fluoxetine is there, sertraline, fluoxetine, fluoxamine, escitalopram. Nowadays, escitalopram is very, very commonly used. And there are combination in the market like escitalopram plus clonazepam, something like that. And these are the SSRIs, very, very commonly used. And some antidepressants with broader effects, like they are both useful for anxiety and depression also. They are like SNRIs, serotonergic and norepinephrine reuptake inhibitors, and tricyclic antidepressants. So there is insomnia, you better choose a drug where there is more sedating, like mirtazapine also. So if there is lethargy, hypersomnia, sleeping more and eating more, and there is weight gain. So the SSRIs like fluoxetine will help. So less sedating medication, if for a student, you can go for bupropion, some like that. So there are REMAs which are not really effective, not much popular, and then in refractory patients we can use them. So the drug trials should be last for at least 4 weeks. So within 1 month we cannot change the antidepressants. So if you start with the 20 mg of fluoxetine, so we have to wait for 4 weeks to get the result. Because with all these antidepressants, the effect to plasma concentration reaches by 2 weeks, and the effect will come only after 2 weeks. So there may be some symptom changes after giving the medication, but you will get all the effect only after 4 weeks. So at least wait for 4 weeks. Then only, if it is not working, we can go for either dose change or the drug change. So prior to 4 weeks, we just can't do that. So if there are partial responders, usually the 70-80% symptoms will come down, and later on you may not find that 20-30% change may not be seen. So for such cases, we can give some other co-administration of lithium also. So if there is psychosis, we may have to add antipsychotics. If there is anxiety, some anxiety drug, benzodiazepine can be given for a short period. And if it is first episode, we have to continue the drug for a few weeks and a few months. So minimum of this should be for at least for 6 months. We prefer to give one episode 9 months. When it is a mild episode, we can stop after 6 months. So we have to taper the dose gradually, then only we have to stop the drug. And we have to put them on maintenance if it is a recurrent depressive disorder. So people may ask, the patients may ask us why there is no depression, why you are continuing the medicine. So if it is recurrent depression, it is better to continue on long-term basis. If severe depression, better refer the case to a psychiatrist, and ECTs and treatment of choice when there is suicidal ideation. And in pregnancy, pregnant women, if there is severe depression, so first choice sometimes would be ECT also. And we don't like to give any medication in the first 3 to 4 months of pregnancy. And there are SSRIs are definitely little safer to give if needed. And in phototherapy, sleep deprivation, RTMS, these are all other treatments, alternative methods, and they may be tried, but I'm not sure they will definitely help the patient. But for seasonal affective disorder, the phototherapy is effective. But in regular practice, we never try to give phototherapy. And treatment of mania, there are many mood stabilizing drugs. And when there is a manic episode, so sometimes if the situation doesn't permit to give mood stabilizer, then only psychotic medication can also be tried, like olanzapine or quetiapine. So mood stabilizers like lithium, carbamazepine, sodium valproate, and even topiramate, lamotrigine, these are all the drugs that are used for treating bipolar disorder to stabilizing the mood. And in agitated, if the patient has psychosis, we'll add the second generation antipsychotics like olanzapine, risperidone. Sometimes olanzapine, risperidone alone can also be tried when it is a first episode of mania. And ECT again, when it is severe, we have to take a decision to give ECT. So there are other non-pharmacological methods where people are really very much interested, and they just come to us and to the clinician and say, I don't want to take medication, I just want to have some counseling. So they think that counseling will work for everything, but counseling or these psychotherapy sessions, so not for each and every case, these are helpful, but definitely they have a role. So CBT, which will focus only on negative thought patterns, can be tried, and they are effective in depression where there are more negative thoughts, and also in bipolar. So the coping strategies, relapse prevention, these can be taught, and interpersonal, the family members, relationships can be improved. And sometimes if it is a grief case or a role transitions, so if there is some social conflict, the interpersonal therapy can definitely help. And the psychoeducation to the family about the illness, the course of illness, the symptoms, and the treatment options, all these things can be done. A family focused therapy can be given, focusing on involving all the family members in the sessions. And DBT is one where there is a personality problem also, especially in women. Comorbid borderline personality will be there, where you can add dialectical behavior therapy to them. So these lifestyle interventions, which we have to educate the patient. These are very these are the routine things, but definitely this will help the patient in preventing the further episodes and also alleviating the symptoms. So regular sleep schedule, though they are on medication, if regular sleep schedule is not maintained, so there are cases of relapse. So more avoiding screen time, regular sleep schedule, and these are very much important in preventing the episodes. And regular exercise, and which will boost the endorphins, will also help in improving the mood. And balanced diet, and there are like supplements like folic acid or omega-3 fatty acids, vitamin D may have some mood stabilizing activity. These can also be taken apart from the other medication. And stress management is one thing. Relaxation techniques, deep breathing or progressive relaxation techniques, mindfulness, yoga, meditation, all these things will not alleviate the clinical depression or clinical mania. These are all helpful only to further relapses or to prevent or to give that well-being. But the scientific evidence is there that they will not reduce the clinical depression. So these are all only supportive therapies for the well-being of the person. And these can be used for a normal person also. So that is the case. So encouraging routine and structure in daily activities and occasional rehab and workplace accommodations, all these things has to be done. So brain stimulation, I told you, ECT is one thing. RTMS is one non-invasive strategy and which is picking up nowadays. The evidences are there that this will help, but it is a temporary phenomenon. So yoga, meditation, art, music therapy, acupuncture, light therapy, these are all. So there is evidence for informed use, and these are all complementary therapies. So the key points to note for managing depression is all non-pharmacological treatments are effective in only mild to moderate cases. They are essential adjuncts in more severe cases along with medication. So the patient preference, the cultural beliefs, accessibility, all these should be the intervention choice. So there are few myths about psychiatry which I just wanted to share. So first, so they think depression or mental illness is a sign of personal level. So the fact is the mental illness is a medical condition like diabetes, asthma, or hypertension. There are some internal complex causes for all these diseases. Similarly, mental illness has its own psychopathology within the brain and the genetics and the brain chemistry. So one should understand this, and just because of the personal issues and social issues, one cannot have a mental illness. And psychiatric disorders aren't the real illnesses, but these are all real illnesses. Why I wanted to insist this is, so sometimes we just see patients, those are regularly taking, they are consulting a psychiatrist, and the people saying them like, telling them why you are using this medication. There is no need to use this medication. You can do yoga and all some other meditation. Everything will come down. So they think that they are not real diagnosable medical conditions. So, but all these are real diagnosable medical conditions. So psychiatrists give only medicines to sedate the people. So the point is any drug which acts on the brain, even anti-epileptics or any medication which acts on the brain will have multiple actions. So naturally, they may give rise to some amount of sedation. It doesn't mean that for just sedating the person will cure the illness. So it is vice versa. So you cannot stop them for lifelong. You have to use them. This is another myth. So it's not. It is defined for depression. So 6 months to 9 months. The episode is only 6 months to 9 months. And if it is recurrent depression, we may have to continue for a long time. If it is a bipolar, he may have to take it for lifelong. So if it is a schizophrenia, he may have to take for lifelong only when it relapses. The first episode is only treated for 2 years, even in schizophrenia. So not all medications are lifelong. So talking therapy. So like this, just they go to a counselor or a psychologist, they will talk and just talk and they charge. This is one myth. But there are evidences like this CPT, CBT, DBT, all these are scientifically proven. So they are effective as medications for many conditions. So people are with mental illness are all violent and they are dangerous. Not so. So we most of the time they are more of a like they are victims rather than perpetrators of violence. So they are scary and they are not safe. So these kind of myths are there. It is not true. So modern psychiatric facilities are very safe and ethical. So only crazy people need to see a psychiatrist. It is not so. And the stigma has come down a lot compared to when we joined, we started practicing. In this 30 years, there is a lot of change, and nowadays it has become more, what do you say, a socially accepted thing to consult a psychiatrist. So children are also affected. Children don't get mental illness is not true at all. So in childhood, psychiatric diseases are there. And childhood depression is also very common. As I mentioned, they may not present with a typical depressive symptoms, clinical signs, as I mentioned. They may present with, especially children, they may present with more irritability and a behavior issue than the typical depression symptoms. So cannot be treated. It's lifelong. It is not so. There are most often they are episodic, and the episodes can be resolved with appropriate and adequate treatment, and it is not for lifelong. So 5 to 10% cases where they require lifelong treatment. So the conclusion is we have to break the stigma, and it is the role of clinical practitioners also. So to reduce the stigma, and there is nothing wrong in consulting a psychiatrist or a doctor for their mental health problem. Yeah. So thank you very much for giving me this opportunity. And I also thank the organizers, the IMA Nellore branch for conferring me with this OM Boher IMA AP State Oration Award. Thank you very much. And I also thank the organizers, the IMA Nellore branch for conferring me with this OM Boher IMA AP State Oration Award. Thank you very much.
Thank you, madam. Thank you very much for giving, for delivering the Dr. O.M. Baer IMAAP State Oration for the year 2024.
Thank the organizers, the IMA branch, conferring me with this OM Boher IMAAP Oration Award. Thank you very much.
Thank you, madam. Thank you, ma'am.
Sir, please unmute, sir. Yeah.
Thank the organizers, the
Thank you, madam. Thank you very much, madam. The next speaker is Dr. Raghavan Garu, who is a consultant uro-oncologist from Apollo Hospitals, Chennai. I will be giving a brief introduction about him. Dr. Raghavan Garu, he has done MS FRCS from Edinburgh MD FRCS. He is an adjunct professor of uro-oncology, Tamil Nadu, Dr. MGR Medical University, and AHERF, Senior Consultant Uro-Oncologist, Apollo Hospitals. And he is an alumni of PGI and Royal College of Surgeons. He was a consultant uro-oncologist at Bradford University, teaching hospitals. Currently, senior oncologist and lead clinician, uro-oncology and robotic surgery, Apollo Hospitals. He has published more than 50 papers in international journals, performed novel and pioneering works in robotics in South India. Under his cap, he has many awards and honors and grants. Best of BAUS, poster number 90, Manchester 2006. Best Poster Award, Poster Session 37 at EAU 2005. Best Young Scientist Award 1993-94 State Medical Council for Science and Technology. Gold Medal in Surgery 1993 SRMC India. Gold Medal in Anatomy 1990 SRMC India. Grant for Fellowship from Prostate UK. And here I present Dr. Raghavan Garu, and he will be delivering Dr. K. Rajamma oration on uro-oncology and robotics for general practice. Thank you, sir, and I welcome you to this CME, sir.
Thank you so much. It's a pleasure and honor to be with you all. I immensely thank IMA Nellore and Apollo Hospitals for giving me this opportunity. It's a pleasure to deliver an oration. It's not, it's a honor, more than pleasure. It's a honor to deliver an oration. And to that end, I'm extremely grateful to all of you who have considered my name for this oration. Thank you so much. As doctors, in India, we do a lot of talks. We deliver a lot of talks in various forums and platforms. The one platform I love to talk is IMA. The reason is IMA is a group of doctors, most of them specialists, be it cardiologists, neurologists, or surgeons or whatever. But all of us in India are at heart are general practitioners. We are all general practitioners because I am a general practitioner when it comes to cardiology. I am a general practitioner when it comes to neurology because my relative is going to ask me, who am I supposed to go? What am I supposed to do? And I'm supposed to guide them. They don't understand that I am a specialist in any way. They think that I know everything and I have to answer the questions to them. IMA is a platform which allows us to understand what's happening in other domains. For example, the talk which I was listening to from ma'am was absolutely enlightening for me. So which made me understand a lot of things which will help me to translate to my patients as well as to my relatives. Hopefully, my talk will also be doing the same to you all. And with that hope, we'll start the talk. Today, I chose to deliver a talk on uro-oncology and robotics. It sounds superfluous. It sounds amazing. But trust me, all of you, if you close your eyes and think about it, every one of you would have had at least one relative who is affected by something to do with urinary tract. Inevitably, a cancer related to urinary tract. Be it bladder, be it prostate, kidney, anything and everything. One relative of yours would have been that way, at least. So how are we going to guide them? What is that we're going to tell them? And how are we going to counsel them? That's where this talk is pitched to. I'm not here to make you an expert in uro-oncology, but I'm here to make you understand that this is a lovely branch with excellent treatment and great hope. And that's where I'm going to start now. Why is uro-oncology now important? Uro-oncology is important because urological cancer has an intricate component of not only a cancer problem, but a functional problem. The urinary tract is a very functional tract. Be it kidney, bladder, prostate, penile testicular areas, all have its unique function, which almost cannot be replaced by anything else. So we need to understand that we need to give a cancer care to the patient, thereby giving longevity, but also maintain the quality of life for those patients. So understanding these two and getting the fine balance between these two is what uro-oncology is about. Why is it important? Because there is so much of improved awareness. right from social media platforms, right from understanding. People are now more aware. There is a huge proliferation of diagnostic centers, both for good and bad. Definitely for good, because we are now finding younger patients with many of the urological cancers. The youngest renal cancer patient I came across was 21. The youngest bladder cancer patient I came across was 19. The youngest prostate cancer I came across was 38. So we are having young patients. We are also, the same token, India has people who are living for a longer time. Now an average male in India living nearly up to 80, and an average female is living up to 72. These are all patients who are very much aware that they have to have and maintain the quality of life. This is the man who has great grandchildren and grandchildren in US, and he doesn't want to trouble them in any way. So we want to give them a care which will deliver that component as well. Patients are very knowledgeable. Thanks to the internet and social media, knowledge is plenty. And added to that, we have what I describe as California daughter syndrome. Inevitably, almost every human being in India has one connection to US who is a relative there, and inevitably that relative is a doctor. And inevitably they will give some advice as well. We need to balance that as well. Uro-oncology is about preserving quality of life, giving the adequate cancer care so that we give back to this world a human being who's functional, dependent, and confident. How do we do that? We completely tailor the treatment. In uro-oncology, one size will never fit all. Each patient, the treatment plan will change and modify and nuancedly adjusted to meet the needs. We utilize every latest technology. If there is any advance that happens in medical field, the first branch to try it is uro-oncology. Be it robotics, be it genetics, be it anything, you give me something new, we will do it. We also have moved on to do organ preserving surgery whenever possible. And we do a teamwork. In uro-oncology, there is no boss, there is no subservient. Everybody is a boss, everybody is a subservient, because we work together and we understand that in this patient, surgery is better. In that patient, radiation is better. And we are very happy to refer to each other and make sure that patient gets the max. The 5 branches in uro-oncology, namely kidney, prostate, urinary bladder, penile and testicular cancer. I'm going to put one slide for each and move forward to tell what difference has happened. In kidney tumors, many of you will remember radical nephrectomy, an incision which is about 35 centimeters in length. Everything in that area gets removed. Remember radical mastectomy, everything gets removed. They used to do the same for this tumor as well. Gone. Those days have gone now. No longer we do that mega big operations. Almost 90-95% of my kidney cancer work is either laparoscopy or robotics. We also have understood partial nephrectomy is exceptionally useful and gives the same oncological control and preserves the renal function. So we do partial nephrectomy. On an average, I do about 70 to 100 partial nephrectomies a year compared to about 10 radical nephrectomies. That is a phenomenal change that has happened. Excellent oncological outcomes, preserve renal function, reduces cardiovascular risk, gives the longevity to the patient. So let's move to, I'm just highlighting what has changed. I'm not going through the full detail of treatment plan. In urinary bladder cancer, we know that TRBT is the standard. And after TRBT, many patients, we try to preserve the bladder with what we describe as intravesical therapy. We just put some chemicals in the bladder and try to preserve it. But once a patient reaches a stage where the bladder cannot be preserved, then the option will be either to do an open radical cystectomy or radiotherapy to the bladder. In radical cystectomy, people used to be struggling a lot, recovering over 3 months, 4 months, and etc. Things have changed completely. Patients are now in the hospital for anywhere between 5 to 6 days, and they are back to work within 3 weeks or 4 weeks. You remember a very famous patient who had a radical cystectomy recently? Shivakumar, the famous actor in Karnataka. He was operated by my mentor, Professor Mano Murugesan. Within less than a month, he was back to his acting job. So that is the biggest difference that has happened in bladder cancer. We offer this operation and quickly recover the patient, preserving the quality of life. Vaginal preserving surgery for women, erectile preserving surgery for men, and even a neobladder in the appropriate patient. In the appropriate patient, everything is delivered to them. One of my patients in UK who underwent a radical cystectomy with a neobladder. Advantages: minimal blood loss, quick recovery to work, oncologically same. My teacher, Professor Stolzenberg at Leipzig. Prostate cancer, amazing developments. You will not believe how much we have moved. Just to give you a simple statistic, in 1980s, metastatic prostate cancer will not live beyond 3 years. Nowadays, they are living more than 10 years. That difference have been achieved. Of course, don't worry about early prostate cancer. Almost always they are cured. Excellent cancer cure, excellent cancer control. And we have such an armamentarium of treatment for them: surgery, radiation, hormones, chemotherapy, newer drugs, immunotherapy. You have such a big platter of treatment for these patients. We do robotic prostatectomy now, and what we describe as nerve spare technique. And I promise I'm putting 1 or 2 days here. We do it as a day case. Patient come in the morning, go home in the evening to have dinner in the house. Continence recovery, most of the patients are continent and catheter removal. If at all, by 3 to 6 weeks, they are completely continent. Recovery of function. If a patient had erectile function before, almost 80% chance they will recover after. And it also offers an opportunity to give more treatment in future if need be. Overall, patient satisfaction is very high. That is a console of a robot. Now, just a quick word about penile cancer. Previously, people used to do only a total penectomy and radical inguinal dissection. Thankfully, it has gone. Nowadays, we do organ-preserving surgery called glanzectomy. And we just beautifully do just dynamic sentinel lymph node biopsy, if not a robotic modified inguinal block. No skin loss, no necrosis, no flaps, nothing. Advantages: very little complication, avoids unnecessary surgery, and very, very quick recovery back to its life. Testicular cancer. If something has made a phenomenal mark in the history of cancer, it's testicular cancer. And thing that has made a mark is actually chemotherapy. Chemotherapy has transformed testicular cancer to that level that we are having patients who are alive for lifetime now. Cure is purely achieved in testicular cancer. Very minimal side effects, return back to work. Superb shift that has happened now. We have changed. And as a team, as an IMA, as all of you who are general practitioner, including myself as a general practitioner for my relatives, we need to understand that awareness has increased. We have fantastic blood test, simple screening test. Radiology has improved so well. Biopsy techniques have got so better. And therefore, we are getting more and more patients with these problems. We need to guide them properly. The word now is multimodal therapy. The word is judicial use of surgery, radiation, and all the things. It's not that one will fit one patient. It will be a combination of many which fits the patient. It's a multidisciplinary approach. We use every armamentarium that is available in the scheme of things, robotic surgery especially. And medical oncs have sort of marched ahead. We have very, very good chemotherapy with minimal side effects. We have understood dose adjustments, and we have immunotherapy now as well. From a primary care perspective, this is what I want your eyes and ears to open for. Please advise your relatives to do mast cell checkup. A hematuria, a blood in the urine, is not carrot juice, is not beetroot, it's not heat. It needs to be worked up with a CT urogram and a PSA and a flexible cystoscopy. 40% patient will have a malignancy. PSA for every man above 50, but I will prefer every man above 40. Ultrasound for renal tumor should be part of the health checkup. Testicle and penile examination should be part of every man's life till he is alive. And this is exactly the same as breast self-examination for women. We don't think twice about it. Why are we thinking twice about this? And many things can be looked after by the community. You don't need to come to the hospital to look after. Kidney cancer can be followed up in the community. Bladder cancer can be followed up very easily by just a flexible cystoscope. Prostate cancer, just a blood test called PSA. Of course, you don't need to worry about testicular cancer and penile cancer. But we also have a responsibility to tell them what they should not do. The first thing is smoking. I'm very saddened to see youngsters, we had a huge dip in smoking between 1980s to 2000, 2004, 5. And now there is an increase back amongst the youngsters who are clinging back to cigarette. It's exceptionally sad to see this. One habit which can be responsible for 58 cancers has to be stopped. I still do not know why any government in the world is not banning it. Healthy diet. Avoid dyes if possible, including hair dye as well. Healthy personal hygiene, self-examination, be aware, be positive. Early diagnosis gives so much of cancer cures. Multimodality treatment is the way forward. Quality matters. A quality of life matters all the time. We need to understand the cancer biology and deliver the optimal treatment to the patient, not one size fits all. And one medical oncologist cannot look after everything. One surgical oncologist cannot look after everything. Those days, thankfully, has gone, and it should go. People should understand that subspecialized care is the way forward. My request to all of you, do not hesitate to screen for cancers, and do not ignore simple symptoms. Be aware, be positive. I'm going to run some videos just to show what robotics has done to this world. And this is a patient who had a tumor in the IVC, inferior vena cava. And I'm going to show a video just to show that inferior vena cava tumor can be excised with a robot. Now, whilst this tumor is running, this video is running, you can ask more questions. And if I've crossed my limit of time, you can please let me, I'll stop the presentation. I have just 2 videos to run if there is a time for it. What you're seeing right now is the vena cava, the lower part, upper part of the vena cava, we have slinged it above the renal vessels. And now we are identifying the opposite renal vein that is also slooped up. The tumor is being isolated now. So this is the renal artery. This renal artery. This is the first time in the world this surgery was preserved. IVC tumors usually will have excision of IVC as well as the concomitant kidney as well, which is usually right kidney. But this time we managed to preserve the right kidney and excise only the tumor, and that also using the robotic technology. You will see that tumor is getting excised now. So that is the excision of the tumor along with the renal vein and the renal vein and the IVC wall. And now that the tumor is excised, we will start suturing the IVC. Just accelerate it. I'm just going to the end of this reason. So that is the IVC which is being sutured and closed. That is the opposite. That is the ipsilateral renal vein. That is the IVC which is fully done and preserved. So this patient had a leiomyosarcoma of the IVC, grade 1, and she is alive even today at 1 year follow-up with no recurrence. Another patient where I thought it'll be interesting. You would have seen a lot of radical prostatectomies and partial nephrectomies. I thought I'll show something unique and different. So this patient had a right adrenal lesion. See this? This is the paraganglionoma of the ganglion, and that was a secreting tumor. So what we thought is that we will do a robotic excision of this. That is the IVC being isolated. This was situated between the inter-iotocaval area, between the aorta and the IVC. And inevitably, these things will have at least 15 or 20 blood vessels supplying to it. So what we did is to use a robotic technology to excise the whole thing. This is the full length of the IVC which is being exposed. And it was a tumor which was located in the inter-aortic cable going behind the renal, going behind the IVC. So we started isolating. We lifted the IVC, as you would see in a minute. IVC is up in the air. So IVC, this is the IVC separated off, and this is the tumor separated off. As I explained, multiple blood vessels supply these things, so we put Hemolox to control it. And we went around the IVC to take the tumor down. Once again, preserving the ipsilateral kidney. Up in the air is the IVC. Can you see that? Up in the air is the IVC. On the floor is a tumor. Separated off now completely. IVC there. And the aorta and the kidney preserved. So I'm going to stop this. And if you have any questions, I'm happy to answer. If not, I would once again want to thank IMA Nellore and Apollo Hospitals who gave me this opportunity to present this oration to you. Thank you so much.
Thank you, sir, Raghavan sir and Dr. Ashok. Thank you very much, sir. Madam, Dr. Bhaga Harita Garu, leading interventional cardiologist from Guntur. She has served many years in Ramesh hospitals, having to her a great number of PTCs done successfully, and very knowledgeable, very research-minded person. Now presently working at KIMS Hospital. She has been awarded Dr. O.M. Baer IMA AP State Prestigious Oration. This oration for the year 25. For the year 24, our Registrar of NTR Health University was awarded. For the year 25, this award goes to Dr. Harita Garu. Madam, please give a presentation.
Thank you, sir. Thank you for the kind introduction. Hope you can see the slides, sir.
Yes, ma'am. Ma'am, go to slideshow mode, ma'am.
Okay. Can you see the slides, sir?
Yes, ma'am. Go ahead.
Sir, first I'm greatly honored to receive this medal oration. I would like to thank IMA Nellore for honoring me with this gold medal. Basically, my topic today is heart failure, which is almost always thought that it is a terminal illness like oncology problem or a renal failure, wherein it ends up with death. But today I would just like to go through my cases wherein there are some reversible causes. So if we see the trajectory of heart failure, this is the typical course. Here you can see this is the first episode of congestive heart failure which the patient has landed up. Here we have to start the disease modifying therapy, both curative and modifying the morbidity of the patient and minimizing the complications. So as the patient improves, slowly time goes on, and at some point, most of the patients, at least 50 to 60% of the patients will have again a dip in their health, and they land up in congestive heart failure. So once if again it starts, it recurs in an immediate period, and finally it lands up with death. So basically today my topic is on reversible causes of heart failure. Most of the times which we miss in our OP. If the patient lands up with heart failure, many of the times we think about the commonest cause, that is the coronary artery disease, rather than these infections or autoimmune causes, alcohol, drug abuse. Diabetes as such can cause restrictive cardiomyopathy and heart failure, and sudden surges in hypertension that happen during procedures, especially the urology procedures and the gynae procedures, wherein the patient lands up with sudden surge in hypertension. If we see the echo shows an ejection fraction of 30%, and this is usually transient if we treat the hypertension properly during that acute phase. Similarly, arrhythmias. So whenever we see a patient with arrhythmia, we think that the arrhythmias are secondary to cardiomyopathy. But nowadays, there are standard theories saying that the cardiomyopathy is secondary to arrhythmia rather than arrhythmia causing cardiomyopathy. So peripartum cardiomyopathy, drug-induced cardiomyopathies, nutritional deficiencies are also common, and right heart failure secondary to lung causes. So if we see the infections, the common infections that cause cardiomyopathy, or we have already seen during the pandemic, it is COVID. Influenza also causes commonly cardiomyopathy. Dengue fever, retroviral disease, all these things can cause cardiomyopathy, and most of these viral infections are reversible if we identify in the early period. So previously, all the textbook viruses like enterovirus, rotavirus, Coxsackie virus, these are research-guided viruses. But commonly we don't see it because we have to send the samples to viral centers, but we are not doing it regularly. So the bacterial infections being post-streptococcal autoimmune diseases, diphtheria, scrub typhus, tuberculosis also causes LV dysfunction. And if we identify it in the right time, we can treat it, and it is preventable. So if we see the virus, so initially in 1950s, it was the rampant, very bad flu influenza virus, and later in the mid 1980s, we see the HIV virus, then comes the adenovirus, and 2010, it is the Epstein-Barr virus, and in 2020, it is the COVID virus. So all these viruses can cause myocarditis. So coming to my first case, he is a 20-year-old MBBS student who came with sore throat since 1 month. Presentation was 1 week back. He had vomitings and loose stools, and she was given IV fluids, and we thought orthopnea is secondary to IV fluids, and after 5 days, he developed decreased urine output and AKI. So this is the ECG of the patient. So suggesting nothing but sinus tachycardia is there. There are no STT changes. The QRS morphology is normal. If we see the echo, it is around 30% ejection fraction is there. There is a associated RV dysfunction also along with left ventricular dysfunction. That is globally, all entire myocardium is involved, and he is having bilateral pleural effusions at the time of admission. So his ESR CRP was high, ASO titers were high, and serum creatinine was elevated, and we treated him for a while. After that, 20-year-old presenting without joint pains, without fever, but still we had a discussion, and we have conducted the throat cultures wherein it came positive for streptococcus, and when we treated him with penicillins, his LV ejection fraction improved to 40%, and most of the symptoms decreased, and we diagnosed it as acute rheumatic fever, which is a completely reversible cardiomyopathy. So here is a 10-year-old boy presented with fever, which is on and off since 8 days, and again severe throat pain, but with neck swelling and puffiness of the face and renal failure, with a history of loss of consciousness. So here in the ECG, we can see clearly that only P waves are seen and broad QRS complexes are seen. So this is nothing but a complete heart block with the bundle branch block. So to save the life, initially we kept him on a temporary pacemaker, gave him diuretics, and he had hyperkalemia, and we took the hyperkalemia measures, and he completely improved, and he is discharged. We thought probably it was AKI with hyperkalemia with complete heart block, and he was discharged. Again, he came to the hospital after 4 weeks with an echocardiogram showing 35% patient in failure. So later, after 2 days, he developed gross weakness of all the 4 limbs, and this case was a GB syndrome, a viral illness which presented with acute GE, renal failure, complete heart block, treated with temporary pacemaker, and post-viral autoimmune myocarditis was there, and he had GB syndrome, and he improved after giving IV immunoglobulins. So some other autoimmune causes that cause LV dysfunction are Takayasu arthritis, SLE, systemic sclerosis, APLA, and Kawasaki heart disease. So here is a 18-year-old. Actually, she was a staff nurse. She presented with breathlessness grade 3 to grade 4, and it was associated with PND and bilateral pedal edema. When we saw the pulses, she had a significant hypertension at the time of presentation. So all the peripheral pulses were felt, but we thought of, because she is a young female with the hypertension, we thought probably it is a vasculitis, and we did a CT iotogram, which showed that there is an absent left kidney with a small right kidney, suggestive of renal artery stenosis. After the iotogram, maybe because of the contrast, we thought, but patient had no urine for 1 day. So when we did the echo showed a severe LV dysfunction and bilateral large pleural effusions. And when we did an iotogram, we thought we should open as she's not having urine output, we thought if we open the renal artery, probably the only kidney that is left is right kidney, and there is a decreased blood flow for the right kidney. We thought we would open it. So we did an iotogram, conventional iotogram. So you can see the catheter here, and this is the aorta. We can see the tortuosity and the ugly aorta, which is having significant vasculitis. And we cannot see the renal arteries. Normally, we see the renal arteries on both sides, but we cannot see the renal arteries here. So we wired the right renal artery and we opened it. So here you can see that we can see the aorta here, and this is the renal artery that is filling completely. We thrombolized her as there is significant thrombus in the renal artery. So after thrombolysis and giving mycophenolate and steroids, she completely recovered and she was doing well. So the next most common cause that causes heart failure is arrhythmia. Even if there is a prolonged first degree heart block, the atrial support for the left ventricle, the blood flow to the left ventricle is lost, and the patient can have exertional breathlessness. So we should not neglect any heart block, even if it is first degree, second degree, or a complete heart block. So the other entities being frequent ventricular ectopics and left bundle branch block, atrial fibrillation with fast heart rates result in tachycardiomyopathy. Or else if it is a supraventricular tachycardia, which is persisting for more than 24 hours, it results in LV dysfunction. So here is a 57-year-old female who is a known, she is a known diabetic with complaints of breathlessness and fatigue. There is a strong family history in the family history. Her brother had heart disease, and we did a dual chamber pacemaker for the patient. She had mild LV dysfunction. In the follow-up, she had significant breathlessness and pedal edema. And because we pace the right ventricle, the ECG will have a left bundle branch block pattern, which results in dysynchrony of the muscle contraction. And this leads to significant LV dysfunction. And it resulted in 25% ejection fraction after doing a pacemaker. So this LV dysynchrony is secondary to pacing. So as we pace the right ventricle first, there is dysynchrony in the left ventricle. If the septum contracts, it will push the blood towards the lateral wall rather than pushing it into the aorta. So this dysynchrony even causes mitral regurgitation. Once the synchrony is restored, there is proper contraction of the entire left ventricular muscle and the cardiac output increases. So we treated her with all the drugs, but there was no response. So we did a pacing, which is cardiac resynchronization therapy pacing. And after that, she improved very well. And the LV dysfunction also decreased. So the fifth case is a patient with the bronchial asthma. She presented with breathlessness sudden in onset after treating her with deriphyllin and salbutamol. At presentation, her heart rate is around 160, blood pressure is 80/60, though the saturations were normal. ECG is showing a fast heart rate of 150 to 160. Most of the times when you see an ECG with 150, 160 heart rate, it suggests that it could be atrial flutter with 2:1 block. If the patient is having an atrial flutter like this, the rhythm should be reverted to normal immediately. So the echo showed a severe LV dysfunction. So she was treated with adenosine, and after giving adenosine, her rhythm restored to normal. So this is the normal treatment which we give for supraventricular tachycardias. And whenever any patient presents with supraventricular tachycardia, we have to look for the causes. Like sometimes it could be conduction problem, or most of the times it could be secondary to some drug induced, that is any bronchial asthma, or it could be secondary to thyrotoxicosis. All the reversible causes we have to check for before concluding that it is heart failure. So nowadays the term atrial failure also is existent. We all know pretty well about the ventricular failure, but there is a term called atrial failure whenever the atrium gets fibrosed, or whenever there is atrial fibrillation that is happening. The atrial kick is lost, and the lost atrial kick will decrease the cardiac output, leading to heart failure. So we have to correct the atrial failure also whenever we are treating the patients. So coming to the valvular causes of LV dysfunction, we know if the patient is having mitral regurgitation or severe aortic stenosis, because of the afterload mismatch, patient may land up with LV dysfunction. Severe mitral stenosis, acute rheumatic fever, and acute infective endocarditis, all these can precipitate LV dysfunction, and most of these conditions are reversible. So the next case being a 78-year-old male, post PCI done for his coronary artery disease, presented with class 4 breathlessness. He was unable to move. He was so fatigued, and he was unable to move even his legs. Whenever he is moving his legs in the bed also, he was having breathlessness. Echo showed severe LV dysfunction, left bundle branch block, angio triple vessel disease. We did a PCI to LAD and LCX, but he had severe mitral regurgitation. So for this case, we did a mitra clip, and he is still doing well. And mitra clip is one entity. When we try all the available medication and all the available interventions, but still if the patient is breathless and he is having severe mitral regurgitation which is causing LV dysfunction, then mitra clip is an option. So coming to the next patient. So this is a classical case wherein most of the times we see this common phenomena, diabetic patients presenting with chest pain, angio shows triple vessel disease. We see an angio, then ECGs, but echo of the patient was 25% EF. So whether we should go ahead with the treatment or not. Already if the muscle is infarcted, there is no point in going for CABG, that is bypass surgery. So we did a cardiac MRI in this case. It showed a thin scar rather than the entire left ventricle. Entire left ventricle is viable. Only a thin scar is seen. So we subjected the patient for CABG and he recovered completely. The follow-up echo is 35%. We cannot expect a complete recovery because there is some amount of scar. So a 52-year-old female diabetic presented with class 3 breathlessness. She had a past history of non-small cell lung carcinoma. So she took 5 cycles of chemotherapy and she had associated anemia. We thought it was secondary to anemia, but the ejection fraction was significantly less. It was 20 to 25%, and this case it was due to chemotherapy. So there are some cancer drugs that cause cardiomyopathy. One of the drug is the bevacizumab. So she completely recovered after stopping this drug. So the common cardiotoxic drugs, whenever we see such patients of heart failure and severe LV dysfunction, we should go back and see if the patient is on any cardiotoxic drugs. And if we stop these drugs, at least 60 to 70% of the patients will have again a normal LV function. So unexpected drug complications that came to our hospital for admission being one of the pulmonologist's wife. She had angioedema in the hospital, in their hospital, and they gave injection adrenaline, and she landed up with Takotsubo cardiomyopathy, that is stress cardiomyopathy. If we give high amounts of catecholamines, they trigger a vicious cycle wherein the heart is unable to contract for the heart rates. So the heart will land up in a cardiomyopathy called stress cardiomyopathy. So sometimes even injection buscopan and chronic iron injections, which is commonly practiced in peripheries, it can cause iron overload and along with that LV dysfunction. And excess IV fluids post-op, whenever we are treating the patient with IV fluids, if the patient is having some amount of diastolic dysfunction, the patient can go into LV dysfunction with failure also. So we should be cautious whenever we are giving high amounts of IV fluids in the post-op period. So this is a 24-year-old female. She presented she had a history of hanging at home, and she was treated in the local hospital, there intubated and shifted to our hospital. ECG is slightly suggestive of some poor R progression and some STT changes. Maybe this is because of the hypoxia that landed up, hypoxia of the left ventricle, which landed up with an ejection fraction of 30%. And such type of cases also, this is hypoxic cardiomyopathy with cardiogenic shock secondary to hanging. And after 5 days after treatment, she completely recovered. So the entity which I have described previously is a stress cardiomyopathy, seen in the post-op cases, like most of commonly seen in GI surgeries, especially involving resection of the esophagus, colon, and after doing an end-to-end anastomosis. In such cases, surgeries that are prolonged for hours and post-trauma and any unexpected event in the family, either death of the siblings or children, can also land up, the patient can land up with stress cardiomyopathy. And other common cause being subarachnoid hemorrhage and post-adrenal surgeries. So these things we have to keep in our mind whenever we are treating such cases, and we have to look for the LV function if the patient is having tachycardia in the post-op period. So in such situations, if the patient is having hypotension, don't give dobutamine or dopamine, because the catecholamine is the trigger for the heart disease here, and we should not give them dopamine or dobutamine, even noradrenaline also. So this is a case treated by a neurosurgeon, subarachnoid hemorrhage. She had associated severe LV dysfunction with hypotension. In such cases, never give these drugs, catecholamines, and it will result in a drastic fall in significant BP, and the LV function drops down even to 10%. So the other entity, before labeling it as idiopathic dilated cardiomyopathy, better give a trial of thiamine, whatever it is, because we do see some patients who have thiamine deficiency and they present with which we previously learned like wet beriberi. So we have to treat them with thiamine, and we do see within 1 week of giving thiamine, the patient will become completely normal. Some patients with thiamine deficiency, they present with severe PAH also. So if you exclude all other causes like chronic PT or lung disease or liver disease, so some patients with liver disease also, they have severe PAH and right heart failure. Sometimes we have a difficulty about which is the first, which is the cause. Like cardiac cirrhosis is one entity that is present, and so in such cases we should be cautious in treating the primary problem. So if time permits, I would go through this case. Probably this is the last case. So similar patient with we did a cardiac MRA. So this is dilated cardiomyopathy with severe LV dysfunction. So normally we do run heart failure clinics. Why? Because in the routine OP, if we see these cases, we may miss the cause of the heart failure. We'll just treat it like a routine heart failure patient. So we call them for the heart failure clinic and thoroughly evaluate for the causes. And we see if the patient is having, he is on the complete therapy or not. So we would see the quality indicators, whether the patient is on beta blockers or not, whether the patient is on AC inhibitors and ARNI or not, and if the patient gets admitted, average length of the stay of the patient, and readmissions. So within 30 days, if you treat the patient, he goes back home, and if comes for the readmission, if the readmission rate is high, we have to again think about the protocols in the hospital. So these are the quality indicators. So thank you, sir. Thank you for giving me this opportunity. Thank you, IMA Nellore.
Thank you, madam. Thank you very much.
Sir.
Amarendra Reddy, please. Sir. Amarendra Reddy. రాహుల్ అమర్ లేనట్టున్నాడు, నువ్వు తీసుకోకరావా రాహుల్? రాహుల్ 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 ఎనివే Dr. C. Bhaktaval Reddy, renowned cardiologist from Nellore. He has been awarded with the Criterion E.S. Reddy Oration. This oration is installed in the name of Dr. E.S. Reddy, who was a great philanthropist. He was the first president of IMA state from Nellore. And not only that, he has run a hostel wherein so many people have studied in this hostel. Yenugu Pattaya, still known as. His brother is Yenugu Pattaya, his younger brother, but it was started and founded by him. The entire property of him was donated to Rotary Club. And now Dr. C. Bhaktotsal Reddy, sir, your CV is not opening. Dr. C. Bhaktotsal Reddy, a renowned cardiologist, previously worked in Narayana Medical College, and after that he has worked some period in Simapuri Hospital. Now he is the Director of Cardiology, Apollo Hospital, Nellore, and a very famous cardiologist in Nellore. Thank you, sir.
Good morning. Thank you for giving me this opportunity, especially Nellore IMA. Sir Ashok, sir, thank you. And for giving me this Yenugu Sundaram Reddy Garu oration. Now, today I will discuss about a new class of drugs which were common nowadays to use because it's become day to day. Is using anticoagulants in different scenarios is becoming a real tough. So we'll discuss something about new novel oral anticoagulants. Normally in any, for any coagulation, either it's intrinsic pathway or extrinsic pathway, will start using the coagulation factors, and then which uses 7, 9, 11, 12, and then combine to cause factor 10 to activated factor 10A, which leads to the activation of prothrombin to thrombin, and then lead to fibrinogen to fibrin. This is how the common coagulation cascade runs, which needs a lot of coagulation factors. So end of the day, we need the fibrin to form with so that there won't be the clot will be there so that it won't bleed. So what are the drugs that are commonly available previously were other than the parenteral drugs like heparin or low molecular weight heparin or direct thrombin inhibitors? Oral anticoagulants, the common traditionally used as vitamin K antagonists, that is coumarin derivatives, that is warfarin. So it acts by the 2, 7, 9, 10 factors, this is the traditional way. So the newer anticoagulants are rivaroxaban, apixaban, edoxaban, which directly acts on the factor 10A, or the direct oral thrombin inhibitors like dabigatran, which affects the coagulation cascade. Today we will discuss about these things. So what is the necessity of using the anticoagulation? The famous neurologist in UK, Sir William Gowers, who's one of the pioneers in neurology, identified the atrial fibrillation. Because when there is a common entity nowadays is the atrial fibrillation, which leads to the atrial standstill. So that here you can see the left atrial appendage having the clots. These clots, when there is an atrial standstill, especially in atrial fibrillation, these clots will dislodge from the atrium and go to the brain, or any, for that matter, any organ, causes the massive embolic phenomenon. The most common is cerebral strokes. So we need to prevent these strokes. For that, AF is one of the causes for the usage of these anticoagulants. So epidemiology, if you see, it's in India, especially 0.1 to 1.6% among Indian population. There's very famous studies, Nagpur AF studies in the urban population has shown AF of 0.196%. The mean age was 60 plus or minus 15 years. Most of them are female patients. Whereas in the AP study, 1.6% are higher among the males patient. This is the rural population. So there are so many risk factors for atrial fibrillation, like genotypes, family history, old age, height, or the reversible risk factors like previous cardiac surgeries or valvular heart disease, coronary artery disease, sleep apnea, or diabetes mellitus, hypertension, obesity, and the associated heart failure, or one of the most common cause nowadays is binges of alcohol, and then some drugs, or the hyperthyroidism, which leads to the atrial fibrillation. There are some risk assessment scores, when to use the anticoagulants, when not to use. The famous commonly used is CHARTS-2 score, that is based on the congestive heart failure, hypertension, age more than 75, diabetes mellitus, stroke or history of thromboembolism or any other vascular disease, age 65 to 75 and sex category, female sex has 1. So based on the scores, if the score is 0 or 1, there is no need for any antithrombotic therapy. If at all, if requires, you can keep lower dose of antiplatelets. Or if the score is more than 1 in males or equal or more than 1 in males or equal or more than 2 in females, it needs antithrombotic therapy because the higher the chart score, the more risk of stroke per year. The same way, there are so many scores which assess the different patterns like bleeding scores, where who bleeds more. So when there is bleeding score, bleeding risk is high, then you need to titrate the doses to the lower levels or need to use the lowest possible doses to avoid bleeding complication, because intracranial hemorrhage or for that matter in the gut or wherever the bleeding tendencies is one of the most dramatic complications of uses of these drugs. These scores are based upon the hypertension or abnormal renal or liver parameters, previous history of stroke or bleeding tendencies, labile INRs or elderly people or drugs or for that other drugs or ethanol ingestion. So previously we have only the oral anticoagulants which were used extensively for thromboembolism in both veins and arteries. Only the vitamin K antagonists were the feasible oral anticoagulants before. But the problem with the oral anticoagulant, that is vitamin K antagonists, is there is an increased risk of bleeding, narrow therapeutic index, individualized based INRs, and many more problems that we'll discuss. So it usually the vitamin K dependent, the coumarin derivatives, warfarin or citram acts on the, so affects the synthesis of 2, 7, 9, 10 factors and also the protein C and S. So it inhibits the synthesis of vitamin K dependent coagulation factors as well as anticoagulant protein C and S. So because it takes 3 to 4 days, minimum 72 hours for the effect is seen, because it does not have any effect on the already synthesized factors. So it only affects the further synthesis of these factors. So the effect of these already synthesized factors should wean off. The other problem is you cannot never ever give loading doses of warfarin, because if so many people ask us why can't we give loading dose. So the main problem is it also affects on the anticoagulant protein C and S. So if you give higher doses, loading dose of warfarin, it can cause paradoxical effects. It can cause more thrombosis. So never give the loading doses of warfarin. And the problem with these coumarin derivatives are it has so many interactions either by the intestinal flora synthesis or absorption or drug metabolism or displacement of the drug from the protein binding sites or the co-administration of other drugs leading to drug interaction by drug absorption or synthesis of the clotting factors or microbial enzyme inducers. There are so many drugs that has drug interactions with warfarin. So we have to be very careful whenever we are using warfarin. But still, even though there are so many other drugs are available, but still till today, prosthetic valves or the valvular AF, still coumarin derivatives are at the drugs of choice, because there are no immediate or direct studies which can approve the usage of novel anticoagulants. Of course, pregnancy, the newer drugs were not been tried, and the pregnancy still the heparin is the drug of choice, and the vitamin K, that coumarin, can be used in the second trimester, but the first trimester and the third trimester, heparin is the drug of choice. And the renal impairments and severe renal disease, antiphospholipid syndromes, and the compliance of the drugs taking and the other diseases, dosing inconvenience, because the vitamin K derivatives can be given only OD and the other newer drugs can be given. It has to be given twice a day. That we will discuss. The other thing is the cost. And also the vitamin K acts on the so many things on the body. That is other than the coagulation factors, it also reduces the vitamin K damage and decreases the proteinuria and increases the calcium absorption, increases the bone formation and reduces the arterial stiffening and vascular calcification, and also it reduces the incidence of coronary vascular diseases. All these effects of vitamin K will be lost if you use coumarin derivatives. So what are the drugs that are come into picture? The first one which come into picture was dabigatran, which was first approved in 2010. It is a direct thrombin inhibitor. It acts on the thrombin. The other drugs are rivaroxaban, apixaban, edoxaban, and they are direct factor 10A inhibitors, which were approved later in 2011 and 2014 and 2015. And the newer one is betrixaban. So what are the important advantages of using these newer novel oral anticoagulants are there is no dietary restrictions. So you can eat whatever they want and fewer drug interactions compared to warfarin and reduced the risk of stroke and major bleeding risk compared with warfarin. There are a number of head-to-head trials compared with the warfarin along with these drugs. So they are almost on par or more efficacious than warfarin. And the very more important thing is it reduces the incidence of intracranial bleeding risk very much compared to the warfarin. And the perioperative bridging is not required. And the most important thing is no anticoagulation monitoring is required. That means the warfarin, if they are taking, patient needs to be monitored both PT and PT-INR regularly at 3 weeks to 4 weeks interval because the effect of warfarin may vary with the so many, as we discussed, with the so many parameters. So why do they don't need these newer drugs? Because of predictable pharmacokinetics and pharmacodynamics and absorption, and these things will have with the fixed dose combinations. They have expected efficiency, so they don't need to be monitored. But that is a debatable issue that we will discuss it later. So at fixed doses, there is no need for periodic monitoring. At all blood levels, it is certain that the drug exposure falls within a limit without monitoring the coagulation. So this is very important slide. The warfarin, the vitamin K epoxidase, and then lead to gamma carboxylase, and then leading to the synthesis of the factors, which is not a prodrug, and the bioavailability is 100%. Dosing is once a day, and it takes 4 to 5 days to get the peak effect of warfarin. Half-life is 40 hours. There is no renal clearance done, and interactions are multiple. The other thing, the first one is dabigatran, which is the direct thrombin inhibitor, which is a prodrug. The most important thing is dose is BD. It has to be given 12-hourly basis. Time to peak effect is 1 to 3 hours. And the main thing is it has high renal clearance. 80% of the drug goes through the renal clearance. That is why you have to be very careful in renal failures, especially if there is creatinine clearance is less than 30 or less than 15. You have to be very cautious in using the dabigatran or preferably contraindicated. The next is rivaroxaban and apixaban or edoxaban, they are direct factor 10A inhibitors. These are not prodrugs. The bioavailability varies from 60 to 80%. Apixaban is BD dose, and rivaroxaban, based on the condition, it can be OD or BD, and the half-life varies from 7 to 11 hours. And the lesser renal clearance. It has, compared to the dabigatran, this has lesser renal clearance. So a lower doses can be tried in the renal failures, but still it will be very dangerous because if there is a renal failure, there is high chances of bleeding. So what are the conditions that we commonly use these sort of drugs is thromboprophylaxis. Most of the times with the knee or hip surgeries, we come across having DVT or which is leading to the pulmonary thromboembolism. And as a prophylaxis, we always give the anticoagulants or venous thromboembolism, stroke prevention in non-valvular AF. They are indicated as of today only in non-valvular AF. If there is an associated rheumatic condition, the only coumarin derivatives are indicated as of today. And the roles in different drugs roles in the acute coronary syndrome, mechanical heart valves, heart failures, and coronary or peripheral arterial disease, for that matter, even after the coronary interventions, or the embolic stroke of unknown source, that these things we will discuss subsequently. So the doses, usually these are fixed doses based upon the weight and the different conditions that we will discuss. The atrial fibrillation, dabigatran is 150 milligrams BD. If there is a renal problem, then you should reduce to 110 milligrams BD. Rivaroxaban 20 milligrams OD, or the apixaban 5 milligrams BD. And the venous thromboembolism, especially the rivaroxaban or apixaban, you give a slightly higher dose for initial 21 days. That is rivaroxaban 15 milligrams for 21 days and then give 20 milligrams OD. Whereas the apixaban, you give 10 milligrams BD for 7 days followed by 5 milligrams BD. Yes, personally, I have very good experience with these drugs in these pulmonary embolism cases as well as in DVT. They recover very well with these drugs, better than the warfarin. And also the thromboprophylaxis after hip surgery or knee arthroplasty, you can give 10 milligrams OD of rivaroxaban or 2.5 milligrams of apixaban. So depending upon the chart score, as we discussed before, if the 0 or 1, there is no need for antithrombotic therapy. If the risk is 1 or 2, and then based on the bleeding score or the renal parameters, which one to use, either you want to use the newer drugs or vitamin K antagonists, that we can decide. So we first discuss about the dabigatran. If the dabigatran it is indicated, then if the points, if the age is more than 80 or the concomitant treatment with verapamil, the dose is 110 milligrams BD. Or if the age is less than 75, so between 75 to 80, or the weight less than 60 kgs, creatinine clearance 30 to 49 ml per minute, and the associated use of antiplatelets or the bleed score is more than 3, reduce the dose to 110 milligrams 12th hourly. Or if there are no indication, if there are no other these factors, then you can give 150 milligrams 12th hourly. The same way you can decide about the doses based on the creatinine clearance, 5 milligrams of apixaban 12th hourly or 2.5 milligrams of 12th hourly, or the rivaroxaban based on the bleeding risks and the weight and the age and the indications. You can use 20 milligrams for 24 hours or 15 milligrams for 24 hours. There are number of trials which in different conditions, but initially it started with the treatment in non-valvular AF, like Aristotle trial with apixaban, Rocket AF trial with rivaroxaban, and Engage AF with adoxaban, and the Relay trial, very famous Relay trial with the dabigatran. Then they all showed a significant benefit compared with the warfarin. But these are not, they are done with the comparison with warfarin. There is no head-to-head trials initially. The later there are so many head-to-head trials comparing rivaroxaban versus apixaban, rivaroxaban versus dabigatran. But there are almost all are same results, but there is very minimal difference, especially in venous thromboembolism. Apixaban is slightly better, but these things are not yet proven because it needs more data. And the same way, different trials have shown very good benefit, but the risk of hemorrhagic stroke is reduced, as well as the bleeding risk has been significantly reduced. As well as the latest real-world data from Aristophanes is consistent with the findings, especially in the older patients. These drugs are really safe. I'm not going in details into the studies. Same way, there are so many trials like the venous thromboembolism, like the apixaban amplify trial and dabigatran recover trial and adoxaban hoxoid trial. These are all showed very good benefit in the venous thromboembolism trials compared to warfarin. And there are so many indications and trials which are going on, especially in terminally ill patients, cancer patients, and embolic stroke of unknown source, venous thromboembolism, particularly in acute coronary syndromes, where we use high doses of antiplatelets. When to use antiplatelets, whether you are supposed to use ecosprin or clopidogrel or prasugrel or ticagrelor, initially these things can be combined. There were trials which comparing clopidogrel plus rivaroxaban, clopidogrel plus apixaban, but the bleeding risk was slightly higher. Later, they started comparing using with the ticagrelor, but adding with the antiplatelets and using the higher dose definitely carries more bleeding risk. As well as with the heart failure, and whereas long-standing coronary artery disease or peripheral arterial disease, nowadays the uses of drugs, if there is a thrombus in the peripheral arteries, these novel anticoagulants have been approved. So in the different, there are so many indications, but commonly these are the suggestions, but made with the studies. These are no hard and fast rules which one to use, but this is the common way they use. High risk of strokes, high chart score, dabigatran. Previous history of strokes, rivaroxaban. High risk of bleeding, dabigatran, apixaban. and medication compliance problem, rivaroxaban, elderly patients, apixaban. But these are the summary of, with the summary of different trials, different indications to use, which one to choose. Then comes the problem is once you give the drug, but the problem is when to do, how to monitor if there is a problem. See, as my professor used to ask us a simple question, a drug which can cause anticoagulation, which means which is not allowing the blood to clot, and you are saying it won't bleed. How does these two fit in? So the one which can cause anticoagulation should cause bleeding. So there are, even though it has a very fixed pharmacodynamics and kinetics, which can have a standard metabolism with the drug fixed doses, but still, especially when there is an associated use of other drugs, elderly individuals, thin individuals, the results are slightly uncertain. So suppose if there is a problem, what to use, how to monitor? If there is a bleeding problem with these drugs, how to monitor is a very tough task. The common uses of drugs, common uses of tests like PT, APTT, these things are not effective. But there are so many assays, factor 10A assays or photogenic assays, which can directly measure the factor 10 levels so that you can use the factor 10A antibodies. That I will discuss it. So the common test that you use is PT, APTT or VTT or ECT, but the fixed is anti-10A factor assessments are better. Suppose imagine there is a bleeding complication. So, but the best advantage with novel anticoagulants is they have a short half-lives. So their effect lasts shortly. So the initial mechanical compression, surgical hemostasis, fluid replacements or additional hemodynamic supports can be given. Because dabigatran have high renal clearance, hemodialysis can help, but it may not be effective for other direct 10A inhibitors. Now the prothrombin complex concentrates are available. The activated prothrombin complex, the 50 international units per kg per day, can be very effective in reducing the bleeding and stopping of the bleedings. Based on the risks, it can be repeated again. So coming to the antidotes. So commonly, if there is with the warfarin, if there is a problem, if there is a high INR, the most commonly we give vitamin K, but it takes 24 to 46 or 48 hours or 24 hours for the vitamin K to act and synthesize and giving. Or the other thing is give fresh frozen plasma to reduce the risk of bleeding. And of course, now the prothrombin complex concentrates are available, and the oral charcoal or the hemodialysis or the usage of desmopressin or tranexamic acid or other antifibrinolytic agents can be tried. So if the last dose was recent enough, within 8 hours of rivaroxaban or the apixaban with 6 hours or rivaroxaban, if the last dose was within 2 hours, then the activated charcoal can help, and the dabigatran, as I discussed, you can use hemodialysis. The other newer antidotes that have come that was in the research and came into the practice is etabestutumab, which is a monoclonal antibody fragment that specifically binds to dabigatran, neutralizing its anticoagulant effect. It's only FDA approved antidote for dabigatran related bleeding, even though it is rare, but it is available now. The other is modified version factor 10A, that is andexanet alpha. It's a decoy. So it's a receptor binding to neutralizing apixaban or rivaroxaban, neutralizing these effects. The other thing is aripiprazole, which is a synthetic molecule designed as a universal antidote for novel anticoagulants, which works by binding both to direct thrombin inhibitors and factor 10A inhibitors, but it is still under research. So it mostly, if it comes, things become very easy for us. The other question is how to switch from warfarin. So if the patient is already on warfarin, how to switch to different novel anticoagulants. So if they are on vitamin K antagonist, once the INR is less than 2, you can choose to the other anticoagulants. Or if they are on the common unfractionated heparin, after stopping 2 hours of stopping unfractionated heparin, you can use these drugs. Or if they are using on low molecular heparin, they can use the next dose of low molecular heparin. Instead of that, you can use these drugs. Or if you want the NovoSC2 VKA, concomitant treatment can be given until the INR is 2 to 3. or if you want to change to the novel anticoagulants to parenteral anticoagulant, then the next dose of anticoagulant time you can give the parenteral anticoagulants. One to other, the next dose, it can be planned. So what if the patients are undergoing for some intervention? Suppose if the patient is on some warfarin and he wants to undergo some elective surgery, we have to bridge with the heparin and then we would stop the heparin at least 72 hours prior to the elective procedure and do the surgery. Whereas with these novel anticoagulants, because of the shorter half-life, if they are for the minor surgeries, like biopsies or bladder biopsies or LVP studies or catheter ablation or angiograms, you can stop 2 days prior and then skip the last doses and then do. Or if there are major surgery, skip 48 hours before the surgery and or three days before the surgery, and you can restart if it is minor surgery 24 hours after surgery, or if it is a major surgery 48 hours after surgery you can use. The real challenges for here is, as we discussed, which has a short half-life. If there is no compliance, they are not taking drugs regularly. If it is BD dose, then if they skip one dose also, there is every chance of clot formation. So you have to be very sure that the patient will take the tablets very regularly. That is one of the drawback. Number two is cost. Of course, in Indian scenario that we have to always look into that picture. But now the costs have relatively come down. So probably that may not be issue. The other thing is when to monitor. There are no proper easy ways to monitor the effects. Even though they say there is no need to monitor, but still, if there is a complication, especially in elderly individuals or thin builds, if there is a bleeding tendencies, then you get stuck. How to monitor, what are the effects, how to reverse is a big question. And those laboratory assays and all the things may not be available everywhere. So these things should come up in the near future. But overall, these drugs are really, really useful. The recent past, the 1 week or 10 days back, we had a patient who underwent bilateral knee replacement. And then the second day, patient was standing and he underwent some physiotherapy, developed venous thromboembolism. And the entire clot is sitting in the right atrium and plus the tricuspid valve. We were so scary to see that when he will develop, when it will go to the lung. Patient is not breathless. We just given for 24 hours of heparin and then we started this apixaban. And within 48 to 72 hours, the clot has disappeared. So and patient is stable now, but the venous DVT is still there. At least it will take 3 to 6 months. We'll just put a filter so that it won't embolize again, or at least massive embolization can be prevented by putting in IVC filters. So these things are coming up and we need to learn. For individual experiences are more important as we know the things. And thank you so much for patient hearing. And thank you once again, the Nellore IMA and the Ashok sir for giving me this opportunity. Thank you so much, sir.
Thank you, sir. Thank you, sir. Bhakta Reddy, sir. Now, next speaker is Dr. G. Bhavana. There is no lunch break. The last speaker, we have brought her to the lunch break. She is a budding neurophysician practicing at Nellore. She graduated from DM Neuro from Narayana Medical College and now practicing at Vrindavan. And she is daughter of the famous gynecologist of Nellore, Dr. Sarita. Madam, please carry on your lecture.
Thank you, sir. Thank you for giving a platform today in the IMA section. Here I am sharing my slides. Is it visible, sir?
Yes, you are visible.
Okay. Today my topic is about peripheral neuropathy. So here, before proceeding to topic proper, just a brief introduction about the structure of peripheral nerve and classification of nerve fibers. So a peripheral nerve contains a group of nerve vesicles, which in turn contain a group of nerve fibers similar to a cable containing bundles of both myelinated and unmyelinated fibers. So nerve fiber proper is made up of an axon and its associated Schwann cells. So nerve fibers can be sensory, motor, and autonomic fibers. So each peripheral nerve contains a parallel bundles of nerve fibers, which are either efferent or afferent or myelinated or unmyelinated, surrounded by 3 layers of connective tissues, that is epineurium, perineurium, and endoneurium. So here in the image, you can see the green color one is a endoneurium, which contains multiple nerve fibers, which these multiple nerve fibers are embedded in the nerve vesicle, which is surrounded by the purple color perineurium. Multiple purple color nerve vesicles are embedded within light pink color connective tissues, which is epineurium. So overall, this peripheral nerve is surrounded by the epineurial sheath. So moving on to classification of nerve fibers, there are mainly 2 categories of classification, that is Erlanger and Gasser classification and numerical classification. Predominantly, we follow Erlanger and Gasser classification, which is type A, type B, and type C. Type C is predominantly alpha, beta, gamma, and delta. Alpha carries somatic motor proprioceptive fibers. Beta carries touch and pressure fibers. Gamma carries motor to muscle spindle fibers. And delta, which carries a fast pain fibers, cold and touch fibers. These type B fibers, they carry predominantly preganglionic sympathetic fibers, and type C are dorsal root ganglion fibers and postganglionic sympathetic fibers. So as we can see, type A and type B both are myelinated fibers, and type C is predominantly unmyelinated fibers. So similar to this, another numerical classification, which is 1A, 1B, 2, 3, and 4. This 1A, 1B corresponds mainly to alpha A fibers, and type 2 to predominantly A beta fibers, and type 3 to predominantly A delta fibers, and type 4 to predominantly type C fibers. So in this image, you can see the motor, sensory, and autonomic fibers. Motor fibers are predominantly always myelinated fibers. Sensory can be myelinated, thinly myelinated, and unmyelinated fibers. Autonomic fibers are very thinly myelinated or unmyelinated fibers. Here you can see the diameter of the fibers also from motor to autonomic. There is a gradual decline in the diameter of the fibers. So coming on to the topic proper, that is peripheral neuropathy. So peripheral neuropathy, it is a vast topic, so I have cut short this topic for you. So here main symptomatology includes the positive sensory symptoms and negative sensory symptoms, positive motor and negative motor symptoms. Likewise, autonomic also negative and positive symptoms. So if there is any injury to the sensory nerve fiber, the presentation will be negative symptomatology and positive symptomatology. So if large sensory fiber is involved, there will be decreased vibration, decreased proprioception, and sensory ataxia. If small fiber is involved, there will be decreased pain and temperature sensations. Along with that, there is positive symptoms in the form of paresthesias, dysesthesias, and allodynia. Paresthesias and hyperasthesias also. The clinical response to motor injury will be negative symptoms in the form of wasting, hypotonia, weakness, hyperreflexia, and orthopedic deformity. And positive symptomatology in the form of fasciculations and cramps. Coming on to autonomic nerve injury, decreased sensations in the form of decreased sweating, hypotension, urinary retention, impotence, and vascular color changes of the deformities of the extremities, and positive symptoms in the form of increased sweating and labile hypertension. So these nerve fibers are broadly classified based on the size of nerve fibers, that is small fiber neuropathy, large fiber, and mixed fiber neuropathy. Another classification is length versus non-length dependent neuropathy. Another classification is based on anatomical involvement, axonal and demyelinating, based on duration, that is acute, subacute, or chronic, and based on the nerve fiber type, sensory, motor, and mixed, based on the site of involvement, distal and proximal. So moving on, next is length dependent neuropathy. Predominantly, majority of cases, we will encounter this length-dependent neuropathy. Here, a major phenomena here is dying back neuropathy. That is, any nerve injury that starts in the terminal nerve axon with progress proximally. So, hence it is called dying back neuropathy. So, it is predominantly seen in the axonal degeneration. So, pattern of sensory and motor deficits develop according to the axonal length that is involved. So sensory deficits typically follow a stocking and glove pattern. Stocking first involving the lower limbs, then gloves involving the upper limbs involvement. So sensory changes, they initially occur at the most distal from the dorsal root ganglion cells. If paresthesias has reached the knees, they start appearing the tips of the fingers and upper limbs. If the site of lesion is 30 to 50 centimeters from the dorsal root ganglion, this sensory level lesion will spread up to the anterior torso, which is more on the lower abdomen compared to the thoracic region. If this lesion is more proximal to the DRJ, that is around 20 to 25 centimeters from the DRJ, it follows a Benny cap pattern of sensory change or the scalp vertex due to the distal involvement of the ophthalmic branches of fifth nerve. If it spreads almost near to the DRJ, that is only 12 centimeters fibers from the DRJ or spare, entire body there will be sensory loss except for a band of sensation or the posterior midline from the occiput to the sacral region. So here you can see the first image is showing a length dependent versus non-length dependent. So length dependent, you can see stocking and glove pattern. Non-length dependent, that is a patchy involvement of either upper limb or lower limb. So here in my right side image, this is a Benny cap pattern. If the DRJ cells up to 12 to 24 centimeters below that are involved, this is a Benny cap pattern involving only the scalp. So pattern of motor deficits. Here, intrinsic muscles of foot are initially affected, followed by the peroneal muscles, and then the gastrocnemius and soleus involvement. So predominantly, in compared to anterior and posterior tibial compartment affected early before the posterior tibial compartment because it has got lengthier nerve supply. Ankle dorsiflexors are more affected compared to the plantar flexors. If plantar flexors are affected, we have to think of another differential diagnosis like intraspinal causes. So moving on, next is small fiber neuropathy. It is a common neuromuscular disorder. It affects small myelinated A delta fibers and unmyelinated C fibers. These small sensory fibers, they carry pinprick and dermal stimuli. Autonomic C fibers, they mainly innervate the involuntary muscles like cardiac muscles, smooth muscles of GI tract and gastrointestinal tract, and predominantly glands like lacrimal, salivary, and sweat glands. So this is a most important slide because beauty of peripheral neuropathy, predominantly small fiber neuropathy, lies in diagnosing what is the cause of small fiber neuropathy. So predominant causes are metabolic, mainly diabetes, impaired glucose tolerance, B12 deficiency, copper deficiency, and abnormal thyroid function. Next is more important, toxic causes like alcohol and chemotherapeutic agents, neurotoxic agents, and vaccine associated. Infective causes like HIV, Lyme's disease, and hepatitis C. Hereditary causes like Fabry's, Tangiers, mutations in sodium channels, Wilson's disease, and familial amyloidosis. Immune-mediated like Ehlers-Danlos, fibromyalgia, monoclonal gammopathy, acute inflammatory small fiber neuropathy, and autoimmune disorders like lupus, connective tissue disorders, CIDP, sarcoidosis, and rheumatic diseases. Next comes Sjogren syndrome and primary systemic amyloidosis. And finally, celiac disease. So, small fiber neuropathy predominantly presents a sharp pain described as burning, pins and needle sensations with either stabbing, lancinating, electric shock-like pain. So, this pain will be typically worse at night. Patients will tell they have got intolerance to bed sheets or socks like that. So, they have also got a feeling like they are walking on a sand or gold balls or pebbles. So, on examination, there will be allodynia, hyperalgesias, and reduced pinprick and dermal sensations. So, pattern of sensory loss in small fiber neuropathy predominantly will be distal loss of pinprick sensation, above which there is a band of hyperalgesia with normal sensations above the level. So here in small fiber neuropathy, motor strength, proprioception, and deep tendon reflexes are all well preserved, which will be lost in case of large fiber neuropathy. So predominantly small fiber neuropathy will be length dependent. A few 20 to 25 cases or 25% of cases are non-length dependent, which causes a patchy asymmetric involvement or asymmetric mono or multiplex neuropathy involvement. So length-dependent small fiber neuropathy, think predominantly of metabolic causes. Non-length-dependent small fiber neuropathy, think of paraneoplastic disorders and immune-mediated pathologies like Sjogren syndrome. So autonomic involvement along with small fiber can be seen in the case of amyloidosis, diabetes, sarcoidosis, and Sjogren syndrome. Presentation will be dry eyes, constipation, dry mouth, sweating abnormalities, palpitations, urinary retention, sexual dysfunction, and skin discoloration. So this, as it is a length-dependent disorder, there will be reduced sweating in the case of feet, that is distal anhidrosis. Proximally, there will be compensatory proximal hyperhidrosis to maintain the thermoregulation. So examination reveals coldness and white, red, or purple skin discoloration of the feet. And
Hello, madam. Bhavna, madam, we are unable to hear your voice, ma'am.
is it visible, sir?
Ma'am, your voice is now audible, ma'am. Can you do your screen share 1 second, ma'am?
Yeah. Just a second, sir. Yeah. I think connection is lost.
Yes. Just screen share and then start from where they're the same thing.
Okay, sir. Just a few seconds. So is it visible, sir?
Yes, ma'am. Go on, ma'am.
Okay. Moving on to the next criteria, that is VESTA criteria. At least 2 of this following, that is signs and abnormal QST threshold and reduced nerve fiber density at distal leg without large fiber neuropathy symptoms. So main differences of large and small fiber neuropathy. Large fiber neuropathy, predominant symptomatology is numbness, impaired vibration sense and loss of position and loss of reflexes with impaired nerve conduction studies. But compared to small fiber neuropathy, large fiber neuropathy interferes with the normal daily activities of the living, and it has got a risk of falling and fractures. And small fiber neuropathy presents with shooting sharp pains with normal strength and normal reflexes. It is electrophysiologically, that is nerve conduction testifies it will be silent, but it will be diagnosed in skin biopsy by intraabdominal nerve fiber thickness density and the QSAR test. It produces a limited disability. So evaluation wise, nerve conduction studies. So if we do nerve conduction studies, we can find out the large fiber neuropathy deficit, but small fiber neuropathy, it couldn't be found out in the case of NCS test because conduction velocities of small sensory fibers are too slow for their responses to be captured on the routine nerve NCS. So should be done to exclude large fiber neuropathy and bilateral S1 radiculopathy. So peripheral neuropathy frequently affects both large and small fibers. When associated with diabetes, CTDs, connective tissue disorders, amyloidosis, if large fiber neuropathy is detected on NCS test, no need of confirmation for small fiber neuropathy. So skin biopsy, it is a gold standard for diagnosing small fiber neuropathy, used to evaluate intraabdominal nerve fiber density, IEN, FD. It is more sensitive and less invasive compared to sural nerve biopsy. Mainly, we do skin biopsy in cases like non-length dependent small fiber neuropathy or focal small fiber neuropathy. So sites of biopsy are, we will take a 3 millimeter punch biopsy, just tell you, which is about 7 to 10 centimeters above the lateral malleolus. We took 3 biopsies from those sites and we send for the sampling, and we will see the intra-nerve fiber density. So these two are the upper 2 images, which show a normal individual with normal nerve fiber density. Below 2 are the images of a diabetic patient, which show a decrease in the intraabdominal nerve fiber thickness density. So next, here comes the autonomic testing. We proceed with QSAR test, that is quantitative pseudomotor axon reflex test, done if a patient complains of any sweating abnormalities, that is distal hypohidrosis and proximal hyperhidrosis. So it measures the sweat output in response to acetylcholine. It reflects the function of postganglionic sympathetic unmyelinated pseudomotor nerve fibers. So another test is cardiovascular autonomic testing for orthostatic intolerance and palpitations and tachycardia. So here is a sweat gland, a normal sweat gland innervation. After giving acetylcholine, first image is a normal patient. Second image shows decreased density in the second image. So associated conditions. So as I have mentioned earlier, peripheral neuropathy, especially small fiber neuropathy, the beauty lies in coming to a diagnosis. So first style of investigations are CBC, RFT, LFT, lipid panel, ESR, CRP, ANA, thyroid profile, HbA1c, and 2-hour glucose tolerance test. Next is extractable nuclear antigen for Sjogren syndrome, B12 levels, methyl malanoic acid levels, homocysteine levels, and tissue transglutaminase anti-gliadin antibodies for celiac disease, HIV and HCV antibodies. Next comes the second tier of investigations, serum ACE levels for sarcoidosis and vitamin B1 and B6 levels, copper levels, fat PET analysis for systemic amyloidosis, paraneoplastic antibody panel, ganglionic acetylcholine receptor antibodies to evaluate autoimmune autonomic ganglionopathy. And third and last tier of investigations are, as it mainly pathophysiology involves the sodium channels, sodium channel 9A and sodium channel 10A genes to rule out hereditary small fiber neuropathy, and GLA for to rule out Fabry's disease, and transferritin gene for familial amyloidosis, and ABCA1 gene for Tangier disease. So next is large fiber neuropathy. Large myelinated fibers which are rapidly conducting, A alpha and beta fibers are affected. It carries proprioception, vibration, touch, and somatomotor. It can be sensory and motor fibers. So predominant involvement is numbness and tingling. Patient describes this sensation as sensation of walking on cotton floors, feeling strange, inability to turn the pages of a book, or inability to discriminate among the coins when given hand. Next is sensory ataxia, like waddling like a duck. And along with that, there will be wasting of the small intrinsic muscles of feet and hands with hamatodeformities and weakness of hands and feet. So on examination, there will be abnormal DTRs and impaired vibration sense, which is the first objective evidence, and impaired touch and joint position sense. There will be increased blood flow with the hot toes. Along with that, there will be loss of joint position leads to pseudoarthrosis, that is involuntary sinus movements of fingers and hands when arms are outstretched and eyes are closed. Along with that, positive Romberg sign, and long-standing large fiber neuropathy presents with shortening of the Achilles tendon with pes sapinis. And these patients are, as I mentioned earlier, these patients are at the higher risk of falls, fractures, and development of Charcot neuroarthropathy. So on doing nerve conduction studies, there will be low amplitude snaps and CMAPs, but distal latencies and conduction velocities are only minimally affected. So EMG will reveal acute or chronic denervation changes. Next is the axonal neuropathy. So this mainly, this is a axon degeneration. Numerous causes have been found out. There are metabolic, vascular, toxins, vasculitis, and inherited causes. This axonal neuropathy can be acute, subacute, and chronic. This will be predominantly length-dependent distal symmetrical polyneuropathy. So symmetrical distal loss of sensory and motor function in the lower extremities that extend proximally in a graded manner. It results in sensory loss in the stocking-like pattern, distal muscle weakness and atrophy, and distal loss of limb reflexes. So we have to find out the cause, whether it is acute, subacute, or chronic. So for acute or subacute axonal neuropathy, we have to think predominantly of the infectious causes and toxins. Infectious causes like West Nile virus, rabies, HIV, CMV, and Lyme disease. Toxins like arsenic, thallium. Next is porphyria. Chronic, predominantly motor dependent is Charcot-Marie-Tooth disease and distal hereditary motor neuropathy. And finally, chronic distal symmetrical, predominantly sensory polyneuropathy. So there are some drugs which causes predominantly axonal neuropathies. These are chemotherapeutic agents like vincristine and paclitaxel, nitrous oxide, colchicine, isoniazid, hydrolazine, pyridoxine, lithium, alpha interferon, dapsone, phenytoin, cimetidine, disulfiram, chloroquinol, and ethambutol. So on performing the NCS, this axonal neuropathy will show low amplitude snaps and CMAPs, but distal latencies and conduction velocities are only slightly affected, as it is predominantly large fiber neuropathy. EMG shows acute or chronic denervation changes. Here, axon regeneration proceeds at a rate of 2 to 3 millimeters per day. Hence, recovery with this axonal degeneration will be delayed or often incomplete. So next is demyelinating polyneuropathy. So it predominantly presents as segmental demyelination or myelinopathy, that is injury to the myelin sheath or Schwann cells with sparing of the axon. So axon will be spared, surrounding myelin sheath will be damaged. So it can be acquired or inherited, can be acute or chronic. So causes of acute demyelinating polyneuropathy, AIDP, Aman and Zika virus. Causes of chronic primary demyelinating polyneuropathy, CIDP and its variant. Chronic inflammatory demyelinating polyneuropathy and its variant, anti-MAG myelin-associated glycoprotein, multifocal motor neuropathy, Charcot-Marie-Tooth disease type 1A, OM syndrome. Next is Gallo polyneuropathy. Next is monoclonal gammopathy of undetermined significance, and Waldenstrom's macroglobulinemia. So what are the drugs causing demyelinating polyneuropathy? Amiodarone, chloroquine, hydroxychloroquine, golden taxols, and toxins are arsenic, hexane, bucthon, tellurium, and diphtheria toxin. So here you can see chemotherapeutic agents are predominantly causing involvement of axons compared to myelin sheath. So clinically, there will be early generalized loss of reflexes, disproportionately mild muscle atrophy in the presence of proximal and distal weakness, neuropathic tremor, and palpably enlarged nerves. So on performing the NCS, there will be reduction of nerve conduction velocities to less than 70% of the lower limits of normal with relative preservation of CMAPs and SNAP amplitudes. Other features include motor conduction block, temporal dispersion of CMAPs, and markedly more prolongation of distal motor and F wave latencies. So here comes the differences between axonal and demyelinating neuropathy. So axonal is predominantly gradual and insidious onset, whereas demyelinating may be acute or subacute. So axonal neuropathy, so large and long axons are affected early, hence initially lower extremities are affected. Demyelinating is a diffuse process, starts in the lower end but not always distally. So axonal neuropathy follows a stocking and glove pattern of sensory motor loss, results in symmetrical distal clinical signs in legs and arms, whereas demyelinating neuropathy presents as generalized weakness with mild sensory loss. So axonal is distal involvement, demyelinating is proximal with distal involvement. Axonal, there will be early loss of ankle reflex, with proximal tendon reflexes relatively being preserved, whereas demyelinating, all reflexes are lost early in the disease. So muscle wasting is the diagnostic feature of axonal neuropathy, whereas it is relatively absent in the case of demyelinating neuropathy. So next, moving on to evaluation. So CSF proteins, on doing a CSF examination, they are normal in the case of axonal neuropathy, and these are elevated in the case of demyelinating neuropathy. Cranial nerves are less involved in axonal, more common involvement in demyelinating neuropathy. Slow recovery and incomplete recovery, poor prognosis for axonal neuropathy, rapid recovery and good prognosis for demyelinating neuropathy. Residual deformities, because recovery is incomplete in the case of axonal, residual deformities are less common, relatively less common in demyelinating neuropathy. Nerve conduction studies are normal or slightly lower. Nerve conduction studies are normally slow. Predominant causes of axonal neuropathy are toxic, metabolic, HIV, diabetes, and Charcot-Marie-Tooth disease type 2. For demyelinating neuropathies, GB syndrome, CIDP, diphtheria, and motor neuropathy with conduction block. So a short note on treatment of neuropathy, predominantly for neuropathic pain. So management of neuropathic pain should be two-pronged, mainly targeting the symptom relief and addressing the underlying causes. So along with that, treatment must be individualized accounting for the comorbidities, tolerability, and the nature of pain, whether it is localized neuropathic pain or widespread neuropathic pain. So first-line therapies are gabapentinoids, which are predominantly gabapentin and pregabalin. Next comes the SNRIs. Next in line are TCAs. SNRIs are duloxetine and venlafaxine. TCAs are amitriptyline and nortriptyline. So gabapentinoids, they bind to alpha-2 delta subunit of the voltage-gated calcium channels, thereby reducing the excitatory neurotransmitter release. Compared to pregabalin and gabapentin, pregabalin has got a rapid onset of action, well tolerability, and predictable pharmacokinetics. So according to AN and Neurology, American Academy of Neurology 2022 guidelines, pregabalin has got level A evidence compared to gabapentin, SNRIs, and TCAs. So almost pregabalin has got level A evidence, so it is almost drug of choice for peripheral neuropathy. So next comes the SNRIs. These are mainly useful for patients who have got comorbid depression, anxiety, or fibromyalgia. Next in line are TCAs. They work beautifully, but these are limited by their anticholinergic side effects like dry mouth, dry eyes, urinary retention, and orthostatic hypertension and cardiac risk, especially in the case of elderly. So topical applications for localized neuropathic pain include lidocaine 5% patches and capsaicin patches and gels. These are particularly useful for localized post-surgical neuropathy or post-herpetic neurology. So there is a debate whether monotherapy, combination therapy, or sequential therapy. So combined overall these three, combination therapy is more helpful compared to the monotherapy. So gabapentin, we start with a dosage of 300 mg, maximum dosage is 3,600 milligrams. Pregabalin is now for minimal dosage is around 50 mg is also available. So maximum dosage is 600 milligrams. Topiramate, which is an anticonvulsant, we can start with 25, we can go up to 400 milligrams. It is a beautiful weight loss agent actually, but there is more paresthesias. Most worrying symptom for topiramate is paresthesias. Amitriptyline and nortriptyline, both are TCS. We can start with 20 milligrams and we can move on maximum to 100 milligrams. And local applications are lidocaine 5% patch, 3 patches. As this is a local application, we will see more of local edema, erythema, and burning, and no systemic side effects. Capsaicin 0.75% topical anesthetic, and tramadol, which is an opioid, semi-synthetic opioid analgesic. If not unresponsive to these gabapentinoids and all, we can give a shot of tramadol, 50 milligrams to start with, and to move on 400 milligrams. Next is a mexiletin, which is a voltage-gated sodium channel blocker. Initially, we start with 200 milligrams, and maximum dosage is 600 milligrams. So, non-pharmacological treatments for peripheral neuropathic pain, that is mainly neurostimulation, that is transcutaneous electrical nerve stimulation, which is a non-invasive method of neuromodulation using cutaneous adhesive electrodes to apply pulsed electrical stimulation that stimulates predominantly A-beta fibers with the goal of indirectly inhibiting the nociceptive pain transmission in the spinal cord DRGs. Next is spinal cord stimulation, mainly for refractory neuropathic pain, and CBT, cognitive behavioral therapy, for chronic pain with mood disturbances. So finally, to conclude, peripheral neuropathy, as I said earlier, the beauty of peripheral neuropathy lies in identifying the cause of peripheral neuropathy. Next, whether it's treatable or not, whether it's reversible or not, and treatment always should be individualized, either monotherapy, combined, or sequential. Predominantly, combination therapy works well compared to the mono and sequential therapy. Thank you, sir.
Thank you, Bhavana. So, Rahul, please introduce Dr. Alladi Mohan garu.
Good afternoon, all the delegates. The next presentation will be by Dr. Alladi Mohan garu. He is a professor of medicine, Department of General Medicine, SIMS, Tirupati. He is going to deliver Dr. Alladi Mahadevaya and Annapurnamma Memorial Oration. He is installed by Dr. Alladi Venkatesh. Dr. Alladi Mahadevaya are conducting deliveries in the St. Joseph Hospital very early era of doctors in Nellore. And his wife Annapurnamma garu is a social activist. And now I am going to do a brief introduction about Dr. Alladi Mohan garu. Dr. Alladi Mohan garu did his MD General Medicine in AIIMS, New Delhi, and he got many degrees like FRCP from Edinburgh, FAMS from India, and FCC in USA. He is working as Dean of Faculty, SIMS University, and Senior Grade Professor, Department of Medicine, SIMS Tirupati, Andhra Pradesh. He is the best outgoing student, and he achieved 25 gold medals and prizes, along with Best Teacher Award in 2011 from Government of Andhra Pradesh. He did 355 publications in reputed international and national journals and edited 4 books, including the popular textbook of tuberculosis and non-tuberculous mycobacterial diseases, 3rd edition. Along with that, he is the member of International Advisory Board, Hutchinson's Clinical Methods, 25th edition, that is 2022, and 24th edition, that is 2017. He worked as past chairman in 2018 and 19 Andhra Pradesh, chapter of Association of Physicians of India. Along with that, he is an external examiner in MBBS, MD Medicine, and DN Pulmonary Medicine since 30 years. Thank you, sir. Thank you, Mohan, sir.
I hope I'm audible loud and clear. Yeah.
Yes, sir. Go ahead, sir. Go ahead, sir. You're looking. Yes, sir.
I sincerely thank Ashok sir and the IMA for bestowing upon me this honor of delivering the Dr. Alladi Mahadevaya and Annapurnamma Memorial Oration today. It is one of those rare occasions where one Alladi will be speaking and delivering another Alladi oration. I have chosen the topic of the day's presentation to be my journey in tuberculosis. So in the next 45 minutes or so, that has been assigned to me, I will try to walk you through what my journey has been in tuberculosis. Many of the previous generation people from Nellore should be able to identify this building. If the younger ones are not able to, long ago there used to be a movie theater called Kanaka Mahal. Exactly opposite to Kanaka Mahal, this building was seen, and this building is the residence of Dr. Alladi Mahadevaya. This building has now become a mall, and the Kanaka Mahal theatre is no more. So Dr. Alladi Mahadevaya is one of the earliest well-known doctors from Nellore, and Annapurnamma Garu is a very well-known social worker who has contributed momentously for the welfare of the health and the society as well. It is indeed a privilege and an honor to deliver this oration today. I wish to declare that I have not received any funding for delivering this oration, and I have no conflicts of interest to declare. Carl Sagan, mathematician, physicist, astronomer from Cornell University, said, "They saw for us what we see for them. We see beyond them because we stand on their shoulders." I stand upon the shoulders of the people who mentored me, who taught me, who encouraged me, and who helped me in my incredible journey through tuberculosis. The beginnings go back to approximately 41 years ago, year of grace 1984 through 1990. Many of the august audience online today would perhaps recognize Sri Venkateswara Medical College, which is one of the older medical colleges in Andhra Pradesh today. My journey in tuberculosis started in this college. Professor Premanand is the name very well familiar to most of you. Professor Premanand, in a class discussion one day, had shown us a patient who had miliary TB in only one lung, unilateral miliary TB. Unilateral miliary TB is very rare. It's a chance event. And then when I had asked him as a third semester student what to understand more about this, he said, "Go to the museum and look at the specimens there." The pathology museum in the SV Medical College is a treasure trove in which I spent a lot of hours looking at the gross pathology specimens and trying to catch up with what the dead taught us the living. Thereafter, the interest in tuberculosis deepened. This is the All India Institute of Medical Sciences of 1991. This front appearance you don't see today. This is one of the older photos of that time. In the institute, I had the good fortune to see various facets of tuberculosis, and Corwin Hinshaw's textbook was very widely read in those days. And Hinshaw said that he even did not believe that TB control could be attained by medical means within the 20th century. That was the gloom prevailing at that point in time. And this was my first major work on tuberculosis. This was my postgraduate thesis. A very interesting story. When I told that Professor Jain Pandey, who is my thesis guide along with Professor Sharma, I told that I would like to do my MD thesis on TB. Boss said, "TB? It's gone or going. What do you want to do with a disappearing disease?" Then there was a double dhamaka. HIV, TB, drug-resistant TB, and whatnot. TB spiraled out. This particular work was a very weird application of what is called Bayes theorem. And this gentleman is Professor J.N. Pandey. This is me in 1991 at the All India Institute of Medical Sciences. So what had happened was, all the samples I had collected for the bronchoalveolar lavage samples, I had collected 6 months upfront for analysis. They completely got burned in a major fire accident that occurred, burning out 5 floors of one wing of the AIIMS in April 1993. The option was to do something different rather than going for the molecular testing. So Professor Pandey asked me to make a mathematical model applying Bayes theorem, and that model is this one. So when you encounter a patient with TB, suspected TB, you can, if no test is positive, you can start treatment with anti-TB drugs empirically, or wait till the smear is positive, or do something else, which is early bronchoscopy in this case. Each path has probabilities, and at each node, the circular node is a chance node, the square node is a choice node. Here you make a choice, here something happens. So it can be TB or not TB, it can be good response, poor response. So you have utilities at the end of the paths. And we showed that as the pre-test probability of TB shown on the x-axis goes beyond 0.4, that is 40%, the early bronchoscopy, if you see when the pretest probability is low, early bronchoscopy has the highest expected value and is supposed to be the best option. But once the pretest probability goes above 0.4, empirical ATT, which everybody is doing these days in practice, takes precedence over the early bronchoscopy. This paper got published without a peer review, straight acceptance in one of the best journals, the Quarterly Journal of Medicine. At that time, it had an impact factor of 5. So this is Professor Pandey, 2012, in the NAMSCON, National Academy of Medical Sciences. I was the youngest recipient of FAMS awarded by the NAMS, and that was the Golden Jubilee oration which I had delivered in the NAMSCON 2011. The interest in the pursuit of tuberculosis further enhanced, and Professor Sharma, who has been along with me in this journey from 1991 through today as well, he was a major influence. He has been a major influence on my life. And we then published this adult HIV negative miliary tuberculosis series. This is a often quoted paper. This was abstracted in the Yearbook of Diagnostic Radiology in 1997. We showed for the first time in the world that what is a cryptic miliary tuberculosis. In cryptic miliary tuberculosis, chest X-ray is normal. See the upper panel in the figure? This chest X-ray is normal. This is our colleague, a medical doctor with a prolonged fever. No test was positive. And in those days, a new CT scan was set up in the All India Institute. A new machine had come, so it will give HRCT cuts. So we did the HRCT cuts, chest X-ray normal, CT chest done on the same day of miliary pattern, and we did, as we were evaluating, one small node came up here. We biopsied the node. It shows granulomatous inflammation suggestive of TB. So this is for the first time in the world we have demonstrated in a life. This used to be an autopsy finding. This patient will die undiagnosed, then the autopsy will show miliary tuberculosis. We showed for the first time that it is a situation where you have a normal chest X-ray and a miliary pattern on the CT, cryptic miliary tuberculosis. This patient had come to us for treatment of resistant Kala Azar. He was given sodium antimonyl sulfate, no response. We admitted him to give amphotericin B. One Sunday morning, when the ward was being cleaned, suddenly this person developed severe breathlessness. We got a portable X-ray done. It shows bilateral, classical frontal opacities. This is the textbook picture of ARDS. This, we were having a discussion with whether to intubate or not. Patient started gasping. We intubated him. We put him on ventilator. Then we sent the endotracheal aspirate for AFB. That tested positive. While on ventilator, the airspace consolidation cleared and the miliary pattern emerged. And we did a liver biopsy of this patient, which showed a classical miliary pattern. This is MTB ARDS, miliary TB in HIV negative person with acute respiratory distress syndrome. So I wrote up this paper. Our experience with ARDS caused by miliary TB. Everybody knows sepsis, multiple organ dysfunction syndrome, polytrauma, burns. These are the common causes of ARDS. But TB as a primary cause of ARDS is not well established. We provided hard data for the first time in this issue. Then I moved over to Tirupati, 1998. The new block, which is chock-a-block full these days, was just being constructed. And we did a further extension of the work on TB and miliary tuberculosis. And till today, this series of ARDS in TB that is published in the International Journal of TB and Lung Diseases is the largest series in the world today. 20 years down the lane from the date of publication, this is the largest series in the world today. We showed that the patients who present with TB ARDS can be diagnosed definitively by doing the ET aspirate, then for AFB, now gene expert. So miliary TB in adults has been a haunting story, considered a pediatric disease. It was not widely understood or appreciated. So we have this classical documentation of ARDS in miliary TB. Extensive conglomerate lesions, more than miliary in pattern. And this is again an often quoted paper. Around 1998, while I was leaving the institute, we had an idea. Why should the white man teach us TB? Why should these Croftons, Feldmans teach us about TB? We see TB, we should teach the world. So we thought of bringing out our own textbook of tuberculosis. Year 2001, the first edition came out. This was reprinted 4 times. In 2009, we came up with the second edition of the textbook. This was also reprinted 4 times. Then in 2019, just before COVID hit us, the third edition came. This was also reprinted 3 times. And the third edition expanded to include non-tuberculous mycobacterial diseases as well. Then, if you look at the foreword of the third edition by Mario Raviglione, Mario Raviglione is the director of Stop TB, the World Health Organization. He has mentioned that the fact that it is conceived and produced in India, the country which not only has the highest TB burden in the world, but has also contributed to many of the major advances in TB care and control over the past decades is symbolic. This is the most well-read tuberculosis textbook across the world, be it Beijing, Berlin, Boston, or Bhatinda. This is the #1 textbook which is studied for knowing about tuberculosis. The 4th edition is on the way, and end of 25 we expect it to be available for the discerning readers. Statistics in medicine has been my fascination and has been the core of my research applications. And this is one of the very early papers of ADA in TB pleural effusion. Today, 3rd semester student will be telling diagnosis of TB pleural effusion, ADA is useful. But the fact is, see this handwritten diagram, no statistical package, no laser printer, hand-drawn image of the plot of sensitivity versus 1 minus specificity, wherein we could show that at a cutoff of 36, the trade-off between sensitivity and specificity were optimal. That was the first paper where ROC curve method was used to derive the cutoff of ADA in the diagnosis of TB pleural effusion. This is David Schlossberg's textbook. David Schlossberg's textbook, through the 6th and 7th editions, we had the honor of contributing the chapter on biliary TB. Dr. Schlossberg is no more. The 5th edition of Dr. Schlossberg's textbook carried our research data as specific tables in this chapter, and the 6th and 7th editions of this textbook, the chapter was written by us. It is an international textbook on tuberculosis. Then we further continued our journey with miliary tuberculosis. Further, the miliary tuberculosis, as is seen in 2017, in what are the various challenges in the diagnosis and treatment, this was published. Then there is a question of organ involvement in TB. Many of you perhaps would have seen this cartoon. In almost every year's journal club by TB-CD MD or Medicine MD, or for that matter, any talk on TB, whether it is a national epicon or NAPCON, this is invariably shown. This is invariably shown. So the upper panel shows organ involvement in HIV negative or immunocompetent people. The bottom panel shows organ involvement in HIV seropositive or immunosuppressed individuals. This we published in the Indian Journal of Medical Research, which is published by ICMR, and in the year 2013, ICMR looked back on the occasion of its 100 years of publication to identify the 13 top articles that were published during the last 50 years in the journal and ranked them 1 to 13 as the most cited articles. This paper was ranked 8th. In a 50-year history of a journal, 8th rank, single-digit rank is reasonably good. And this paper has the unique distinction of being republished one more time in 2004. This was originally published in 2004. It was republished in 2012. Again, the full article was published as the most cited article. This is the Indian extrapulmonary TB guidelines. There have been guidelines for treatment of TB. Often, the guidelines for treatment of TB are extrapolation of the guidelines that were developed for the treatment of extrapulmonary TB. And these guidelines have always been an indirect application to extrapulmonary TB. But we thought we should have our own extrapulmonary TB guidelines. Extrapulmonary TB is often treated based on the image, based on the clinical findings, radiological findings. People look at the X-rays or ultrasound or CT, and then they start treating. But that's not how it is to be done. The correct way to diagnose extrapulmonary TB is to establish, one, where is the disease? 2. What is the disease? Where is the disease is known by what is known as clinical examination, clinical localization. What is the disease is established by biopsy, fluid aspiration, and diagnostic testing. So, in association with the Ministry of Health and Family Welfare, Government of India, and the Central TB Division, and the London School of Tropical Medicine and Hygiene, and the World Health Organization country office, we came up with the Index TB guidelines. These guidelines were released in 2016 in the boardroom at the All India Institute, and I was the lead for the TB and the heart. So our group worked on the evidence available for TB and the heart, and these guidelines are often referred to as evidence-based guidelines for the diagnosis of extrapulmonary TB and the treatment of extrapulmonary TB. For example, lymph node TB, how long you want to treat? TB meningitis, how long you want to treat? What is the duration of treatment? When will you give steroids? When you should give steroids? When you may give steroids? All these issues were addressed in these guidelines. Then we published this as a policy document in 2017, and I have been one of the members of the drafting committee of these guidelines, and this has been another landmark in my journey in tuberculosis. The Government of India then came out along with the WHO country office for India with regard to what is called as standards for TB care in India. So I was one of the reviewers for the standards of TB care in India, and this book is also a benchmark as far as TB care is concerned in the programmatic approach or outside the programmatic approach. Then during COVID, we thought, why don't we look at what is happening in extrapulmonary TB? What has been the diagnostic changes? We have moved forward from smear examination and LJ solid culture, Lowenstein-Jensen solid culture, to we have moved forward to expert MTB-RIF, or the gene expert in the diagnosis of tuberculosis. The turnaround time for the test is 2 hours, coupled with the line probe assay. These two have given us the diagnosis of, is it TB? Is it drug-resistant TB? Is it multi-drug resistant TB? So this evidence-based systematic review and meta-analysis of diagnostic and therapeutic modalities for extrapulmonary TB it has received more than 300 citations in 3-4 years of its publication. This is a very interesting story. Many patients, my friends in cardiology, who perhaps may not be in the audience today, they encounter patients with idiopathic ventricular tachycardia or idiopathic heart failure, very common. Often the cause of ventricular tachycardia is not known, and the patients are labeled as idiopathic. So I always felt that this is not exactly idiopathic, only that we are not looking at it in the depth in which it has to be approached. So we described a new entity, new nosological entity, which is idiopathic ventricular tachycardia with tuberculosis lymphadenopathy. We studied patients very systematically. This is the method of diagnosis of TB: molecular test, smear, culture. Molecular test, smear, culture. We looked at whether there was peripheral lymph node or mediastinal lymph node involvement was there. Some patients had both cervical as well as mediastinal lymphadenopathy. Some patients had only mediastinal lymphadenopathy. So then we looked at the cardiac MRI, whether there is a myocardial scar in the baseline MRI, number of episodes of VT, what was the LVEF. We did a PET CT to compare the uptake in myocardium and lymph node. This is where these patients were treated only with anti-TB drugs, only with anti-TB drugs. and see the change in the number of episodes of the ventricular tachycardia. At baseline, more than 35, 31. With anti-TB treatment, it became 0. It's a new nosological entity, new disease entity, which the Journal of the American College of Chest Physicians, I am the first author for this paper, the Journal of American College of Chest Physicians rushed it through as a early to publish article, and it is now a practice changing protocol. Whenever you see a VTAC, look at evidence of lymphadenopathy or evidence of tuberculosis. And this is the timeline of tuberculosis. Since the time Andrea Vesali introduced post-mortem examination and Fracastorius declared consumption to be contagious, we've come a long way. MDR-TB, XDR-TB, molecular diagnostics, etc. But it took thousands of years for humans to identify the causative organisms and another 60 years to arrive at effective treatment. Towards the end of the 20th century, the twin disaster of HIV and TB, XDR, MDR, TB, seemed to be on the verge of threatening to ruin the mankind. While it is heatedly debated that TB is resurging, this may hold true for the industrialized countries. But in the third world countries like us, TB never ever disappeared to resurge later. TB has always been with us, only revealing itself every now and then, making us wiser. So, quo vadis, whither goes thou? It started with NTP in 1962, which became RNTCP in 1993. And silently, in the noise of COVID, it became the National TB Elimination Program at 2020. Whole world wants to eliminate TB by 2035. India wants to do it this year. Is TB going, or gone? For TB to be gone, it's not enough that we doctors alone diagnose and treat TB. It is the responsibility of the society. It is the responsibility of every responsible citizen of this country to join hands in the battle against TB. With the focus shifting now to the other poor cousin of M. tuberculosis, these are the non-tuberculous mycobacteria. We did a major 5-year prospective study, a multicentric study of non-TB mycobacterial diseases that is funded by the ICMR, and the 13th edition of the API textbook of medicine, which is about to come out in 2 months' time from now. I have contributed the chapter along with Professor Sharma on the non-TB mycobacterial infections. The journey against the journey in pursuit of tuberculosis has been wide. It has been a turbulent path. It has not been easy. And before I shortly close this oration, I would like to place on record the heartfelt thanks for the persons listed here who provided me archival material about Dr. Alladi Mahadevaya and Annapurnamma. The Dr. Nagalakshmi and Dr. Praveen are the grandchildren of Dr. Alladi Mahadevaya and Annapurnamma Garu. And Yasya Amatam Tasya Matam Yasya Matam Saha Naveda Yasmat Vijanatam Avignatam Avijanatam Vignatam. I conclude my presentation at this point in time. I only request everyone and appeal to everyone to join hands in the incredible fight which we are still facing against tuberculosis. Let's all work together and eliminate TB from the face of the earth. Thank you and namaste.
Thank you, sir. Thank you very much for giving an elaborate lecture on your journey in tuberculosis. And Dr. Alladi Mahadevaya and Mrs. Annapurnama Memorial Oration. Thank you once again from IMA Nellore, sir. Thank you, sir. Now, Dr. G. Shobha Rani, Associate Professor, ACSR Government Medical College, will enlighten us on approach to anemia. Dr. G. Shobha Rani is presently working as an Associate Professor. She has completed her medicine from SVMC Tirupati. Now I request Dr. G. Shobha Rani Garu to give her lecture. Thank you.
Good afternoon, sir. Sir, shall I start my video, sir? Sir,
Go ahead,
am I
ma'am. Go
audible?
ahead. Yes, ma'am. Go ahead. Share your
Sir, I
presentation.
am audible, no, sir?
Yes, yes, ma'am. Share your
Yes,
presentation.
madam. Yes, madam.
Okay, sir. Sir, my video is also audible, sir? Visible, sir?
Yes, ma'am. Yes, ma'am.
Okay, sir. Sir, good afternoon, sir, everyone.
Make slideshow, madam. Click on slideshow.
Yes, yes.
Bottom right side.
Yes.
Go ahead, ma'am.
Okay. Sir. So today my topic will be regarding approach to anemia. As all of us know that anemia is the most common thing often recognized by our abnormal screening test, because why I chose means anemia is the most common thing which we come across regularly in our clinical practice, and most of the people by and different age groups might have come across the same point with some types of anemias, because this is the basic thing which is responsible to fight against infections or for host defense, everything, I feel. But it is in severe anemia, sometimes it may be simple and nutritional can be dealt. Sometimes if not treated properly or diagnosed properly, it may lead to life-threatening conditions like heart failure, and sometimes severe anemia can be life-threatening. So a little bit focus on how to diagnose anemia and how to approach for the diagnosis. So before approaching for diagnosis of anemia, let us know the definition of anemia. What is the WHO guidelines for defining anemia, and a little bit thing about pathological classification. Then coming to anemia definition, it is a significant reduction in the circulating red cell mass or the hemoglobin content, resulting in a lower ability for the blood to carry oxygen to the body tissues. So a significant reduction in the red cell mass and the hemoglobin content, thereby resulting in the lower oxygen carrying capacity, is defined as anemia. So what are the WHO guidelines for the definition of anemia? So according to the age group, WHO has given the grading like 6 months to 5 years, less than 11 grams per dl, and 5 to 11 years, less than 11.5 grams per deciliter, and 12 to 14 years, it is less than 12 grams per dl. More than 15 years, that is adults, in females, it is less than 12. In males, it is less than 30. In pregnant females, it is less than 11 grams per deciliter. So depending on this level of hemoglobin percentage, again, it is graded into grade 1, grade 2, and grade 3. When the HB is 11 grams per deciliter, it is mild anemia. When it is between 8 to 11 grams per dl, that is moderate anemia, grade 2. Less than 8 grams per deciliter is severe anemia. So this is hematopoiesis, which is responsible. It is the process. It is the whole thing where the mature erythrocytes come out from crossing through the several stages. This is the process by which the formed elements of blood are produced from the hematopoietic stem cells. In adults, bone marrow is the main site for the hematopoiesis. In fetals, it is from yolk sac, liver, and spleen before bone marrow is takes up for the marrow production. So this is the main, the RBC production It through all these stages, from the primitive hematopoietic stem cells, it transforms into poor erythroblast, early normoblast, late normoblast, reticulocyte, and erythrocyte, which is the main erythrocyte where the HB is, where the hemoglobin will be there in the erythrocyte. So this mature erythrocyte remains in circulation for about 120 days before being engulfed and destroyed by the phagocytic cells of the RES, that is reticular endothelial system. Each RBC has numerous hemoglobin molecules, which again has 4 globin chains, and each globin chain has heme group containing iron for the oxygen binding. So all this is the genesis of the erythropoiesis. So the critical elements in erythropoiesis is mainly the erythropoietin production, iron availability, the proliferative capacity of the bone marrow, and effective maturation of the red cell precursors, because erythropoietin is the physiological regulator of the red cell production. It is a glycoprotein hormone mainly produced and released by the peritubular capillary lining cells within the kidney. The fundamental stimulus of EPO is the availability of oxygen for tissue metabolic needs. Whenever there is an impaired oxygen delivery to the kidney, it can result from a reduced cell mass leading to anemia. So it is directly proportional. Whenever there is a decreased anemia, decreased oxygenation or hypoxia, there will be raised levels of the EPO, that is erythropoietin. It acts by binding to specific receptors in the on the surface of the marrow, that is erythroid marrow, and the precursors inducing them to proliferate and mature. So when with the EPO stimulation, red cell production increases by 4 to 5 folds and within 1 to 2 weeks. But this mainly needs, this erythropoietin production mainly needs the presence of adequate nutrients, especially iron. So that's why all these things are important for the erythropoiesis. The functional capacity of the erythron therefore requires normal renal production of the EPO and the functional erythroid marrow, adequate supply of substances like for hemoglobin synthesis. A defect in any of these key components can lead to anemia. So this is just a little bit introduction before going for our evaluation, because these steps, in each and every step where it is deficient, it can lead to anemia. So what is the classification? So the basic classification, how the anemia can be classified into. So this is a pathophysiological classification, can be divided: anemia due to blood loss, anemia due to impaired red cell formation, and anemia due to increased red cell destruction, that is hemolytic anemias. So now we'll go with what are the causes of anemia due to blood loss. So it can be acute hemorrhage, which leads to blood loss and anemia due to chronic blood loss. Then coming to anemia due to impaired red cell formations, we can have cytoplasmic maturation defects and nuclear maturation defects. In cytoplasmic maturation defects, we have whenever there is a deficient heme synthesis, it can manifest as iron deficiency anemia. And whenever there is a globin deficient synthesis, then we can have a thalamic syndromes. And nuclear maturation defects are commonly vitamin B12 or folic acid deficiency, which seen in megaloblastic anemia. And other impaired red cell formation, other conditions which leads to impaired red cell formation or defect in the stem cell proliferation and differentiation, seen in aplastic anemias and pure red cell aplasia. So bone marrow failure due to systemic diseases like anemia of chronic disorders, like anemia of inflammation or any infections and disseminated malignancies, anemia in renal disease, anemia due to endocrine and nutritional deficiencies, and anemia in liver disease. All these conditions leads to chronic anemia, which and then bone marrow infiltration. We have lymphomas, leukemias, and multiple myelomas. And congenital anemias like sideroblastic anemia and congenital dyserythropoietic anemias. So these are all decreased. Next, coming to anemia due to increased red cell destruction. So increased red cell destruction, we have intracorpuscular and extracorpuscular defects. So intracorpuscular defects are whenever there can be an abnormal hemoglobin and metabolic abnormalities and membrane or cytoskeletal defects. In thalassemia, sickle cell anemia, and unstable hemoglobin variants are where we see the abnormal hemoglobin. and metabolic abnormalities like G6PD deficiency, pyruvate kinase deficiency, and cytoskeletal or membrane defects like hereditary spherocytosis and hereditary elliptocytosis. And coming to extracorpuscular defects, they are immune-mediated and mechanical trauma, hypersplenism, and reaction to secondary to inflammation by the, invading the pathogens. The example is malaria. So immune-mediated or autoimmune hemolytic anemias, acute or delayed hemolytic transfusion reactions, and malfunctioning of the cardiac valves is a mechanical trauma. So these are all the causes for the pathophysiological causes for the we classify in these grounds. Then after knowing the basic thing regarding anemia, its classification and erythropoiesis, let us come to the topic proper, that is approach to anemia. So in approach to anemia, we need a good history. We have to elicit the history and the proper clinical examination with the supported laboratory investigations. As all of us know that history taking place an important role in diagnosing any disease, which is very, very important, followed by the clinical examination. So with that, we get a proper history and clinical examination, thereby we can go for the proper diagnosis and the treatment. So the history taking, we have to, starting from the in history, we have to know about the symptoms, and thereby in examination, we have to elicit the signs. Most of the patients with chronic progressive anemia, they may present to us with fatigue, the soft stamina, that is generalized weakness or breathlessness, and tachycardia. Tachycardia in the form of palpitations, the patient may complain to us. There may be a pallor of the skin. Some patients, they complain that my skin has become pale, my nails also pale, like that somebody can complain. And headache, and sometimes with giddiness also, with the history of giddiness, they can present to us. And when it is anemia severe, there can be signs of heart failure, including edema, increased, raised JVP. And then examination, we can, on auscultation, we can hear the systolic flow murmurs. And other symptoms include, whenever there is a blood loss, 10 to 15%, there is vascular instability, more than 30% loss, pastoral hypertension and tachycardia, and more than 40% loss, the patient may present with hypovolemic shock, confusion, dyspnea, diaphoresis, tachycardia, and hypertension. This we can see in the acute blood loss. And in hemolytic anemia, sometimes a patient present to you with intravascular hemolysis, back pain, hemoglobinuria, and the signs of renal failure. And history, apart from all these symptoms, we have to elicit the history, not only with the complaints what the patient has told to us. So we have to focus on different causes of anemia, which are associated causes. And then we have to elicit history regarding any history of fever is there. So suspect and infections, neoplasms, and collagen vascular diseases. Whenever there's a history of jaundice, this is yellowish discoloration of eyes, think of any hemolysis. And ask for the history of bleeding also, whether it is from vagina or bleeding per rectum to exclude hemorrhoids or any DUBs or any other bleeding disorders can also be there. So history of bleeding we have to ask. Then history of weight loss, that is regarding the malabsorptions and any infectious metabolic or neoplastic conditions we have to rule out. We have to focus in these symptoms also. And we know certain diseases which cause anemia. They are of gastric ulcerations, which can lead to the bleeding, internal bleeding can be there. Sometimes microbleeds can be there, and rheumatoid arthritis and renal failure. So these are, and apart from all these conditions, this is all in the history. And we have to focus on past history also. So we have to know regarding any blood transfusions are there in the past to exclude such diseases like thalassemias, any drug intake is there, and certain drugs which cause anemia, or whether the patient is on any chemotherapeutic drugs or any NSAID and certain anticonvulsants, all these drugs can cause anemia. And apart from drug intake, we have to ask regarding any exposure to tranquilizers, insecticides, any pain, solvents, and hair dyes. So drugs, like lead poisoning patient can present to us with anemia also. The hair dye anemia, it's a very rare cause, but particularly when the dyes containing paratoluidine can present with anemia, so which is a rare variant. Not only present history, past history, and we have to focus on any family history of anemia, jaundice, cholelithiasis, any splenectomies, bleeding disorders, and abnormal hemoglobins are present in any this history also is important in the family, so that we can rule out the hereditary spherositis or the thalassemias. And in females, have to ask regarding the menstrual cycle regularity, amount of blood loss, clots, and then obstetric history is also important. Any history of abortions or and in multipara, there's number of pregnancies which may lead to anemia. And then regarding personal history, focus on the diet. What is the appetite? Taking mixed diet or vegetarian. In vegetarians, commonly we expect the B12 deficiencies and consumption of either clay or laundry starch, which indicates there is a iron deficiency anemia, and the alcohol intake, which is a cause for megaloblastic anemia. So personal history, we have to focus all these things regarding its personal habits. And then bowel history. Is there any alteration in the bowel habits? That is to exclude any neoplasm. There is altered constipation or diarrhea. Is there any blood loss due to hemorrhoids and worm infestations? And regarding bladder history, any discoloration, any hematuria is there, any renal or hepatic diseases, and then urine, dark color urine in the paroxysmal nocturnal hemoglobinemia. So this is all about the history. So starting from the patient symptoms and our history and past history, personal history, and the family history. After that, we will proceed with the physical examination. First, we have to focus on the built-in nourishment, whether there is any malnutrition or signs of any chronic illness there or not. And we have to look for the skin and mucous membranes for the failure. So we can the lower palpebral conjunctiva on the nail beds and the hard palate and the mucous membranes. We check for the pallor and the icterus. Are there any abnormal pigmentations are there? Mostly in B12 deficiency, we can see a blackish discoloration over the knuckles, any petechia or purpura, spider nevi or palmar erythema, so that we can know about any liver disorders. Are there any liver cell failure is there, coarseness of hair, puffiness of face in case of CKDs, and nail defects. There can be chylonychia or chylonychia and leukonychia can be there whenever there is hyperproteinemia associated with anemia. So on general examination, all these things we have to focus, and further you have to look for any clubbing to exclude any hepatic diseases, neoplasms, or inflammatory bowel diseases. And then lymph nodes, palpable enlargement of lymph nodes, any infection or neoplasia, and bilateral check for any edema to exclude cardiac, renal, or hepatic diseases. And whenever there is a severe anemia with heart failure, also we can see the pedal edema. Whenever there is unilateral edema, any obstruction secondary to malignancies, we have to rule out. And this is all about local examination. Then coming to systemic examination. So in systemic examination, in cardiovascular system, we can have high volume pulses, tachycardia, and then cardiomegaly and systemic flow murmurs we can hear the systemic flow murmurs. And coming to respiratory system, there can be bilateral fine basal crepitations can be there, which is a sign of the heart failure. Anxiety, you can check for hepatomegaly, splenomegaly, and rectal examination followed by to exclude any hemorrhoids and the tumors. And in B12 deficiency, you can have neurologically, the position vibration sense will be lost, examination of cranial nerves and the deep tendon reflexes. This is all regarding the clinical examination. So we can identify. And then the supportive evidence is with the laboratory investigations. So the laboratory investigations, we have a complete, that is CBC, the complete blood count, reticulocyte count, iron supply studies, and the marrow examination. So in CBC, what we have to check, there is a red blood cell counts and red blood cell indices, white blood cell counts, and then cell morphology. So in red blood cell count, we have to check for the hemoglobin and hematocrit. And red blood cell indices, which gives us the information whether it's macrocytic or microcytic, it is hypochromic or normochromic by MCV, that is mean cell volume. Mean cell hemoglobin is MCH. Mean cell hemoglobin concentration is MCHC. Red cell distribution width is RDW. And in white blood cells, we look for the differential cell counts and the nuclear segmentation of the neutrophils, platelet counts. In cell morphology, we look for cell size, hemoglobin content, anisocytosis, poikilocytosis, and polychromasia. So then one important thing which have to, apart from CBC, you have to look for the reticulocyte count, the reticulocyte percent, and the absolute reticulocyte count, and the reticulocyte production index, which is very useful, and reticulocyte hemoglobin content. And regarding iron supply studies, we can know whether this is anemia of acute onset or anemia of chronic disease by estimating the serum iron, total iron binding capacities, serum iron, and marrow iron stains. So then coming to marrow, it can be done by aspiration or biopsy. So the erythroid granulocyte ratios, cell morphology, and the iron staining. By biopsy, we'll be knowing about the cellularity of the marrow and the morphology of the cells. So these are the different laboratory tests which give us an information whether it is due to iron deficiency or folate deficiency or any further defects are there, or anemia of acute inflammation or anemia of chronic disease. So after advising the CBC, then summer one chemistry panelists, we have to check for ESR. Whenever there is elevated, it suggests of chronic inflammation, and kidney function with serum creatinine, and liver function with AST and ALT, and hemolytic anemias. When we suspect, we can check for LDH, that is lactate dehydrogenase, bilirubin, and haptoglobin. So in hemolytic anemias, LDH and bilirubin will be elevated with the decreased haptoglobin, and further we'll confirm it by the Coombs test. So hematocrit, which is also an important thing. A number of physiological factors can influence the RBC, including age, sex, pregnancy, and smoking, and the altitude. So the hematocrit is otherwise, that is the PCV, that is the packed cell volume. It is calculated by percentage of red blood cells in total volume of the blood. So it has calculated and given it as at birth, the hemoglobin is 17. The hematocrit will be 52%. And in adolescents, it is 40% if the hemoglobin is 13. Adult man, HB 16 plus or minus, that is 47 plus or minus 6 is the hematocrit value. In adult women, HB 14 plus or minus 2, 42 plus or minus 6. And on average, 45 will be the average hematocrit percent. And during pregnancy, with the HB of 12 plus or minus, 37 plus or minus 6 will be the hematocrit percentage. So the next we have to calculate reticulocyte count. The immature RBC, about 1-2% of the red cells released from the red bone marrow. They circulate for about a day in the bloodstream before developing into a mature red blood cell. And the normal reticulocyte count is 0.5% and 2.5% of the total red blood cell count. It is used to estimate whether the marrow response and the function. So reticulocyte count will give us regarding the marrow response and the function. High reticulocyte count indicates that it works more, that is in compensation for anemia and blood loss and hemolytic anemias. And low reticulocyte count can be seen in conditions affecting marrow like aplastic anemia. So reticulocyte gives us an information regarding the marrow, whether it is functioning or any hyperfunction is there. So this is the important one. One more thing is the reticulocyte production index. It is some references will be a plus or minus, slightly they may differ slightly. It is calculated by the reticulocyte production index. It is calculated by the reticulocyte percent into the hematocrit by 45. That is the normal hematocrit by maturation factor. So the maturation factor is approximately it takes the time in which time it transfers into the RBC once released into the peripheral blood at a particular degree of anemia. So they have fixed the maturation factors. If the hematocrit is more than 40%, the maturation factor is 1. 30 to 39.9%, the maturation factor is 1.5. 20 to 29.9, the maturation factor is 2.0. less than 20%, that is 2.5%. So what is the use of this calculating the reticulocyte production index? If the reticulocyte index is less than 0.2, it is a hypoproliferative conditions. When it is more than 2 or 2.5, that is a hyperproliferative marrow, that is more bone marrow is responding appropriately. The hypoproliferative, we can look for the causes like anemia of chronic inflammation and any nutrient deficiencies like iron deficiency, B12 and folate deficiencies, and hormone deficiencies and CKD, hypothyroidism or hypogonadism, and marrow failure in conditions like aplastic anemia and marrow infiltration and marrow suppression. Then hospital acquired ammonia, mostly due to some procedures, that is iatrogenic anemias followed by some surgical procedures. We can surgical procedures, and sometimes they are attributed to the repeated blood samples also. Blood samples that is attributed, and whenever the index is more than 2.5, that is hyperproliferative. Hyperproliferative marrow can be due to acute blood loss, that is trauma, GI bleeds, or any drain bleeds. Hemolysis, any autoimmune hemolysis, or microangiopathic hemolytic anemias, or intrinsic RBC defects like sickle cell anemia, G6PD deficiencies, any infections, and hypersplenism. So sometimes in anemia, simple reticulocyte count can be misleading. So there we go for the reticulocyte production index, which corrects the this by factoring in the degree of anemia and the maturation time. So this is the importance of reticulocyte production index, which we call it as RPI. So there can be an acute blood loss. There cannot be, sometimes there is no reticulocytosis because the time required to increase the EPO production is very less. In subacute blood loss, we can have a moderate reticulocytosis. Chronic blood loss presented as iron deficiency. So what are the different RBC indices or the different RBC indices? This we can get, everybody can, but looking at the simple RBC, the total blood count, CBC, we can come to one conclusion whether it is microcytic or macrocytic anemias, whether it is hypochromic or normochromic. The simple CBC can give us a clue in our clinical or day-to-day praxis. So how to rate these findings? So MCV is a mean corpuscular volume. It measures the average size of the RBC. So the normal ranges of MCV is 90 plus or minus 8 femtoliters. To calculate MCV, turn into hematocrit by RBC count into 10 to the power of 6. By MCV will give us the size of the RBC, whether it is normochromic, it is microcytic, normocytic, or macrocytic. And MCHC, it measures the concentration of the volume of the packed RBC. The MCHC is calculated by HB into 10 by the hematocrit. The MCH will give the normal size of the RBC, that is MCH, that is mean cell hemoglobin, the average mass of hemoglobin per red blood cell. So MCH will give us the RBC, hemoglobin mass per red blood cell. So the normal will be 30 plus or minus picograms per the cell, that is the MCH. So next one is the RDW. That is a red cell distribution weight. The standard deviation of MCV divided by mean MCV into 100. This gives us the red cell distribution weight. The RDW is useful in the patients with microcytic anemia between iron deficiency and thalassemia. Iron deficiency and the thalassemia in the presence of. Okay, then coming to the this is a slide showing normal RDW or increased RDW in comparison to MCV. So RDW with the MCV, how to compare all these things? To know whether this is due to thalassemias or iron deficiency, we can see In thalassemia, the small red bells are generally in uniform with a normal small RDW. In iron deficiency, the size variability and the RDW are. So this, whenever there is a decreased MCV, it can be seen both in thalassemias and iron deficiency. So with the normal, whenever there is RDW is normal, so you can think of beta thalassemias, and increased RDW, you can see the iron deficiency anemias. And with the normal MCV and normal RDW, that is normochromic anemias. And with normal MCV, increased RDW, that can be inflammatory anemia or hypothyroidism. So with the normal RDW and increased MCV, there can be a bone marrow aplasia. Increased RDW, megaloblastic anemia. So with MCV and normal RDW, we can differentiate between thalassemias and the iron deficiency anemias. So this is one more is that is Menger index used to differentiate between iron deficiency anemia from the beta thalassemia. That is the Menger index is equal to MCV. I mean, this can be calculated by MCV by RBC count in the millions. If it is more than 13, iron deficiency is more likely, and less than 13, beta thalassemias are more likely. So it's one more index to differentiate between iron deficiencies and thalassemias, but is uniformly not reliable, but some helpful whenever we are in a doubt to differentiation. Then comes the, after RBC indices, we can go for the peripheral smear. It is used for RBC size, size and shape, can correlate with the MCV. When it is microcytic, less than 80 factoliters, usually in nuclear maturation defects. Macrocytic, that is more than 100 factoliters, usually in the cytoplasmic defects. And then inclusion bodies like Howell-Jolly bodies, and then hinge bodies, and whenever there is a basophilic stippling, any parasites, all these scans can be performed in the, we can see in the peripheral smear. And the Howell-Jolly bodies are mostly seen in the sickle cell anemias and post-splenectomy. And hinge bodies also we can see in G6PD deficiencies and post-splenectomy and some thalassemias also. And basophilic stippling in lead poisoning. Lead poisoning, you can so all this by examining in peripheral smear, all these things we can come to one. Different cells which are seen in the different conditions. And next, coming to the morphology of the RBC, the normal size of the RBC will be 6 micrometers. And microcytic, you can, what are the conditions associated or the B12 or folate deficiency, liver diseases, and myelodysplastic syndromes are on chemotherapy. Whenever there is less than 6, whenever there is a microcytic RBC, think of iron deficiencies, thalassemias, pyridoxine deficiency, and sideroblastic anemias. And then when the spherocytes, hereditary spherocytosis and autoimmune hemolytic anemias. And stomatocytes, you can suspect hereditary stomatocytosis or liver disease. Elliptocyte, hereditary elliptocytosis, severe iron deficiency anemia. Whenever there are cystocytes, microangiopathic hemolytic anemias, and mechanical valve-induced anemias can be there. So this is all the pictures we get on the peripheral smear. Coming to morphological classification based on RBC, red cell size, hemoglobin content, and red cell indices. Microcytic, hypochromic, seen in iron deficiency, sideroblastic, thalassemia, and anemia of chronic diseases. Normochromic and normocytic and normochromic, they are seen in acute blood loss, hemolytic anemias, and marrow failure. And macrocytic, normochromic are seen in megaloblastic anemias. And then after diagnosing the microcytic anemias, of course, this is an the overall conclusion to how to diagnose confirm the microcytic anemia. All the patients should be tested for iron binding capacity, total serum iron, and serum transfer in concentration. Iron studies will identify whether it is iron deficiency or causes due to acute, whether it is acute chronic or anemia of chronic disease or anemia of inflammation. So iron studies will identify iron deficiency and anemia of chronic disease or anemia of inflammation. If normal, iron studies qualitative abnormalities in globin proteins such as thalassemia, hemoglobin C and S can be seen. If normal hemoglobin, whenever we see a basophilic stippling, that is seen in the lead poisoning. So for sideroblastic anemia, it requires a bone marrow examination. So coming to what are the normal values of iron studies, they range from 50 to, the serum iron normally is 50 to 150 micrograms per dl. It can be measured in the serum, preferably in the plasma. Whenever it is low, serum iron is low in iron deficiency, as well as in anemia of chronic disease and anemia of inflammation. So serum ferritin, it is a circulating iron storage protein that is increased in proportion to the body iron stores. The normal cutoff value is 30 nanograms per ml. And the serum ferritin concentration is increased in anemia of chronic disease, anemia of inflammation, and low ferritin levels are seen in the iron deficiency. And coming to serum ferritin, it is a circulating transport protein for iron, increased in iron deficiency and decreased in anemia of chronic disease. A normal TIBC is, but it can be converted to the TIBC by multiplying by 1.389. The normal TIBC is 300 to 360 micrograms per dl. Then we have to calculate for the transferrin saturation. Transferrin saturation, it is the ratio of serum iron to TIBC. Serum iron divided by TIBC into 100. The normal transferrin saturation ranges from 25 to 50%. In iron deficiency, serum iron is reduced and TIBC is increased, resulting in a lower transformation saturation. And bone marrow iron stain. The staining of bone marrow aspirate smear for iron provides a qualitative assessment of iron in the marrow cells. Stainable bone marrow iron is considered the gold standard for assessing iron stores, but it is rarely required for the diagnosis. So this is the overall what we are here in these times. It is a slide showing iron. I have to differentiate between depending on serum ferritin, RDW, and serum iron levels and TIBC. How to differentiate between iron deficiency, thalassemia, anemia of chronic disease, and sideroblastic anemia. In iron deficiency anemia, the serum ferritin, iron levels, and transferrin saturation will be decreased, and TIBC and RDW are increased. In thalassemias, the serum ferritin will be increased. In RDW, serum iron, TIBC will be normal, and RDW and transferrin saturation can be normal or increased. In anemia of chronic disease, serum ferritin normal or increased, but RDW will be normal, and serum iron is normal to decreased, and TIBC is slightly decreased, and transferrin saturation is normal to slightly decreased. In sideroblastic anemia, the RDW is increased, and TIBC will be normal, and ferritin and transferrin saturation can be normal to increased. So after evaluation microcytic anemia with serum ferritin, RDW, serum iron, iron binding capacities, we'll move for macrocytic anemias, where we measure the serum B12 levels. If the serum B12 levels are normal, we will go for MMA and the serum folate levels. If normal B12 and folate at the next, we have to proceed with the TSH, that is thyroid stimulating hormones, and history of alcohol and bone marrow examination to rule out any MD, any myelodysplastic syndromes. So this is macrocytic. And coming to normocytic anemia evaluation, the reticulocyte count will be helpful in narrowing the diagnosis of unexplained anemia. When the counts are increased, you suspect hemolysis or any recovery from the bleeding and repletion of iron, folic acid, or vitamin B12. So whenever there is a decreased reticulocyte count is seen, so think in terms of deficiency of iron, vitamin B12, folate, or copper, and medications that suppress the bone marrow, and primary bone marrow disorders including MDS, myelofibrosis, or leukemias. So this is the overall table showing us whatever we have heard till now. So the history, review the history, CBC, MCV, and reticulocyte count. If the MCV is less than 80, think of the common causes like iron deficiency, thalassemias, and anemia of chronic disease, and anemia of inflammation. And the serum ferritin is low at T-stat. Think of any iron depletions. If it is no, the possible thalassemias, hemoglobin analysis, especially for severe microcytosis, you can see. And it is 80 to 100 capital liters, the common causes, sometimes in iron deficiency, vitamin B12 also, and anemia of chronic disease, drug-induced infection, hypothyroidism, and others. And it is more than 100, think of B12 deficiencies and the MCV, megaloblastic anemias, drug-induced, and liver diseases, hypothyroidism, MDS, and others. So this is in brief regarding the evaluation purpose. Then comes the bone marrow examination, which gives us a semi-quantitative and qualitative assessment. So before any explained anemias, you can go for bone marrow examination with simple RBC indices and examination of B12 and folate. We can come to one conclusion whether this is microcytic or macrocytic or normocytic, or whenever there is a reticulocyte picture will give us whether it is hypoproliferative or hyperproliferative. And then in red marrow, it consists pathological analysis of bone marrow is obtained by the bone marrow aspiration and biopsy. So what are the differences between aspiration and biopsy? So in aspiration, it can do it fast. It gives us a better cytological detail. It gives relative quantity of the different types of cells. It is ideal for cytogenetics and molecular genetics. Can be performed alone in iron deficiency anemia, anemia of chronic disease, megaloblastic anemia, and acute leukemias, and it is less painful. So in biopsy, in defined biopsy, it is a slowing process. It represents all cell types. Topographic details, cellularity and infiltration. We can know regarding topographical details, cellularity and infiltration. It explains the cause for dry drop, that is aspiration. We can suspect their myelofibrosis. It is helpful for aplastic, hypoplastic anemia, lymphomas, or metastatic carcinomas, or any myeloproliferative neoplasms and the diseases of the bone. That when compared to aspiration, that is more painful. So by aspiration, we can know about anemia of chronic disease, iron deficiency, and megaloblastic anemia and acute leukemias. By defined biopsy, we can know about the plastic, hyperplastic anemias, lymphomas, metastatic carcinomas, and myeloproliferative neoplasms. This is the picture regarding CBC and reticulocyte counter. I think this is a repetition, but once again, when the reticulocyte index is less than 2.5, check for the red cell morphology, normocytic, normochromic, hyperproliferative. The causes could be marrow damage due to infiltration or aplasia, and decreased stimulation, inflammation, metabolic defects, and the renal diseases. And microcytic or macrocytic, maturation disorder, think of maturation disorders that can be nuclear or cytoplasmic. The cytoplasmic can be iron deficiency, thalassemia, sideroblastic anemias, and nuclear defects, folate deficiency, B12, drug toxicity, and myelodysplasia. And the index is more than 2.5, hemolysis or hemorrhage. So acute blood loss, intravascular hemolysis, metabolic defect, membrane abnormality, fragmentation, hemolysis. Then after knowing all these things, the final diagnosis comes by grading the anemia, normocytic, normochromic, and then etiology. So this completes the evaluation of anemias. Wherever it is iron deficiency, we will supplement with iron. Whenever there is a B12 or folate deficiency, we will supplement them accordingly. And then RBC transfusion, cryoprecipitate mostly in whenever there is cryoprecipitate only when to replace the fibrinogen levels, and chelating agents in lead toxicity, splenectomy in hereditary spherocytosis, and bone marrow transplantation in aplastic anemias. All these treatment. This is only for the completion sake, the treatment. But to enlighten regarding the national preventive programs, the government is also implanting. I mean, it is also conducting so many national programs to prevent anemia. They are the National Nutritional Anemia Prophylaxis Programs. National Iron Plus Initiative for Anemia Control, National Nutritional Policies, Anemia Mukt Bharat, that is 6x6 approach, 6x6x6 approach, and deworming program, and food fortification programs. So these are the the different national programs are also been conducting by the government to prevent anemia. So this is a brief thing regarding how to evaluate the anemia. Thank you, sir. Thank you, Ashok sir and IMA team for giving me this chance. Thank you, sir.
Thank you, madam. We welcome Dr. Madhavi Lata Garu, Professor in HOD Department of Dermatology, Shantaram Medical College, Nanjala. Madam is one of the owners of the Shantaram Medical College, daughter of Mr. Shantaram, the chairman of the Nanjala Medical College. She was also the member of the former member of the AP Medical Council. She has done her specialization in dermatology in hair transplantation in Israel. She has been awarded the NATCON oration. This oration has been installed by us. We have done the national conference in 1997 with the funds of it. In remembrance of the conference, we have put it the NATCON 97 oration. This has been given to Dr. Madhavi Lata. Madam, we welcome you for the today's session.
Thank you, Dr. Ashok sir, for giving me this opportunity. I thank IMA Nellore for also giving me this opportunity, and thank you for your kind words, Dr. Ashok sir. Today, I'll be dealing about systemic lupus erythematosus. Just a moment, I'll be sharing my slides. Sharing. Just a minute. Desktop is this. Share them. Share them. Screen share. Screen lo petti share చేయండి. స్క్రీన్ లో పీపీటీ పెట్టి షేర్ చేయండి.
మేడం ఇప్పుడు మీ దాంట్లో స్క్రీన్ షేర్ అని ఒక ఆప్షన్ ఉంటుంది మేడం, గ్రీన్ కలర్ బటన్.
యా సార్,
క్లిక్ ఆన్ దట్.
క్లిక్ చేసినాం. యా, ఐ హావ్ క్లిక్
ఎంటర్ స్క్రీన్ పైన ఎంటర్ స్క్రీన్ క్లిక్ చేసి మళ్ళీ షేర్ బటన్ క్లిక్ చేయండి సెంటర్ లో.
ఓకే, ఎంటైర్ స్క్రీన్ క్లిక్ చేయాలా సార్?
చేసి మళ్ళీ కింద మధ్యలో షేర్ బటన్ ఉంటుంది బాటమ్ లో, అది మళ్ళీ ఒకసారి క్లిక్ చేయండి. yes.
Oh, thank you so much. So
one second, let it come. Yeah, ఇప్పుడు మీ ప్రెజెంటేషన్ ఓపెన్ చేయండి.
Yeah. Thank you sir, thank you for the help.
స్లైడ్ షో పెట్టండి అదే బటన్ క్లిక్ చేయండి.
Yeah, thank you sir. So thank you sir. Let's dive into the topic systemic lupus erythematosus. So World Lupus Day is celebrated on May 10th. The contents of my slide would be the discussion of the epidemiology, etiopathogenesis, clinical manifestations, diagnosis and treatment. Coming to historical aspects, in 1851, Senze was the first person to coin the term lupus. Hebra was the first person to talk about skin lesions. Kaposis was the person to talk about the simile of butterfly rash or malar rash. Jonathan Hutchison and William Osler, these two were the people who discussed about the multi-system nature of the systemic lupus erythematosus. And Gilliam was the one who classified into cutaneous and extracutaneous, or LE specific and LE non-specific lesions in SLE. Coming to epidemiology, it affects 1 in 2,000 people. As we all know that females are more prone for this 10:1 ratio. This female preponderance is seen more in 16 to 55 years. Less than 16 and more than 55 years, the female to male ratio is 2:1. Most commonly seen in blacks and Asians. and less in whites. If an identical twin has SLE, the chance of spread to the another twin is 25 to 50%. If it is non-identical, then it is 4%. If a sister or mother is suffering with SLE, there's 4% chance of the children of sibling getting SLE, but 30% of them chance to have the positive anti-nuclear antibodies. What is systemic lupus erythematosus? Systemic when it involves multiple organs. Erythematosus means erythema, reddening of skin. Lupus because it looks like a wolf bite, and also because it affects the skin. So that is systemic lupus erythematosus. As we all know, it's an autoimmune disease where the body is recognizing its own proteins as foreign and it's developing autoantibodies. And these autoantibody complexes, they get deposited in the skin, joints, vasculature, and this causes immune abnormalities. What is etiopathogenesis? What causes lupus? The multiple etiological factors, the genetic factors, hormonal factors, environmental factors, drugs, stress, chemicals. So the multiple etiological factors which cause lupus. When we talk about genetic factors, HLA-DQ, HLA-B8, DR3, DR2, deficiency of complement C5 and C6, these genes, where do the susceptibility act? They act at places where there is B cell and T cell function, innate immunity, complex immune complexes clearance, apoptosis. These are the places where the susceptibility genes will act. The susceptibility can be MHC related or non-MHC related, where HLA, DR1, 2, 3, 4, C2 to C4 deficiencies, interleukin 10, 6, and polymorphisms. Also, multiple hormones, multiple genes have been linked to SLE. So, as I told you, these genes act at innate immune response, immune clearance, adaptive immunity, and multiple like DNA methylation and other things. When the person has these susceptibility genes and when they are having these environmental factors, so there will be development of multiple features. Environmental factors, the most important one is the UV radiation, smoking, exposure to heavy metals like cadmium, mercury, gold, industrial factors like silica and trichloroethylene, drugs, bacterial infections like parvovirus B19, cytomegalovirus, and Epstein-Barr virus. Hormones, why are females more affected? So there's been a lot of link to the role of estrogen and prolactin, and persons who have low androgen estrogen levels, concentrations are more protective. People who are using endogenous estrogens, they increase the risk of SLE in women. So there is multiple ways these hormones, these estrogen and prolactin have been linked to SLE. Drugs, sulfonamides, hydrolazine, isoniazid, dipenamide, minocycline, and many other anti-arrhythmic drugs like procainamide and propofol. Many of the drugs are, whatever may be the etiological factor, the pathogenesis is the same. So what is the pathogenesis? So when a patient has susceptible genes and this ladies have susceptible genes and they're exposed to UV radiation, then because of the exposure to UV radiation, there is apoptosis, which is known as programmed cell death. When there is programmed cell death, there is exposure of the nuclear material, like DNA, histones, other proteins. So these nuclear antigens are exposed. So in normal situation, what happens is macrophages and other antigen-presenting cells, they will clear this apoptotic material. But when the patient is having susceptibility genes, there is less effective clearance and these apoptotic bodies are exposed. So what happens when these are exposed? The body will, because of the susceptible genes, the body will recognize these apoptotic bodies as foreign material. So when there is, because of they are identifying it as foreign, so there won't be these nuclear antigens will not be cleared. There will be heap up of these nuclear antigens. And these nuclear antigens will get presented to the antigen-presenting cells. There is interaction between the antigen-presenting cell and T cell. Because of this interaction, the important B cells will secrete antibodies. So when these secrete antibodies, these antigen antibodies, they will become into antigen-antibody complexes. And these antigen-antibody complexes, they go via blood, and along the complement activation, they get deposited in the kidneys, skin, heart, joints, and they cause local inflammatory reactions. And as I told you, these immune complexes increase the complement cascades, and they cause increased permeability of these tissues, which causes tissue damage. So this is the picture which I'll be showing. So there's apoptosis, that is programmed cell death. In the normal situation, these macrophages will come and engulf the material and they cause clearance. But since they are genetically susceptible, this presenting cell, they engulf the nuclear material and they present to MHC2 cells. They interact with the key helper cells. With their interaction, there will be interleukin-6 will be released, and this will stimulate the B lymphocyte to produce autoantibodies to the exposed nuclear material. It could be dsDNA, it could be Smith, it could be antiphospholipid, it could be antiphospholipid. So these autoantibodies will expose. When these autoantibodies get deposited in the tissues, they cause tissue damage. So the important things here is the apoptotic debris is not cleared. Because they are not cleared, the body recognizes them as foreign, and this foreign material, antibodies will be developed. So autoantibodies will develop. Autoantibodies along with the complement, they get through the blood, they go and they get deposited in the skin, joints, heart, liver, and it also causes the blood-brain barrier, and it causes the clinical manifestations. So there are other potential triggers like cigarette smoking, viral infections, bacterial infection, drugs. As I said, whatever may be the etiological factor, the pathogenesis is a development of autoantibodies. This, as I told you, there is loss of self-tolerance, production of autoantibodies, deposition of these complexes, and immune complexes deposition and inflammation causing tissue damage. So what are all the microscopic and macroscopic features? In macroscopic features, because of the deposition of these antibodies in the tissues, it causes pleurisy, pericarditis, endocarditis, lymphadenopathy, and splenomegaly. Microscopic. So when there is deposition of these autoantibodies in the glomeruli, that is, they get deposited in the podocytes and the capillaries, which causes lupus nephritis. So there is proteinuria, that is more than 0.5 grams of proteinuria will be there. When these autoantibodies with complexes, they get deposited and they cross the blood-brain barrier. When they go to the neurons, there will be increase in the cytokines, immune cells, which causes neuronal death, which causes delirium, psychosis, and seizures. When these autoantibodies, they get deposited in the bone marrow, they cause a decrease in the stem cells, which causes decrease in the production of WBCs, decrease in platelet count, decrease in the RBCs, causing anemia, thrombocytopenia, and leukopenia. When these autoantibodies or T helper cells, activate T helper cells, they bind to RBCs and platelets, they cause idiopathic thrombocytopenic purpura. When these get deposited in the pericardium and the synovium, they cause acute pericarditis, synovitis, pleural effusion. When they get deposited in the skin, if it is in the scalp, it causes non-scarring alopecia or lupus. In the rash or malar rash, in the oral cavities, it causes oral ulcer. So this will explain all the clinical features of our diagnostic features of our SLE. So this is a picture showing pleurisy, a picture of showing pericarditis. This is a picture showing limb and sac endocarditis. You can see the vegetations here, where the vegetative growths around and which are interfering with the blood flow. So this is a picture showing immunoglobulin, that is in the dermoepidermal junction, immunoglobulin deposition, hematoxylin bodies in the endocardium, and perivascular fibrosis in the spleen, and the wire loop wire loop lesions in the kidneys, all because of the deposition. So the criteria, which is the present criteria which we have to see is how to diagnose systemic lupus erythematosus. The major important entry criteria is anti-nuclear antibodies being positive. That is, if the anti-nuclear antibody titer is more than 1 in 80 only, we have to consider about the next additive features. The primary is the presence of anti-nuclear antibodies. The additive features are, there are clinical immunological domains. Like clinical domains, as we have discussed, the leukopenia, thrombocytopenia, hemolysis, fever, delirium, psychosis, alopecias, oral ulcers, whatever we have discussed before, pleural effusion, pericardial effusion, each symptom is given a point. And immunological also, antiphospholipid antibodies, complement, and anti-dsDNA antibody, each is given a point. So when the total score is more than 10, then only we can diagnose it as systemic lupus erythematosus. The primary feature is presence of anti-nuclear antibodies more than 1 in 80 dilutions with these features. So all of us know, we have read about this ARA criteria, 11 important criteria, where malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, serositis, renal involvement, neurological involvement, hematological involvement, and presence of anti-DNA, anti-Smith, anti-phospholipid antibody, and abnormal titers of These are the 11 criteria. More were present. We used to diagnose it as SLE. So let's see what are these. What is the meaning of malar rash? Malar rash is a fixed erythema, flat or raised over the malar eminences. The very, very important thing is it should spare the nasolabial folds. So many times patients will come to us with the PMLE, rash and anything. But when we check there is the spare of nasolabial folds, we have to think it as malar rash. The discoid rash is erythematous raised patches of plaques with adherent keratotic scaling. So we can see this adherent keratotic scaling here. And if they are older lesions, we'll also find atrophy. Photosensitivity is skin rash as a result of unusual reaction to sunlight by patient history or physician observation. In this picture, we can see that all the photo-exposed areas, there is erythematous maculopapular rash. What are oral ulcers? Oral ulceration, which are usually painless, observed by the physician. Most of the time, we have to differentiate these oral ulcers from aphthous ulceration. We have to check for the palate and the oral ulceration to diagnose for the oral ulcers. Arthritis. Most of the time, the arthritis is non-erosive arthritis involving 2 or more peripheral joints. The difference between the SLE in arthritis is rheumatoid arthritis is the arthritis in SLE is always a reducible deformity. Most of the time there are no deformities, but if there are deformities, there are reducible deformities. So, and another important Jacquard's arthritis, which we can see in SLE, the difference between rheumatoid arthritis and Jacquard arthritis is there are no erosions in the pleuritis, convincing history of pleuritic pain, rub heard by physician, or evidence of pleural effusion. Pericarditis documented by ECG or evidence of pericardial effusion. What happens in the pleura and lung? The most important feature is pleuritis, most seen in 45 to 60% of patients. Pleural effusions are present. Even if effusions are there, they're usually bilateral. And about cardiovascular system, pericarditis is seen in 25% of SLE patients, usually asymptomatic and mild to moderate. Tamponades are very rare. Typically occurs in patients when the lupus activity increases They can present with fever, dyspnea, tachycardia, and congestive heart failure. And most of the patients with SLE, they have reduced ejection fraction. The picture showing pericarditis and pleuritis are the renal disorder. So when the persistent proteinuria more than 0.5 grams per day or greater than 3%, then we call it as persistent proteinuria, and presence of RBC cast, granular cast, tubular cast, and mixed cast. So the most important, most major cause of mortality and morbidity is involvement of the renal system. These immunocomplexes, they get deposited in the kidney, result in intraglomerular inflammation with recruitment of leukocytes and activation of the proliferation of resident renal cells. The most important cause of morbidity and hospital admissions are because of lupus nephritis. So the International Society of Nephrology has classified lupus nephritis into 6: minimal mesangial, mesangial proliferative, focal, diffuse, membranous lupus nephritis, and advancing sclerosing lupus nephritis. Neurological, because as I told you, these go cross the blood-brain barrier, and there'll be a leakage in the blood-brain barrier because of these autoantibodies and complex. They get deposited and they cause seizures and psychosis. So yeah, these remain major cause, again less understood. Anemia, leukopenia, lymphopenia, thrombocytopenia. Liver dyspepsias are seen in liver, abdominal pain, nausea, vomiting. Hepatic diseases may be more common in SLE initially thought, but now the deep understanding is being done about the hepatic involvement also. Anti-DNA or to naive DNA, anti-Smith, or positive finding of anti-phospholipid. And any female with history of abortions, we have to rule out anti-phospholipid antibody syndrome. And increased titer of anti-nuclear antibodies. These are the 11 criteria which we take into consideration. Gilliam has classified clinically into LE-specific and LE non-specific. LE-specific, acute cutaneous lupus erythematosus, subacute cutaneous lupus erythematosus, and chronic cutaneous lupus erythematosus, and multiple clinical presentations are there in LE-specific. In LE non-specific, you have purpuras, vasculitis, lividoreticularis, Raynaud's, lupus hair, urticarias, leg ulcers. So multiple non-specific cutaneous features are also present. So what is acute cutaneous lupus erythematosus? 50 SLE have acute cutaneous lupus. At any point of time, they get these acute cutaneous lupus lesions. They are of two types, that is localized and or generalized. If it is localized, it is like butterfly rash on the face. If it is generalized, like toxic epidermolysis-like feature, we will find. This is the butterfly rash, where we can typically see the erythematous maculopapular rash tending to spare the nasolabial fold. This rash can be also on the forehead, chin, and everywhere. So this is the picture of acute cutaneous lupus with malar rash. Generalized acute cutaneous lupus, again of two varieties, exanthematous rash variety or toxic epidermal necrolysis, where there are bullous lesions, separation of epidermis and dermis, rash. So two variety of erythematous rash all over the body. We can see the maculopapular rash, telangiectasias all over the body. And typicality of this is the sparing of the characteristic sparing of knuckles is present. So you can see the erythema all over, but knuckles are spared. And we also can see periungual erythema and telangiectasias. This is toxic epidermal necrolysis-like picture, where we can see hemorrhagic crusting of the lips. This is the typical feature of toxic, where there is separation of epidermis and dermis, where Nikolsky sign will be positive. When we drew, there will be separation. And we also can see the flaccid bulla, where the eruption is like toxic epidermal necrolysis-like. Coming to subcutaneous lupus erythematosus, this presents in two forms: non-scarring papillosquamous type and polycyclic annular type. So this is the non-scarring papillosquamous type, where there is papillosquamous rash and erythema over the back. Annular variety, where the lesions are typically annular in shape, where there's kind of a raised border and central clearing and kind of keratotic plugging like thing we can see here. Histologically, we can find the interface dermatitis with the dermoepidermal junction. Autoantibodies are positive. Risk factors for a patient of subcutaneous to develop into a systemic lupus. So when there is leukopenia, when there are lots of papillosquamous lesions, high ANA titers and presence of anti-dsDNA antibody, these are the risk factors for a patient who have only SLE to develop into systemic lupus erythematosus. 10 to 15% of the patients develop SLE in SCLE patients. That's why whenever we see only localized SCLE or DLE, we have to always screen them every 6 months to see if this patient is going into systemic lupus erythematosus. Chronic cutaneous lupus erythematosus, as a multiple variants are there: localized DLE, generalized, hypertrophic, lupus radiculitis, mucosal, tumid, chilblains, lichenoid variety, rosaceous variety. So there are multiple variants. So in localized DLE, as we all see in our OPD, where the patient will come to us with a dry looking plaque. When we remove the scale, we can underline, we can see the keratotic plugging, which we call it as carpet tax sign or tin tax sign. Most often the localized is only above the neck. Scalp is most often involved with follicular plugging. When it is involved in the lip, you have hyperkeratotic or cribriform lesions around the lips. In long-standing chronic cutaneous lupus, patient can also go in and develop squamous cell carcinomas. So these are the pictures where the first picture, the patient is going into development of squamous cell carcinoma. There is a dry keratotic, dry plaques with atrophy and hyperkeratotic the borders. On the scalp also we can see the lesions which are atrophic, hyperkeratotic, and the center there is hypopigmentation. When we remove the follicular plugging, and we can carpet tack or tin tack because of the follicular plugging. So scalp, palms and soles are nothing but dilated capillaries. When it is localized, if it is disseminated CCLE patient can go into cystic lupus erythematosus. So this is a picture showing perioral, where you can find the cribriform scarring in the ear lesions where there are pits and the concha is involved. Hypertrophic variety or extensive scarring variety, where you can see there is a hypertrophic lesion, scarring is there, mutilation is there, atrophy is there, and pigmentation, hypopigmentation is there. This is another picture showing the scarring type of variety. Lip involving SLE, where there is erythemas and there is ulcerations around the lips. And hypertrophic variety, thick hyperkeratotic looking like lesions, where there are hyperkeratotic plaques. We have to differentiate with hypertrophic like in planus. Lichenoid variety, where there is like purplish color lesions, thick hyperkeratotic plaques with central atrophy. Lupus erythematosus profundus or paniculitis, where there is lower dermis and subcutaneous tissues involved. So we will find kind of nodules, and O-line skin is attached to nodules. When they heal, it forms like saucer type of depressions you will find on the skin. Lupus erythematosus LP, like in planus overlap also we can see. Chilblain lupus, where there underlying cryoglobulins or antiphospholipid anti-syndrome, antibody syndrome, where we can see this kind of purple, red, dusky papules and plaques over the fingertips, rim of the ears, nose, calves, and heels. Again, picture showing the chilblain type of lupus on the thigh region, or then purpuric lesions on the feet. To meet, because of the dermal mucin deposition, you can get off. You kind of get articulated kind of lesions like edematous plaques over the body, and this is because of the deep dermal deposition of mucin. Rosaceous form, where there is a picture typically shows like a rosacea, where there is involvement of the face with lots of telangiectasias, flushing of the face, and involvement of the maculopapular lesions all over the face in a rosaceous pattern. Paniculitis, subcutaneous firm nodules, subcutaneous inflammation, it can be lupus paniculitis, or when it is deep down, it can be lupus profundus. This is the lupus mastitis involving, it can involve the gland which called lupus mastitis, and it on the hand it can cause paniculitis, which is a kind of paniculitis. This is a picture showing long-standing CCLE developing squamous cell carcinoma. You can find the cauliflower-like growth on is going into squamous cell carcinoma. What are the risk factors? Non-scarring alopecias, nail fold capillaries, non-specific lesions, unexplained anemias, leukopenias, high titer of anti-nuclear antibodies. These are all the risk factors for a cutaneous lupus to develop into systemic lupus erythematosus. There's a which is known as Rowell syndrome, where there is combination of erythema multiforme with systemic lupus erythematosus. You can see the patient with the malar rash and hemorrhagic crusting, and on the palms you can see targetoid lesions, that is erythema multiforme along with systemic lupus erythematosus. There is a criteria to diagnose Rowell syndrome. There is major criteria and minor criteria. Major criteria when there is lupus erythematosus, DLE or subcutaneous LE, with erythema multiforme like lesion with or without mucosal involvement, and you find speckled pattern of anti-nuclear antibodies. The minor criteria, presence of chilblains, positive anti-Rho antila, and a reactive RF factor. The non-specific lesions, Raynaud's phenomenon, presence of, this is Raynaud's phenomenon, presence of purpuras, large non-killing vasculitic ulcers, necrotic ulcers, lupus hair, brittle, thin, easily pluckable hair, or seen in the periphery of the lesion. So lupus hair, bullous lesions. Bullous lesions can be because of the bullous SLE. So when you have bullous SLE, there are kind of a thick bulla present, which are subepidermal bulla, and deposition of the IgG and C3 in the dermal region. So bullous LE. Again, picture showing lupus hair and periangual proximal nail fold erythema and ragged cuticles. Now, what is the difference between neonatal lupus? Can a neonate get lupus erythematosus? Yes, neonate can get lupus erythematosus because of when mother is having the anti-Rho antibodies, this can be transferred to the baby. May affect it whose mother is having anti-Rho, the neonate can get lupus erythematosus. 100% anti-Rho antibodies are positive. The typical feature in a neonate is the presence of raccoon sign or mask sign or owl sign, where around the periorbital area you will find erythema. Photosensitivity common. So these are the neonatal lupus where you find these kind of annular erythematous plaques on the scalp, and then raccoon's eye. That is, you can see the around the periorbital there is a dusky erythema which is called as raccoon sign. And complete heart blocks will be present, hepatobiliary disease, thrombocytopenias. So Complications and comorbidities can be there with pneumonitis, like chronic dysphagia, pancreatitis, hydrocephalus, aseptic meningitis, comorbidities which can be present in neonatal lupus. Drug-induced lupus. Drugs can cause lupus. Most common drugs are hydrolazine, procainamide, minocycline, and anticonvulsants. The important diagnostic feature is the presence of antihistone antibodies. If antihistone antibodies are present, then we can diagnose as drug-induced lupus erythematosus. The symptoms decrease when we stop the drug. Renal system, CNS are rarely affected if it is drug-induced lupus. Antihistone antibodies, as I told you, they're always positive. Childhood. After neonate, let's see how it is different in childhood. In childhood, 15 to 20% of children may have SLE. They have severe disease. They have like hematological abnormalities, renal abnormalities are more in case of children. So fever, adenopathy are more common. Elderly, how is it different in elderly? More than 50 years, the clinical cause is really benign, but there is increased incidence of non-specific lesions like Raynaud's phenomenon, subcutaneous nodules, pericarditis, pleuritis. So these are all more common. Anti-Ro, anti-La will be positive. There are flares of the disease activity. There is maternal thrombosis and miscarriage is there because of the antiphospholipid antibody syndrome. And because of the drug she's been using in SLE, that is also causes toxicity. And neonatal lupus in infants born to mother with anti-Ro antibodies. High incidence of preeclampsia, eclampsia, and hypertension. And increases risk of poor pregnancy, low birth weight, preeclampsias. So what is antiphospholipid antibody syndrome? Antiphospholipid antibody syndrome are found in 30 to 40% of patients with SLE. Causes repeated spontaneous pregnancy loss in embryonic and fetal period. If a baby is born, they'll be with intrauterine growth retardation or placental insufficiency, and the mother can have preeclampsias. There's also diagnostic criteria to diagnose antiphospholipid antibody syndrome, like lupus anticoagulant, anticardiolipin, anti-beta-2 glycoprotein 1. These should be positive on at least 2 occasions, 12 weeks apart. Plus, one of the following, that is arterial, venous, or capillary thrombosis, 3 or more consecutive miscarriages, fetal death more than 10-week gestation, or premature birth less than 34 weeks of gestation. These are the criteria to diagnose antiphospholipid antibody syndrome. So you can see the clinical picture where there is acral gangrene, large vessel thrombosis, cutaneous gangrenous ulcers. Eplot can be primary or secondary. Secondary, it can be diseases like candidiasis, arteritis, infections. When the patient is on dialysis, they can develop this Eplot syndrome. Widespread cutaneous necrosis and multi-organ failure are the important clinical manifestations of Eplot syndrome. So severe organ involvement will be there, and survival is directly linked to the organ involvement. Progressive renal failure, infections are there in the antiphospholipid. So now we have seen different clinical manifestations and what are there in children, what are there in neonate, and what is there in elderly. So what are all the investigations we need to do if we see a patient if you want to confirm or see a patient with systemic lupus erythematosus? As we know, we expect anemia, thrombocytopenia, leukopenia, lymphopenia, increased CRP, increased ESR. So normal routine, complete that picture. Liver function test where we can see increased in the liver enzymes, renal function tests, in proteinuria, urine check for proteins, blood sugar estimation, ultrasound abdomen, chest X-ray to see for pleuritis and pericarditis, ECG for pericarditis, antinuclear antibodies, skin biopsies, and kidney biopsies. So this is a typical cell which we see in lupus erythematosus, which is known as LE cell. As I told you when I'm talking to you about pathogenesis, this what macrophages will engulf the exposed nuclear material. So that is the LE cell. LE cell is a macrophage. LE cell is a macrophage which has engulfed the exposed nuclear material. This is known as LE cell or LE body. Histopathology, we can see like hyperkeratosis. Most important one is interface dermatitis and liquefied degeneration of the basal cell layer, and there is the inflammatory infiltrate is present. So, and in the localized variety, we can also see follicular plugging. Autoantibodies, ANA, which is highly sensitive, but even 10 to 15% of normal individuals also can be positive for ANA. It's a best screening test, but it is not it has low specificity. 4 patterns of anti-nuclear antibodies have been identified. One is a rim or peripheral pattern, solid or homogeneous pattern, speckled pattern, and nucleolar pattern. Homogeneous pattern we find for antibodies like histones, chromatin, or DNA. We find in rheumatoid arthritis as well as SLE. The rim or peripheral staining pattern we see for double-stranded DNA and always positive in SLE. Speckled pattern is also positive in SLE, systemic sclerosis, dermatomyositis, polymyositis. In nucleolar pattern, we see in SLE and systemic sclerosis. And these are all the antibodies which can be positive. It can be anti-dsDNA, anti-Smith, anti-RNP, anti-Rho, anti-La, anti-histones, anti-phospholipid, anti-erythrocyte, anti-platelet, anti-neuronal, and anti-ribosomal P. What is important is in drug-induced, we see anti-histone, anti-dsDNA, we see mostly in SLE, and all others also can occur in combination. What are our goals of therapy now? Since we have seen, we have diagnosed that this patient has SLE, what are the goals of our therapy? Our goal should be to prevent or limit irreversible organ damage and lessen the side effects like potential toxicity of immunosuppressive agents we have to lessen. And strategic use of the newer biological agents. Now, all patients, we will diagnose it as like mild disease, moderate disease, severe disease. But in all patients, very, very important thing is the sun protection, sunscreen. That is, it could be physical or chemical sunscreen, or it could be the avoidance of sun using wide-brimmed hats. So the important thing of applying sunscreen is, sunscreen must be applied half an hour before getting exposed to the sun. 1 fingertip unit is enough. From the distal crease to the tip of the finger, that is 1 fingertip unit. 1 fingertip unit is enough for the whole face. And the sunscreen should be repeated every 2 to 3 hours. That is very important when you're using a sunscreen. And since smoking has an ecological role, cessation of smoking is very important. Since these patients do not get exposed to sun, they get deficient in vitamin D. So vitamin D supplementation is very, very, very important. And since they're prone for infection, so getting all the vaccinations is also very, very important. So depending on mild, moderate, and severe disease, we can do the treatment as topical or systemic treatment. The first line of thing is HCQ, hydroxychloroquine. Hydroxychloroquine is a drug which is an anti-malarial, which is the first line of drug to treat SLE. But before starting the patient on hydroxychloroquine, we have to make sure that his eyes are checked to rule out any cataract or any eye problems, and we have to get his ECG done, and then we can start the patient on HCQ, that is hydroxychloroquine. The other options we have for the mild to moderate disease is oral corticosteroids, then non-steroidal drugs like methotrexate, azathioprine, mycophenolate mofetil, cyclophosphamide. These are the other drugs. Specific and non-specific drugs. Specific drugs are the drugs which act at the specific sites, like drugs which act on the B cell, which obstruct the B cell to produce autoantibodies, like now bimekizumab, rituximab, where they act on the B cell to obstruct production of autoantibodies. So, as I told you, the first thing is general measures, and then hydroxychloroquine less than 5 mg per kg body weight. 300 to 400 milligrams per day can be used for hydroxychloroquine. First line in mild disease is topical steroid or topical tacrolimus or pamicrolimus. If they don't respond, then low dose prednisolone, that is one or less than 20 mg per day, 0.5 per kg body weight we can use. And if it's maintained, then you can shift back to hydroxychloroquine. Non-renal, no organ, prednisolone 0.5 mg per kg body weight. Then steroid sparing, icofenolin, mefortil, azathioprine, methotrexate 15 to 25 mg per week, azathioprine like 50 to 100 mg, mycophenolate mefetil 1 to 2 mg, all this used. Maintenance dose can be done with prednisolone, azathioprine. This is the European Union League Against Rheumatism. This is the treatment chart, where first line is hydroxychloroquine and glucocorticoids, and then steroid sparing, methotrexate, azathioprine. The important specific drugs, newer drugs are bimekizumab and rituximab. These are the newer targeting therapies. That is, these bimekizumab and rituximab acts on the CD20. This is anti-CD20. That is rituximab, atumab, ocrelizumab, veltuzumab. These are all the immunotherapy where they act on the CD20. Bimekizumab will act on BAF antigen on B cell. What is important is these act here and they start the production of autoantibodies. If autoantibodies are not produced, there are no clinical manifestations. So these are the targeted therapies. So they B cell directed targeted therapies where they don't secrete the cytokines and co-stimulatory blockade is present. So because of this, there is no secretion of autoantibodies. SLE is characterized by periods of flares and remissions. So increased disease activity is there, followed by less activity. So this is a very, very chronic disease. Counseling of the patient is very important. Asking the patient to strictly follow the regimen given by the doctor is very important. Every 3 months, getting them investigated for involvement of the systems is very important. Trying to rule out, lessen the organ damage by getting them investigated is very, very important. How do you predict flare? So when there is a raise of antibodies, when there is lymphopenias, increased ESR, so we have to predict a flare. Severity is characterized by the abrupt onset of symptoms, increased renal, neurological, hematological, and serosal involvement, rapid organ damage, and associated with the race. So as I told you, in Blacks and Asians, the severity is more compared to American Asians. Younger age of onset, males are more severe disease. Low socioeconomic status also, they have severe disease because they cannot, maybe they're not able to take the drugs like the specific kind of drugs which act on the specific pathogenic mechanisms. So the very important thing is to see that these people are investigated every month and every 3 months to see the progression of the disease. About the systemic lupus erythematosus, I thank Dr. Ashok sir for giving me this opportunity.
Thank you, madam. Thank you very much for your elaborate lecture.
Thank you, madam. Next lecture will be by Dr. M.B. Ram Mohan Garu. He is consultant endocrinologist in Nellore. He will be delivering his lecture on common endocrine disorders in pregnancy and overview. Yes, sir. Ramohan, sir.
Yeah.
You can proceed, sir.
సార్
Are you able to?
రామ్మోహన్ గారి గురించి ఒక మాట చెప్పాలి. రామ్మోహన్ గారు ఎప్పుడు కూడా ప్రతిదానికి ఆదుకుంటుంటారు, ఎప్పుడే స్పీకర్ లేకపోయినా కూడా. ఈసారి ఒరే చేయాలనుకున్నాం కానీ వీలు కాలేదు. నెక్స్ట్ టైం డెఫినెట్లీ గివ్ సార్. అండ్ ఎవర్ ఆల్వేస్ స్మైలింగ్ ఫేస్. థ్యాంక్ యూ సార్.
Sir, I thank Dr. Ashok Garu. I thank Dr. Amarendranath sir. I thank Dr. Rahul Babu sir for this opportunity. The greatness of IMA Nellore CME is that this time we have more than 300 registrations, recorded registrations, so that every physician and all the consultants get used by this CME. Thank you so much, sir.
Sir, 400 registrations, sir.
Great, sir.
418 already now online. 405 people are online, sir.
Great, sir. I'm very happy to be part of Nellore IMA, and I'm very much honored to be here. Thank you so much, Ashok, sir. Today's topic is I'll be covering in next 20 to 30 minutes about common thyroid disorders in pregnancy. So we know that, sir, are you able to see my screen, sir? Yeah. Coming to the thyroid common pathophysiology, physiology occurring in pregnancy due to because of increase in estrogen in pregnancy, there is an increased thyroid binding globulin. So normally you see many of our pregnant ladies having a total T3 and total T4 increased up to more than 1.5 times. Still TSH will be normal. This is because of increased estrogen. And also in first trimester between 8 to 14 weeks, we have a TSH will be suppressed because high HCG will lead to, it is similar in structure with TSH, and this will be suppressing the TSH. So that means that because of HCG, it stimulates the release of T3, T4, and transient suppression of TSH will be there. So it is also physiological. And peripheral metabolism of thyroid hormone is increased in pregnancy and lead to decreased FT3, FT4. And also there is a plasma dilution in occurring in pregnancy, and fetal thyroid is not functioning till 10 to 12 weeks. So we need more thyroid from the mother. Transport of thyroid hormones from the mother to the baby during early pregnancy. And there is also demand for increase in T3, T4 up to 30 to 50%. That's why we tend to increase the doses, pre-pregnancy doses to during pregnancy by 25%. That means, for example, if the patient is given 100 micrograms of thyroid pre-pregnancy, in pregnancy you give around 125. Or depending on the need. That means that the demand of thyroid hormones is more in pregnancy, and they need more thyroid hormones for both for mother and baby. So coming to the case-based discussion, here we have a 26-year-old primee with 5th month gestation with TSH of 2.6 and T3, T4 showing high. You can see T3 is high, T4 is high, TSH is normal, less than 4 only. So what next is this normal? So I'll be telling that this is a normal variation, as I told you, because of estrogen, increased estrogen, increased SHBG. We have high T3 and high T4 during the pregnancy, and it is a normal variation. So that nothing can be done to the patient, no need of any treatment, no worries and no panicking. So this is the normal physiological change. So coming to the prevalence of hypothyroidism in pregnancy, you can see that if they take a TSH of cutoff 4.5, it is on 15%. If you take a TSH cutoff of 2.5 or 3, the prevalence is increasing. That means that if you take a strict stringent model, you have a high prevalence of hypothyroidism. So whom to screen in pregnancy? So you can see that there's a meta-analysis showing if TSH cutoffs are more than 4, number of patients missed with hypothyroidism of 80%. If TSH are more than 2.5, more and more less number of patients are missed in hypothyroidism. That means that depending on the cutoffs, it has shown that the case-based screening can miss up to 49% of pregnant women with thyroid dysfunction. That means you can't decide depending on the case base. So all pregnant women should be screened at first antenatal visit by doing a TSH. So whenever first pregnant lady comes to a gynecologist, do a TSH level, whichever is early. So that we are not missing hypothyroidism in pregnant ladies. So what are the TSH reference ranges in pregnancy? So recommended guidelines, it says that upper TSH 2012 to 2017, you can see that 2014. First trimester we have 2.5, second and third it was kept as 3. But newer ATA guidelines have shown that you should have a local reference range and a specific population, and it is not available, you can take up to 4. So in India, we have seen many meta-analyses have shown that taking a TSH value up to 4 is not going to harm your patients. And ITS and FOXY 2019 recommendations say that same way. In 2019 say that, so you can take up to 4, but you have any doubt or you have anything, take previous results only 2.5. In first trimester, second is 3 and third is 3. So why this 0.5 or 1 unit milliunits international units per liter? Is there any difference in the small value? So I'd like to say that most of our thyroid reports are not so accurate. So there may be having an error of 1%. So you can't go by saying that stringent values of 2 or 3 or 2.5 can be taken to our patients. You can have a 1 point either this side or this side. So coming to the hypothyroidism in pregnancy, if you don't treat hypothyroid patient in pregnancy, what is going to happen? So we have maternal, fetal and neonatal problems coming to occur in the future. We have anemia, CHF, preeclampsia, placental abnormalities, low birth weight, postpartum hemorrhage and myopathy. These are the common things for the mother. And for the fetal, cognitive impairment, neurological abnormalities, developmental abnormalities, congenital hypothyroidism also can occur in some of the babies. Neonatal hyperbilirubinemia, persistent hyperbilirubinemia. I have seen cases where the patients are not coming down with hyperbilirubinemia antenatally, sorry, postpartum. So after 2 weeks also their bilirubin is not coming down with the therapy also. Then when they look at, they have a frank hypothyroidism. It is called congenital hypothyroidism. And also some babies may have respiratory distress. So overturned subclinical dysfunction, maternal fetal outcomes, you can see that overt hypothyroidism has a bad effects compared to subclinical hypothyroidism. You can see there is more anemia, more PAH, and also more IUGR and IUDs occurring because of if you don't treat overt hypothyroidism. So perinatal outcomes also, you can see overall C-section rate is increasing, fetal distress is increasing, and Apgar less than 7 is also increasing with neonatal complications. That means that for a simple treating of your hypothyroidism, you are having a very bad results, bad outcomes if you miss this opportunity of treating a hypothyroid woman during pregnancy. What do you mean by subclinical hypothyroidism in pregnancy? We have a cases where your T3, T4 or FT3, FT4 are normal, but TSH will be between 4 to 10. So between mildly raised T3, mildly raised TSH with normal T3, T4. So this also can have a bad effect over the maternal and fetal outcome. So multiple adverse outcomes, as I told, pregnancy loss, preterm labor, gestational hypertension, preeclampsia, IUGR, C-section, low birth weight, and low Apgar scores. So how do you treat hypothyroidism in pregnancy? So we have a case where you have a 27-year-old woman with second pregnancy with 5th month gestation. TSS is incidentally first time found to be 5.6 with T3, T4 are normal. This can be taken as a classic subclinical hypothyroidism. Do you want to treat this patient or not? First point. So if TSH is 5.6, it is more than the cutoff needed. If you take 3 or 4 also, it is high. So generally, we tend to start in the patients between 4 and 10 in pregnancy, we tend to start treatment. In this situation, we have to start with around 25 micrograms per day and follow up after 4 to 6 weeks of duration. What are the other investigations? You can use a new investigation that is called TPO antibodies, where you want to use an antibody. If the patient is antibody positive, then you can say that postpartum also she needs continuing treatment, because all subclinical hypothyroidism patients if they have antibody positive, we have to continue the treatment. For example, if the antibodies are negative, only during pregnancy the TSH was 5.6. Postpartum, you can stop treatment and also discontinue LT4 in these pregnant women, because the TSH never crossed 10. So without pregnancy, there is no pregnancy, normal woman, TSH between 4 and 10. If antibodies are positive, we treat. Pregnant women, irrespective of antibodies, start treatment between 4 and 10. If antibodies are positive, we continue the treatment postpartum also. So coming to the third case, where 30-year-old first pregnancy with 7th month duration, you have a 7th month duration with T3, T4 normal, TSH is 3.6. So you can see this is a tricky case where you have a TSH less than 4, just above 3 in second trimester. You want to treat or not to treat. So in this situation, where depending on the goiter, if the patient has goiter, if the patient has antibodies positive, you can treat. If patient doesn't have any goiter, patient doesn't have any antibodies, you can wait for 4 weeks and then repeat the test and then follow up the case. If you can see the trend how the TSH is going up. So management of overt hypothyroidism, as I told you, all overt hypothyroidism, TSH more than 2.5 should be treated. So what hypothyroidism need around, for example, optimal dose, if TSH is more than 10, they need around 1.6 to 2 micrograms per kg body weight. I've seen many physicians and many doctors starting with a low dose and up titrating. For example, they give 25 for 1 month, next 50 for next month, then increase to 100. There is no guidelines that you have to start a low dose and give high doses or increase the doses in overt hypothyroidism. If TSH is more than 10, start with optimal dose. And pre-existing hypothyroidism, as I told you, LT4 dose should be increased by 30% as soon as or 25 to 30% as soon as the pregnancy is diagnosed. And generally, we tend to see in non-pregnant women, we tend to see our thyroid profiles in 3 to 4 months. But in pregnant women, we have to see every 4 to 6 weeks so that we have a strict control in this situation. Subclinical hypothyroidism, all women TSH more than 10 should be treated. Antibody positive women between 4 and 10 should be also be treated. You can consider women with TSH between 4 and 10 or TPO negative also, as I told you. If TPO positive between 2.5 to 4 also, you can consider depending on the need. So postpartum state, what happens? You have to post delivery, you have to revert back the patient to, for example, as I told you, you started 100 during pregnancy, increased to 125. So post delivery, in the next day of delivery, you can come back to 100 micrograms and ask the patient to recheck after 6 weeks. Patient with newly diagnosed hypothyroidism in pregnancy, as I told you, patients between TSH between 4 and 10 with antibodies negative, stop the treatment and review FT3, FT4 TSH after 4 to 6 weeks. If the patient's having antibodies positive, then continue the treatment and follow up with the doses, because they require less doses compared to pregnancy in 4 to 6 weeks. So one more thing is, there are many cases of euthyroid pregnant women with thyroid autoimmunity. That means with a patient have TSH less than 2.5 or 3, but TPO positive. In this situation, what you should see that you have to follow up the patient with every 4 weeks. If the trends are going up, if the TSH is going to cross 3, then start treatment. If the TSH is stable with antibodies are positive, still positive, then don't need to treat them. Then, so this concludes the hypothyroidism part till now. So then coming to the hyperthyroidism. Maternal hyperthyroidism is a very rare condition. And for example, you can see case of 25-year-old primate with third month. First consultant friends, where you can see that during first trimester, the TSH is low with thyroid hormones are normal. So what is the next step in this situation? How to follow up this patient next? And what are TRAB antibodies? I'll tell you. If the patient doesn't have any symptoms of hyperthyroidism, like any thyroid orbitopathy, ophthalmopathy, or large goiter, or loss of weight, or tremors, palpitations, classic hyperthyroid symptoms or toxicosis is not there, then it's a most common case of gestational toxicosis because of HCG. So if you have a still doubt in this situation, use the antibodies called TRAB antibodies. That is, these are the TSH receptor antibodies, where this is a classically positive in all cases of Graves' disease. So with around a cost of around 4,000 rupees, you have a very clear-cut idea that if the patient is having any hyperthyroidism or classic hyperthyroidism, or if you're missing anything, you can see. So use of TRAB antibodies is very important when you have a confusion between gestational toxicosis and Graves' disease. And also, what hypothyroidism very rare, Graves' disease is the most common, and you can see that commonly gestational toxicosis is because of increased HCC. So, and also effects of pregnancy and Graves' disease, if you don't treat, there are complications occurring. And also you can see that you have a problem during this pregnancy. So you should be very careful. So how do you manage hyperthyroidism in pregnancy? So if you don't give proper treatment, the thyroidotoxicus can lead to pregnancy loss, pregnancy-induced hypertension, low birth weight, IUGR, thyroid storm, and maternal congestive cardiac failure also in rare cases. You should be very careful. And also, you have many antithyroid drugs. You have carbimazole, methimazole, and neomercazole. These three drugs cannot be given in the first trimester. That means first 3 months of pregnancy. Don't give carbimazole, methimazole, or neomercazole. Only PTU should be given. So the PTU, propyl thiouracil, comes as 50 and 100 milligrams of tablets. PTU is only given in first 3 months of pregnancy. Nowhere else PTU is used, and the side effects are very less with PTU. I've seen many normal non-pregnant women and men were given, other men were given in hyperthyroidism with PTU. So don't use PTU for normal hyperthyroid patients. Use only in the PTU in the whole medical literature is given only in pregnant first trimester up to 3 months. After patient going to 4th month of gestation, I ask the patient to come back, recheck the FT3, FT4, TSH. In these patients, I start again either neomercazole or methimazole. So that means that after first 3 months, from the 4th month, you have to go back to the other antithyroid drugs, and they are safe from the second and third trimester. So as I told you, PT is recommended only during the first trimester, and you can switch back to methimazole or carbimazole in the second and third trimester. So, and also in the follow-up, mainly surgery is indicated in very rare cases. You can go ahead for surgery in second trimester only. And if they are having high dose of PTU is needed, then only you can go for surgery. Iodine radioiodation is contraindicated in pregnancy. And also, if they are TRAP positive, there is a high chance of euthyroid TRAP positive, high chance of having a fetal thyrotoxicosis. So look for it. Postpartum, immediately post delivery, check for TRAB antibody titers and also check for thyroid profile in the baby, so that because these antibodies can cross the placenta, can cause fetal thyrotoxicosis, transient fetal thyrotoxicosis. Look for thyroid profile in the newborn baby. So then coming to the thyroid nodules, there is a rare. So nodules are found in generally in many population. It can also occur in pregnancy. So they can be incidentally found in the pregnancy, and mainly if you have a large nodule more than 2 centimeters, then go for a FNAC. If FNAC is showing any malignancy or borderline malignancy, then comes the problem, what to do. So if the nodule is malignant, rapid growth, surgery should be done in second trimester. So if the nodule is benign, there is no evaluation needed. Follow up for every 6 months to 1 year, so that you have a repeat FNAC. I have last year I have a case of second trimester. Patient is 6th month gestation with a thyroid nodule having a papillary carcinoma. So she was diagnosed with papillary carcinoma, and she was advised by somebody saying that go for termination. I'll do termination of pregnancy and I'll do a total thyroidectomy. She was afraid, and when we consulted, when she consulted, we have seen that was a micropapillary carcinoma where only 3 centimeter size was found. We have taken an endocrine surgeon opinion also. So in this situation, patient deferred for there are no lymph nodes for there. It was not spreading outside thyroid. So we deferred for surgery till the postmortem stage. She was delivered a healthy baby, and after lactation, again, we went for, after 6 months of delivery, she went for total thyroidectomy. After 3 months, we went for radioiodine therapy also, whole body. So that means that depending on the situation, we have to act. if there is a malignant, rapid growth, or slow growing, or depending on the situation, we have to act and give proper suggestion in pregnancy. Then also, coming to the thyroid disorders and infertility, you can see that hypothyroidism and infertility are common because of the ovulatory disturbance occurs in with the thyroid axis and also with the HPA axis. You can see that TSH, SHBG, and these also can interplay a disturbance in the LH response to GnRH stimuli, and also hyperprolactinemia, and also all these things will lead to ovulatory disturbances. That means that you should have a normal TSH to have a good ovulation, to have a normal fertility. So thyroid disorders and infertility, I was telling you, LT4 is recommended for infertile women with overt hypothyroidism. And in subclinical hypothyroidism, if you have a TSH more than 2.5, and if you want to take the patient for IVF or ICSI or assisted reproductive technologies, then in this situation, you can go ahead with for a positive doubt of reference. You can take a patient, give a patient under coverage of thyroid hormone also can be given. So coming to the take home message, to conclude, screen every pregnant woman who first antenatal visit for thyroid profile, so that thyroid is a small disorder, but it needs meticulous follow-up and meticulous consultation with endocrinologist, so that the patient will be having a good outcome, pregnancy outcome. So utilization of endocrinology services are very much needed in all pregnant women with the thyroid, different thyroid disorders, and also uptitrate LT4 in overt hypothyroidism up to 30 to 25% of need is there. And target TSH should be in take off irrespective of trimesters. You can take as less than 2.5. Use TPO antibody tests in subclinical hypothyroidism patients, and postpartum follow-up is missed in most of our patients. So postpartum follow-up is also a must. So to conclude, I can say that recognize the patients who are needed the treatment, recommend the proper dose, and rejoice the outcome. Thank you.
Thank you, Ram Mohan sir. Nice
thank you.
The next session will be by Dr. G. Mithilasri. He is consultant gynecologist from Nellore. She is going to deliver her speech on menopausal health, evolving priorities in women's care. Mithilasri, madam.
Yes,
you
sir.
can proceed.
Good afternoon, all. I thank Dr. Ashok sir and Nellore IMA team for giving me this opportunity. So today, I want to describe a few things. More important, the points about the menopause, where we are lagging for all the women, Indian women especially. So to start with the menopausal health, the menopausal health is an evolving practice in women. So 1 second.
Screen sharing our madam.
Yes, yes, sir.
Screen
Please,
sharing
sir.
our.
I'm doing, sir. 1 second.
Visible.
Sir, my screen is visible, sir.
Yes, ma'am. Yes, ma'am. Go ahead.
Yes, madam.
Wait 1 second, ma'am.
Now, sir?
No, ma'am.
It's not.
Try doing it 1 second.
Slides are not visible.
Click on share button now.
Yes, I'm.
Once you click on share button.
Yes, sir. Just 2 minutes. I'm doing.
శ్యామ్ గారు ఏదో చూడండి అది మేడం తో కోఆర్డినేట్ చేయండి.
లేదు సార్ 1 minute సార్ ఓపెన్ చేస్తున్నాను. Now, sir?
Yes, ma'am. Can yes.
My slides are hello. So
Yes, ma'am.
my
Go ahead.
slides yeah. So sorry for this, sir. So today the topic is menopausal health and evolving priorities in the women care, especially in Indian scenarios. So the average global age for menopause is around 51 years, but when coming to India, it's around 46.7 years. So there is a long-term postmenopausal lifespan in Indian women, which is leading for high risk for osteoporosis, cardiovascular disease, and all other. So coming to introduction, menopause is accompanied by physiological and psychological changes. With rising life expectancy, addressing the menopausal health has become a key focus in gynecological care. Now, the goal is to preserve the quality of life and to mitigate the long-term health risk through proactive and individualized care. So, menopause, there is a comprehensive shift towards a comprehensive healthcare than previous like general symptoms. The emerging focus areas are on HRT, hormone replacement therapy, mental health, cardiovascular risk, osteoporosis, and sexual health. So coming to the symptoms of menopause, there will be vasomotor symptoms, neuropsychological, cardiovascular, musculoskeletal, urogenital, and overall general symptoms. Vasomotor symptoms are hot flushes. There will be sudden feeling of warmth that spread all over the body, and most often intense part are face, neck, and chest. And night sweats, which are very terrible. The woman cannot able to sleep properly with the night perturbations and disrupted sleep patterns. And there is a difficulty in falling and staying asleep due to nocturnal symptoms. Genitourinary syndrome coming to, there will be, because of the decreased estrogen support and collagen in the tissues, there is vaginal dryness, vaginal itching and burning, dyspareunia, urinary frequency and urgency, and recurrent UTIs. Psychological and cognitive symptoms are, there will be memory lapses, difficulty in remembering things, especially short-term memory issues, increased anxiety and worriness, reduced concentration, and the cognitive clarity will be lost, and there will be mood swings like especially depression and irritability due to hormonal changes. Cardiovascular risk increased due to change in lipid profile, accelerated atherosclerosis, and high risk for coronary artery disease and stroke. This all due to the loss of the estrogen support because after menopause. And coming to musculoskeletal complaints, with the loss of support, there will be increased accelerated loss of bone density, leading to early onset osteoporosis, joint stiffness, aches, and increased fracture risk. Metabolic changes like weight gain, increased insulin resistance, and metabolic syndrome overall will be developing. Sexual functions are decreased libido, anorgasm, and fear of intimacy. Dermatological changes, there will be hair thinning and loss, dry skin, pigmentation changes, and nail brittleness. And long-term sequelae will be, there will be increased loss of risk for dementia, osteoporotic fractures will be increased, cardiovascular disease due to development of heart and vascular conditions, and potential increase for endometrial and breast cancers with unopposed estrogen therapy, and menopausal health treatments. So menopausal care has evolved from symptom focus to holistic, addressing physical, emotional, and cognitive care. Previously, the World Health Initiative initially reduced the hormonal therapy due to perceived risk, but later insight supports its benefit when started in the near menopause with personalized care. Evolving treatment approaches. So, hormone replacement therapy is the first line of treatment. The modern gynecological personalizes menopausal hormone therapy guided by the timing of hypothesis to optimize the benefits and minimizes the risk. And the lifestyle and complementary approaches. Modern gynecological care include lifestyle and complementary therapies like behavior therapy, using multimodal approaches and multi-team approach. We have to take the support from the other supportive departments to reduce the risk and to reduce the long-term factors. Non-hormonal alternatives, the women who are not willing to take hormonal therapy, there are recent non-hormonal alternatives which like serotonin receptor inhibitors, SNRIs, osmiferin, and non-pharmacological options. So hormonal therapy, hormone replacement therapy. The modern protocols emphasize individualized therapy and patient dedication, moving away from one-size-fit-all approaches. The healthy symptomatic women under the age of 60 and within the 10 years of menopause onset are the most beneficial women for the hormone replacement therapy. NAMS 2022 guidelines personalizes the plan. That is, we have to take the history of the woman and then we have to decide for the hormone replacement therapy and how long to be given. Timing and eligibility. If the woman age is less than 60 years and the menopause has not crossed more than 10 years, they are the best women to give the HRT without the risk factors and long-term effects. And the route and dose, it's better to give transdermal patches and vaginal rings than prolonged oral tablets. Duration and continuation based on the patient condition, like woman condition, and the complications are risk factors she is having, and safety and quality. 2023 FDA approved the first non-hormonal medication fezolinetant for the hot flushes. It's an NK3 receptor antagonist targeted at the thermoregulatory pathways in the brain. So the hormone replacement therapy current perspectives are its effectiveness, most effective for vasomotor symptoms and genitourinary symptoms. Risk benefit profile, if it started early, that is within 10 years of the menopause and the woman ages should be less than 60 years. And the approach should be an individualized therapy and regular reassessment is mandatory for the continuation of HRT. And timing, as I said, route and dose, transdermal estrogen and micronized progesterone if the uterus is intact. And duration, no mandatory cutoff at 65. If the benefit persists, the woman is having still complaint, it can be HRT can be continued even after the age of 65 years. Non-hormonal options, as I said, fezolinetant, it's an NK3 receptor antagonist, very effective for the hot flushes, and alternatives are SSRIs, SNRIs, and gabapentin, clonidine based on the patient complaints. Expanding options, still there is a lot of growing toolkit beyond the traditional HRTs, which are still in the research. So vasomotor symptoms, mainly we have to focus for the lifestyle. That is, we have to avoid the triggering factors. First line is low dose systemic HRT should be given. If the woman is having uterus, estrogen and progesterone should be given, or if she is hysterectomized, only estrogen is sufficient. And others are non-hormonal and sleep hygiene. She has to take the behavioral therapy for the proper sleep, and if required, melatonin has to be added. Cardiovascular is the risk and menopause. It is the leading cause of death postmenopausal due to CV diseases. Critical period is menopause transition. There will be increased cardiovascular risk, acceleration risk, and early menopause increases the CV risk significantly. So we have to search for the female specific factors, and the risk stratification should be done. Like whether she had premature menopause, or during pregnancy she had any PIH, like pregnancy induced hypertension or diabetes, or post pregnancy or pre-pregnancy, any risk factors for pregnancy, we have to take the proper history. And screening, menopause, we have to take it as an opportunity to do proactive screening, and any interventions needed we can start immediately. And we should focus for the lifestyle and strongly emphasize for the maintaining healthy lifestyle. And coming to metabolic changes, we have to train the women for the not to increase the weight gain, and to maintain dietary approach, regular exercises, medications if required, like metformin for insulin resistance or in pre-diabetic cases. And the screening should be done regularly for metabolic syndrome and hypertensive risk, we have to screen. Coming to osteoporosis, there is the proactive management strategies are Indian Menopause Society guidelines has combined with slogan like fit at 40, strong at 60, and independent in 80 to raise the public awareness. With the menopause, there is a rapid bone loss and significant fracture risk. So there is a universal screening advised, and in India, within 5 years of post-menopause, we have to use the screening like BMD, bone mineral density, and FRAX, which estimates the 10-year fracture probability risk to identify those who are need for interventions. And the lifestyle changes, we have to add calcium and vitamin D with proper exercise and diet control. So for the joint pain and osteoporosis, we have to supplement with calcium and vitamin D3, regular exercise, especially weight-bearing exercise, medications if required, bisphosphonates, and HRT if beneficial, if there is associated vasomotor symptoms only. And advanced options are denosumab and teriparatide in high risk for intolerance cases. So to summarize, the hormonal therapy like HRT is effective if started early. Anti-bone resorptive drugs like bisphosphonate and denosumab is the first line usually used, and anabolic agents like terapeptide and romosozumab protein fracture reduction drugs can be added. But this all should be added only after taking the orthopedic team support and screening the woman. And coming to mental health and menopause, there is recently an increased recognition for the mental health or the depression or the mental instability of the menopausal woman. So we have to screen all the women postmenopausal for any like mental screening should be done, and integrated care along with the mental health providers. We have to take the support and we have to screen the woman. If needed, we have to support her with the psychological uh, cognitive symptoms like cognitive behavior therapy, and if needed, antidepressants like SSRIs and SNRIs should be added. HRT may help if the early transition period we identify and we started, and we have to give the mental stimulation exercise and sleep optimization therapies we have to give. Clinical guidance for perimenopausal depression. First ever guidelines by NAMS and NNCD collaboration gives that recommended systematic depression screening should be done, and the treatment approaches like psychotherapy, drugs when needed, anti-anxiety, adjuvant hormonal therapy for symptomatic women who have associated symptoms. And genitourinary syndrome, the vaginal dryness, dyspareunia, and recurrent UTIs are most frequently noticed. For that, along with the systematic therapy like HRT, we can add topical estrogen therapy. It can be estrogen cream, ring, or tablet. Non-hormone options like lubricants and moisturizers can be given. Other therapies like vaginal DHEA, osmifer, that is selective estrogen receptor modulator, can be given vaginally. And recurrent UTIs, consider the vaginal estrogen with UTI prophylaxis. So the first line of approach is along with systematic estrogen, we have to give low dose vaginal estrogen followed by vaginal DHEA, osmiferin, and moisturizers or lubricant when there is excessive dryness and itching. But energy-based therapies are not yet proven, and like lasers and radio frequency devices due to limited evidence on and safety concerns. But nowadays there is lot of research is being going on for the vaginal dryness and itching for the radio frequency and lasers. With the team like dermatological supports, we can try in selective cases. Sexual health. When coming to the sexual health, a less discussed topic among Indian society, we have to give importance to the quality of life also. And unreported symptoms are widespread, and unreported vaginal and urinary symptoms are lot. Now, recent guidelines have advocated proactive screening and open communications. So coming to the approach, for the loss of libido and anorgasm, there should be psychosexual counseling for the patient and along with her partner, local estrogen therapy, medications if required, and to first we have to rule out the comorbidities like thyroid, depression, medication side effects we have to check. Dermatological cases, we have to take for the skincare, emollients and cream-based moisturizers, hair treatment like topical minoxidil, medical evaluation for thyroid and other metabolic syndromes, and nutritional support like biotin, iron, zinc if deficit. We have to check for the long-term sequelae like fractures, dementia, and cancers. For bone screening, we have to check for the DEXA scan once in 5 years, and cognitive encourage for cognitive activities and vascular risk control. Individualized HRT. Once the HRT has been started, we have to reassess the woman's general health condition and risk for the cancer and complications at least once in a year. And cancer screening like regular mammography, pap smear, and pelvic examination should be done without missing. Safety, there is a reduced risk when used for low doses and transdermal routes, which reduces the vascular thromboembolism and stroke events. Short and combined therapy will reduces the breast cancer risk and avoid unregulated compounded bioidenticals. So coming to the challenges and barriers in the menopausal care, there is a still gap, knowledge gap and educational need which we have to give to the women coming to the clinics, and access to the specialized care. We have to take limited Access to specialized menopausal care is limited, especially in underserved areas due to uneven clinic distribution and systematic barriers like time and reimbursement constraints. Cultural and socioeconomic factors influences menopausal experience and access to care, promoting gynecologists to prioritize culturally competent and individualized approaches. Coming to the conclusion, the menopausal care now we have to take a comprehensive approach, and we have to emphasize on early screening, individualized HRT, mental health integration, cardiovascular event prevention, bone health, and sexually well-being. The future directions are the patient education, destigmatization, and ongoing research is still needed for the healthy woman to stay healthy for her rest of the life post-menopausal. Thank you.
Thank you, madam. Thank you, madam.
Thank you, sir.
Presentation.
Thank you very much, Ashok.
Thank you, sir. Thank you, Ashok, sir. Thank you, Rahul, sir, for coordinating. Thank you, sir.
Thank you, madam. Sir, Shyam Nara. Shyam, sir. Hello.
Shyam garu unnara? Line lo unnara?
Shyam. Hello. Shyam garu. Hello, Shyam garu.
Ashok sir లేరు.
Shyam garu.
శ్యామ్ గారు లైన్ లో లేరు.
శ్యామ్ గారు లైన్ లో ఉన్నారా? నేను ఫోన్ చేస్తాను. గణేష్ చేస్తాను. శ్యామ్ గారు మీరు లైన్ లోకి వచ్చేస్తే మీ బోర్డ్ ఆఫ్ సైన్స్ చెప్పేసి మేము కూడా వెళ్ళిపోతాం. అయిపోయింది. రైట్. ఓకే శ్యామ్ గారు, we thank video tech team, especially Madan Garu and especially Shyam. They were being cooperating and being working with us for the past 1 month. And you have done an excellent job, sir. There are no complaints from the delegates also while joining, and also the network was very good, of high quality.
Thank
There
you,
were
sir.
no complaints of dropping out the bandwidth. And we once thank Shyam Garu. Shyam Garu,
Thank you, sir.
on behalf of our Indian Medical Association, we thank Madan, you, and other team members. Thank you. Now there is a vote of thanks by our Secretary Rahul Babu. Then we'll close the
100%. Thank you.
Yeah. Thank you, all the delegates who have participated and enrolled for this CME, and you made it a grand success by continuously keeping online. Thank you, all the speakers who have presented their wonderful presentations. Thank you, all the technical team. Thank you, IMA Nellore. Thank you all of you.